Good morning, everyone, and greetings from Mahamana Pandit Madan Mohan Malviya Cancer Center. We are pleased to have you all with us for the first Mahamana Thyroid Cancer Update, and this has been organized post the release of the Indian Thyroid Guidelines. Good morning, everyone, and greetings from Mahamana Pandit Madan Mohan Malviya Cancer Center. We are pleased to. So, without causing any delay, I would like to invite Dr. Jyoti Dabolkar. So, without any further delay, I would like to invite Dr. Jyoti Dabolkar. She is the president of the ISTS and the senior head neck consultant, and she'll be giving the inaugural address for the Mahamana Thyroid Cancer Update.
Okay. So now I can speak. I'm heard. Hello?
Yeah, we can hear you, ma'am.
Yes, ma'am, you are.
Yeah, so my slide should be projected, no?
No.
My slide you project from there, no?
Do you want me to do that?
Yeah, I heard it all, but Abhishek, if you can do it, it will be lovely.
Okay, ma'am.
I had asked Asim to do it because I thought probably we don't want any hitch.
Okay.
Like in that first
we are doing it. We are doing it, ma'am.
All right. But the screen is not in the center. That is my problem. The screen, your screen should be in the center. So maybe you have to change the camera angle.
Ma'am, that camera I think is only for the local speaker there. That should be
Okay.
fine.
So what do I do? Chalo. Start karo. Okay. So make it full screen, Abhishek. Yeah. So greetings from Indian Society of Thyroid Cancer. And I really appreciate what Asim at such a young age is doing for head and neck fraternity, that he's taking immense effort to have these webinars, lectures very periodically. Asim, I really want to thank you from the bottom of my heart. I'm really pleased to speak here. Next. Can I move? Abhishek? So the incidence of thyroid nodule disease is on rise globally, which we all appreciate. And this epidemic is not only in the West, but it also in the low and the middle income countries, in which India is included. The thyroid nodular disease is about 12% prevalence, and the National Cancer Registry Program predicts that 1 in 752 Indian males and 1 in 285 Indian females will develop Indian thyroid cancer in the lifetime. So, Abhishek.
Yes, ma'am. I think it's done by their end, madam. They are, yeah.
So should I do it myself? Anyway, I finished this slide. Okay. India has a unique healthcare landscape with the urban and the rural divide, and available evidence and the recommendations need to be adapted to the Indian scenario. Next. So there are many guidelines around which we all know, the ATA, the BTA, the Korean, the European, and they are very well researched and very comprehensive guidelines which already exist. Hello, next. So, but which we all agree that one size fits all is never appropriate situation. And that's why we as India, as I mentioned, we have a different situation, different scenario, different healthcare issues, and we should have our own guideline. So the issues here is a limited resource, inadequate access to the healthcare for everyone in India, delayed presentation of the cases, polarization of the healthcare resources, and about 50 to 75% of the Indians pay for the cancer care out of their pockets, not like America where the insurance company pays for the patient treatment. And that's why the modern advances like molecular markers, the targeted therapy, and the robotic surgery may not be available in India, and it is inaccessible to many in the rural. So the diversity and the disparity of the infrastructure and expertise and training is concerned, which is absolutely the cause. But even the philosophy of the different institute make it a very challenging situation. Next. So the ISTS was founded in 2016 with the founding member having envisaged that there should be a guideline which would best suited for Indian situations and scenarios and guide Indian surgeons in a diverse setting and presentation to treat this cancer appropriately. The successful national meetings and the GBMs have reinforced this vision and had a full support of the EC and the GBM. When I took over last year in 2023, I envisaged that I will have to do this, and we had a basic concept like identifying the best guidelines and the evidence, the amalgamate with the evidence from India, and blend and adapt to the Indian scenario. Next. So you are going backwards. So such an effort was never done before. So we had a very, very limited experience. This was one of the major challenge. Next. Limited Indian data. But I must say in the first case that we had such a brilliant doctors and surgeons who really showed up their might, and we took up this challenge for the first time in the country and probably in Asia, and we could put this document in a very short time. The limited Indian data poses another challenge. The diverse infrastructure expertise, which should have a common minimum standard applicable to majority of the patients and scenario was our aim, and cutting edge topics such as molecular testing and robotic surgery, we advised only with a due consideration or we left them out completely. So the compilation had to be thorough and based on the best available evidence, which has to be again timely and relevant. This could have taken ages to complete, but we completed in 6 months of time. We really pushed our boundaries and limits and energy to finish on time, and it has to be a relevant document. And a perfect guideline formulation procedure would have been, which has to be a time bound and also resource would have been a time bound and resource consuming effort. If we would have waited for a perfect guideline formulation. So we had used the flexibility and the innovation, which next. So what does it take as a systemic approach to these guidelines? So the identify and the define the subject area, convene and run a guideline development group, which is called task force, identify the evidence and assess it on the basis of systemic reviews, translating evidence into clinical practice guidelines and with grades of recommendations, and then internal as well as the external review of the guidelines and periodic update of this guideline. Well, we'll go one by one. First, next slide. Did we identify? And no, only one. Did we identify and refine the subject area? Yes. Did we convene and run a guideline development group? Yes. We made a task force comprising of the different parts of the country with people with a fairly good knowledge and experience were on the task force. Did we identify the evidence and assess it on the basis of systemic reviews? We did identify the evidence, but systemic review was not possible because of the time, and also I'll tell you in detail about it later. Did we translate the evidence into the clinical practice guidelines with the grades of recommendation? Guidelines were formed. The evidence was translated into guidelines and guidelines were formed, but the grades of recommendations were not given. And that is again the time bound, and also we did not have even, we have not searched for even evidence in India, which we are planning to do in the next revision of these guidelines. The internal review was done by the 3 eminent thyroid surgeons of the country, and the external review of the guidelines was also done by Dr. JPS. So if you see the systemic review and the recommendation of the grades, because of the lack of enough evidence, which we have not searched or not been able to produce, made us that we systemic review and recommendation grades we could not do as it is indicated in this systemic approach. Next. So the guidelines also has literature searching and retrieval, then epidemiology, biostatistics, ability to do the systemic reviews, as I mentioned, health services research, then clinical experts, the group process of experts, and then writing and editing these guidelines. So next, the epidemiology, biostatistics, ability to do a systemic review, and health services research, we couldn't do it because basically time sensitive issues, and it could have taken a very long time to incorporate all these and then make a guidelines. So we omitted this 4, the rest all was included. Next. So to need to find a via media, so there are 2 via medias. One is a consensus guidelines, which when available, evidence is scarce or low quality, then expert group is convened who develop the consensus. So as you know, the thyroid cancer is a very well-behaved cancer. It has a very long survival, and it is relatively less common, makes us that there will never be level 1 evidence in this cancer. So the evidence will always be less than level 1 or maybe level 2. So whatever evidence is available, however low, should be taken into consideration, and consensus guidelines should be formed. Now, the other via media was a narrative review, which provides a flexible and rigorous approach to analyzing and interpreting the literature. So although process not well defined, these often gives practice guidelines based on flexible approach to conduct a rich, meaningful, and practical review of the literature. So if you can say that we have used both these flexible combination of both these techniques, that is consensus guidelines and narrative reviews, which we have incorporated into these guidelines. Next. Somehow I'm giving some problem. Are this author who would contribute? So we decided which topic. So it was a thyroid cancer. The author who could contribute to each subtopic which were identified. Authors began with a narrative review of the individual topics. We decided about 11 chapters in thyroid. They refer to the international guidelines like ATA, NCCN, BTA, ETA, AHNS, and also relevant international literature. Then Google and PubMed search for the Indian literature pertaining to these topics was done and was classified according to the level of evidence. And regular online meetings were conducted, and consensus was developed based on the available literature, which literally we started off in October, and from October onwards, I think we met every week for more than 1.5 hours, And the authors internally also reviewed each other's topics and chapters to be more precise. And then pertinent clinical questions which were identified and consensus guidelines was given as answers to this. Now we also added flowchart at the end of every chapter, reiterating the points which are we wanted to highlight to the speaker, to the user. Next. An external review was done, as I mentioned, by Dr. Jatin Pisha, and all the chapters were independently reviewed by 3 Indian authors, Dr. Anil Dikruz, Dr. Deepak Sarin, and Dr. Venkat Rangachari for the radioactive iodine chapters. So I personally feel that we could complete this with all the printing and editing part, and we could come out with the guidelines in the solid form, which was released by none other than Dr. Jatin Shah as the recently concluded Head and Neck Summit at Chennai. And it was really a pleasure that he himself really congratulated the effort, because it is for the first time that the country is having such a document. And I personally was very, very fortunate to get it released by my mentor with whom I trained in 85-86. Next. So the authors to this are all this very, very eminent surgeons, and I really appreciate and want to thank each one of them to literally contribute in spite of their busy schedule and clinical practice. They all abide by the meeting timings and contributions, and I really, really is convinced what Narendra Modi says, that made in India, and we can do it if there is a group, if we can do it where there is a team, if we have a good leader, if we have so many unmet needs of our country in scientific arena can be met. And this is a real example that we could achieve this in a very short time. Next. Do these guidelines give a unique side to the India? Your question could be that, does it different than the other guidelines? And I would say yes. The 2 topics which are already covered with the risk stratification and medullary carcinoma by my authors and not the today's authors. So I will not go into their arena, but this risk stratification was covered by Mitali few days ago. And you can say in the second line that ATA guidelines, and third column is a ISTS guideline. If you see the second paragraph, where there is a consider the serum thyroglobulin was given in ATA guidelines, which we in ISTS guidelines said that serum thyroglobulin, we don't need to routinely do it as a list of for a tool for post-operative assessment, because this was to downplay the role of serum thyroglobulin in a less than total thyroidectomy, considering the concurrent occurrence of thyroiditis, which could falsely raise the TGL, and also to emphasize that the structural incomplete response, which you will pick up on a USG, has more weightage for considering intervention in those with the initial low-risk patients. So we really have changed as per our Indian settings. Coming to the medullary carcinoma, which was written by Anuja. Next slide. Which was written by Anuja, and she just covered yesterday or day before yesterday. And even in that, if you see the first column, what is the choice of investigation? And the ATA guideline says that neither FDG PET nor F-DOPA PET is recommended as an investigation of choice. But we, even though in India, we said that FDG PET or 18F-DOPA PET is a preferred investigation with a high calcitonin, because high calcitonin running in thousands, there can be a distant mets into the bone, into the lung, and that can be picked up if you do the PET CT in the first go with a high calcitonin. So we really change, because FDG PET is available in most of the country, affordable, because if you can detect the distant metastasis early, patient is in a better shape to be treated, even with the newer adjuvant targeted therapies, which will change the whole outcome of the patients. So I really can say that we have changed as per our availability of the resources, the investigation, the the indication of like how it will help the patient, and we really have tailored all the recommendation as per the evidence, and also how useful they are to our patients. Next page, next slide. So next slide. So with these, I want to reiterate, or I want to recapitulate that it was to blend the international evidence to the Indian data and scenario, to encourage the uniform treatment strategy by these guidelines, to educate clinicians to make appropriate referral if they are not going to treat the thyroid cancer when necessary, to encourage those treating thyroid cancer surgeons to acquaint themselves with literature and also understand the process of good clinical practice. I did my way is not the clear ethos one should have. What is done in the majority of the country, or what is done in a majority of the world? That should be your aim. And these guidelines will definitely help you go in that direction, and to stimulate further literature and research in issues pertaining to our country. So we invite you to explore these guidelines with the expectations that you will come back to us with your suggestions, criticisms, and also help us to revise these guidelines, which we are intending in a very short time once the ATA guidelines come out. And we promise you that we are going to insert level of evidence or level of recommendation once we work on the evidence from the literature very shortly, I would say. Maybe in a year, we will come out with the revised guidelines with whatever lacunae and the deficiency which you will see in this, like review of literature and the level of evidence we couldn't insert with a shortage of time. And that is why we promise, next slide, we promise that we will be soon out with this. We acknowledge that this systemic review process was not done and strength of recommendation was given, and it's a dynamic field, and newer evidence will emerge, and we will incorporate them in a very, very short future. So with this, I want to invite you, come and join us next. Come and join us in this endeavor. Give your suggestions, give your inputs, give your help to make it better. And also that you come and join us, next slide, to become a member of this vibrant Indian Thyroid Society. The membership is just a click away. And also I invite you to a very magnificent conference organized by the Calcutta group. Harsh Dhar is a secretary, and Saurav Gupta as a chairman, and also TMC Calcutta group on 7th to 9th of June, to be held at Calcutta, and with a live surgery demonstration, robotic surgery demonstration, with a cadaveric dissection on one day and 1.5 days of a very, very extensive and exciting scientific program put up by all of us. I invite you genuinely to come to enjoy the academic feast and the gastronomic feast of Bengal. Thank you very much for your patient listening. Asim? Asim?
Thank you so much. That was a great briefing of the Indian Thyroid Guidelines. And before we proceed to the next talk, I would like, if anybody has any comments on what Dr. Jyoti Dabholkar just mentioned about the future and the presence of the Indian Thyroid Guidelines. Komal, please.
Good afternoon, everyone. So after that introduction by Dr. Jyoti Dabholkar ma'am, now we'll move on to our first session. The first session is chaired by Dr. Pankaj Chaturvedi. Sir will be giving a talk on epidemiology of thyroid cancer, rising incidence of thyroid cancer in India. Is it really a concern? I would like to introduce Dr. Pankaj Chaturvedi. However, he doesn't need any introduction. Sir is Professor of Head Neck Surgery at Tata Memorial Hospital, Mumbai, and Sir is Deputy Director of Center for Cancer Epidemiology, Mumbai. Sir is the visionary and a father figure for this institute, and without his efforts, even we as an institute, as this department, would not be able to do much. Welcome, sir. And I would also like to introduce, welcome, sir. Sir, are you there?
Yeah, I'm here. Thank you, Komal.
And I would also like to introduce the session experts for this session. That is Dr. Saurav Datta. Sir is Director Oncology, Medica Super Speciality Hospital, Kolkata. Welcome, sir.
Thank you, Kamal.
And the second session expert is Dr. Poonam Joshi. Madam is Professor Head Neck Surgery at ACTREC, Navi Mumbai. Welcome, ma'am.
Yeah, thank you, Komal. Thank you so much.
So over to Pankaj, sir.
So, thank you, Komal and Saurav and Poonam. With your permission, let me start the first session. So, basically, the topic assigned to me is epidemiology of thyroid cancer and whether it is really a matter of cancer concern. So, let me start by this that if you look at this picture, this is the picture on the left hand side. You see the age standardized rates in males, and on the right, you see the age standardized rates in females, all ages. So, the first impression that one would get by looking at these pictures is that thyroid cancer is more of a disease of the high developmental index or high and middle income countries. And that's a correct interpretation of the image that you see. And what is more important is that it is more common in females. It is at least 2 times more common in females. And the disease where it is very common is USA, China, Australia, Republic of Korea, and Saudi Arabia. If you look at the mortality, again, you would see that the high income countries where thyroid cancer is detected most, they do not have the high mortality. But in countries where the disease may not have high burden, but still it is there, the mortality is more common. The reason is that most of the cancers, and we'll be discussing about it, those are detected in the Western world or high and middle income countries are indolent, and those in the low and middle income countries, mostly in the income countries, they are more likely to be true thyroid cancer, and therefore the mortality is higher. And certainly the mortality is higher in males compared to females. Now, this is a very interesting paper that looked at projection of thyroid cancer by 2040. And here, if you look at, then you will be very concerned that actually the thyroid cancer is going to increase in days to come, and most of this increase will be coming in Asia. And look at these numbers here. Currently in 2020, if it was 586,000, it is going to become 761,000. And this increase is almost 29.9% increase. And in female, the increase is less compared to those in males. And mortality, if you look at, it is much higher and going to be that almost 67% increase in the mortality. Now, this is true reflection of what is going to happen overall with regards to cancer burden. So, even in 2040, other cancers are going to increase. So, the study summarized that it is already the 10th most common cancer. So, if you look at the world scenario, it is the 10th most common cancer. It is more common in females, and estimated number of thyroid cancer is going to increase from 29.9% by 29.9% between 20 and 2040. Now, that is what I was telling, that if you look at the continent-wise increase in thyroid cancer, then the majority of the increase in is going to come from Asia, that is 77.8%, followed by Latin America, which is almost 81 point, and then we also have in Africa, there is going to be a 100% increase. The reason is that in these countries, currently, the baseline numbers are small. With the rising affluence, accessible and affordable healthcare, perhaps the detection will be higher, and that is why most of the rise that will happen in 2040 will come from the low and middle income countries. And here, if you see this diagram, it very nicely shows that what is the current burden, and in the current burden, how many are males, females, and the overall burden of thyroid cancer. So here, again, the summary is that the incidence of thyroid cancer is going to rise by 26.6%, and most of this is coming from Asian countries. Now, while we are talking about this entire thing, we must be conscious of the uh, risk factors, that why these risk factors are there. And if you look at the common risk factors, it can be classified into high risk. Uh, then we can also classify them into low risk and unclear. So the high risk are radiation exposure, that is very known to most of the students. And then there are chromosomal alterations which make a person very high risk. And this high risk can be classified into three categories: hereditary medullary thyroid carcinoma, then non-syndromic medullary carcinoma, and then, of course, we have the syndromic familial carcinoma. And amongst the low risk, we have the thyroid imaging, then iodine deficiency, high TSH level, autoimmunity, and then presence of thyroid nodules, environmental pollutants, lifestyle and diet, and high BMI. Apart from these, the role of estrogen is unclear. Now, when we talk of the hereditary conditions, more than 90% are sporadic in nature and due to some somatic genetic alterations. And of the hereditary, majority would be again papillary thyroid carcinoma. Follicular carcinoma is number 2, followed by the anaplastic thyroid carcinoma, and the last is the Hurthal cell carcinoma. Now, these are the chromosomal genetic alterations which I'm sharing in a very basic uh, format. So the bottom line is activation of the mitogen activated protein kinase, that is the MAP kinase, and PI3K AKT signaling pathway. For papillary carcinoma of thyroid, it is a recombinant event and it is the point mutation. For follicular carcinoma, it is a mutated RAS oncogene pathway with fusion and expression caused by the translocation. So this is for the papillary carcinoma, and on the right you see for the follicular carcinoma. And for medullary carcinoma, we must understand that majority of the medullary carcinoma are again they are sporadic, and a small proportion, around 20%, are hereditary. And only 50% of the sporadic medullary thyroid carcinoma have somatic RET mutations, and nearly all cases of FMTC MEN2A, MEN2B have germline mutations in the RET proto-oncogene. And the familial form of medullary thyroid carcinoma is present in 20 to 25%. And in those, we have the RET mutations, and these RET mutations are on chromosome 10q. Now, radiation exposure is something that has been studied very, very extensively as the cause of um, papillary carcinoma and or well-differentiated carcinoma. And this happens because of the DNA strand breaks and somatic mutation. This leads to carcinogenesis. And one of the most studied place for this radiation exposure is the Chernobyl accident site. And there, most early cases were well-differentiated papillary carcinoma with red PTC3 rearrangements. But later on, most studies are showing red PTC1 rearrangements, and this is something which is to be understood what happens in the radiation exposure leading to cancer. But something that came very, very interesting, one scientist from the Princeton University who was an evolution biologist, they found that the wolves of the Chernobyl who were exposed to radiation during the Chernobyl accident, they have developed a pathway to completely bypass the whole carcinogenesis, and they have developed resistance to cancer. So this is something that is very, very interesting. And I thought on one side, we are saying that it leads to papillary carcinoma of the thyroid. On the other side, perhaps the low dose radiation exposure may lead to resistance to cancer. And this is one area that is worth the future research. Now, if you talk about the India, and that is the topic that has been assigned to me, that what is happening with regards to thyroid cancer burden in India. So this is a study that came from Sevagram Vardha, and look at what is happening in a typical medical college. Of all the thyroid cancers, thyroid disorders that visit a medical college, the commonest cause for thyroid disorder for visit to the hospital is goiter, followed, this is the colloid goiter, then multinodular goiter, and papillary carcinoma, almost a small percentage, 39% where the papillary carcinoma. Now, these are the colloid goiters or multinodular goiters for which, or even for solitary thyroid nodule, when we do surgery, incidentally we find a thyroid cancer, and that increases the whole I would say statistically, it increases the number of thyroid cancer detected in the population. So in this study, papillary carcinoma comprised 23.7% of all cases, and 9.2% were follicular carcinoma. And of course, thyroid carcinoma was more common in females than males. Now, if you look at the trends in the thyroid cancer in India, now, this trend is very clear that there is an increase in the number of thyroid cancer reported in India, and it is same as what is happening worldwide, and it is coming mainly from the young and middle-aged women. This increase. So this study actually looked at the entire burden, and over the decade, they found that in women, the increase of the thyroid cancer was from 2.4% to 3.9. Not percentage, it's the age standardized rate. From 2.4, it went to 3.9. In men, it increased from zero point 0.9 to 1.3. And if you look at a relative increase of 62% and 48% respectively. Now, if you classify them into different age groups, then you will realize that the maximum increase in happening in the age group of less than 30 or 30 to 44. So the greatest relative increase in thyroid cancer incidence in men was in age group less than 45, and in all in the women, if you see, it was less than, again, less than 45 years of age. So this study concluded that the incidence of thyroid cancer is rapidly increasing in India, particularly amongst the younger population. And it postulated that such a dramatic rise in incidence of thyroid cancer can be only attributed to overdiagnosis. So now let us discuss about the overdiagnosis. And this is a study which was titled as Thyroid Cancer Incidence in India between 2016 and 14. And they studied the impact of overdiagnosis. So in this study, they looked at the entire different registries that in India we have in different parts of India, population-based cancer registry. So this 14 Indian cancer registries were analyzed, and what they found, that this is the column that you should concentrate. This shows that what is the percentage increase between 2006, 2008, then 2009, 2011, 2012, and 2014. So this percentage increase is reflected in this column for the women, and this is for the men. So if you look at the bottom, then 37% increase is going to happen, has happened between 2006 and 2014, and in the men from 1 to this number is around 27%. So 37% for the women and 27% for the men. So now let us study it further. So they did the mathematical modeling, and they converted this entire cohort into three different area, no, time cohorts. So these 3 time cohorts, 2006, 2008, 2009, 2011, 2012, and 2014, and they observed the changes in the age-specific incidence rate of thyroid cancer between this period. So if you look at the graph here for the men, so in men, the age-specific rates showed an exponential growth consistent with the multi-stage model of carcinogenesis in all 3 periods. And this suggested there was a negligible impact of overdiagnosis. So this is as per the projection between the 3 age cohorts, there is no surprise finding. Now, in the women, if you see, the age-specific incidence rates in women increased progressively from 2006, which is the light yellow, to the dark maroon color. This showed that there is a historical pattern of exponential growth, and this perhaps could be contributed because of the overdiagnosis. So in men, there is no change, but in the women, certainly there is an element of increase in the incidence or increase in the burden of the thyroid cancer. Now, then they looked at different cancer registry and plotted the graph for each cancer registry. And what they observed was the highest proportion of the case attributable to overdiagnosis was found in Trivandrum. And in most of the other Indian cancer registry, the good news is that the corresponding fraction was intermediate. And whereas little or no evidence of departure from the expected space-specific incidence was in Bhopal, Dibrugarh, Kamrup, and Sikkim. And this is the whole picture which shows as per the age group and as per the period. And here, if you see the age group between 0 to 34, female population is this 19.4%, and the attributable to overdiagnosis 74%. For this group, it is 50%, and for the 55 to 64 is 30%. So that means in all the thyroid cancers diagnosed between 0 to 34, the attributable to diagnosis is the highest. And here they calculated for the entire country. Overall, 51% of the women diagnosed in all India crude rates between 2006 and 2014 were likely the result of overdiagnosis. In women, the fraction of overdiagnosis thyroid cancer was particularly high between 35 years, below the age of 35 years, and 50% at the age 35 to 54 years. And estimation of the overall diagnosis showed a small variation across the study period. 49% between 2006 and 2008, and 54% between 2009 and 2011. And that is why the whole concept of active surveillance came in, that we are talking about indolent cancer, we are talking about the overdiagnosis. So this is the whole cartoon which shows, or the table that shows that what are the ideal candidates for the observation or active surveillance. And this is like older patients, accepting a patient who accepts it, reliable and compliant for follow-up. There are significant comorbidity, solitary, 2 centimeter, no evidence of extrathyroidal. So all these are the ideal situation for active surveillance. Now, when we talk about the overdiagnosis, there are two components to it. One is at the macro level and another is at the micro level. Now, what is the macro level cause of overdiagnosis? The first is that there is a widespread use of ultrasound in the local clinics. Like people, sometimes surgeons are doing themselves or they are sending the patients to the clinic, and there for any thyroid enlargement or sometimes for just checkup, people can do ultrasound. And there are hospitals and clinicians who encourage routine health checkups. And this in routine health checkup, sometimes if somebody in the family had thyroid cancer, or somebody had the thyroid disease in the family, or somebody is very scared by reading about the increasing burden of thyroid cancer, they opt for even the thyroid cancer screening, though there is no evidence for that. Now, when you do that, you might find some incidental nodule, you may put a needle, and then you get some Bethesda 2, 3, and the whole cycle of workup and anxiety and perhaps surgery is started. At the micro level, what happens that when we do surgery for thyroid or goiter or whatever, there when we do sectioning, we tend to find and we find thyroid cancer, and that again triggers the whole pathway of further treatment and anxiety in the patient. Now, if you look at the Cancer Registry 2020 report, the National Cancer Registry report of India, it shows in the females, thyroid cancer is there amongst top six, rather top 10 cancer, but overall ranking is the sixth. And this thyroid cancer was second most common in the cancer history of Trivandrum and Kollam in Kerala. Both are in Kerala. The incidence rate of thyroid cancer amongst women is increasing, and it is most common in these two districts. And the high burden of thyroid cancer Kerala could be due to overdiagnosis, because within the country, that is again a high income state and a state where affordable healthcare is there, accessible healthcare is there, and people are very educated. If you look at the males, then in males, still we do not have thyroid cancer coming in the top 10 cancers. Now, this is a very, very interesting table that you should see, that thyroid cancer amongst all cancers in the human, what has been reported in the population-based cancer registry as part of the National Cancer Registry program, 3.6% are attributable to thyroid cancer in females. Now, if you look at the male, female, and both sexes, in the males, this is the total number of thyroid cancer reported, and the lifetime risk, cumulative risk, is 1 in 758. So in India, the cumulative risk is 1 in 758, and in the women, it is 1 in 416. So this is the schema which shows that what is the proportion of thyroid cancer against the background of the total cancer burden in India. Now, what is disturbing and what is that something that we have to keep it in mind? This is the study that was done in the Korea. The mean nodule size for the country is 1.5 centimeter. And if you look at between 2000 and 2012, most of the thyroid cancer detection, if you look at the urban females, urban males, rural males, most of there is a explosive increase in the urban females. And next is the rural females. So most of it is coming from the females, number one. Number two, it is coming mainly from the urban area. And if that is so, then it is a clear indication that something is happening in urban area, and that is typically the sonography that was done for screening of the thyroid was responsible for it. And this is the trend that shows between 2000 and 2013, the nodules which are more than 1 centimeter, the numbers are decreasing, and the nodules which are less than 1 centimeter, their number is decreasing and increasing. So less than 1 centimeter is increasing, more than 1 centimeter is decreasing, and overall cancer burden, if you see, is increasing for males and females. Now, this was a very, very important study, and most of you may have read it, that is it really justified to screen and treat? So this study showed that most common histology was 94.9% was papillary carcinoma. And the screen detected cancer, like some people come to you, walk to you with the palpable or visible thyroid nodule, but screen detected tumors increased from 15% to 56% between 1999 and 2008. And screen detected tumors are significantly smaller than the clinically detected, and nearly 95% of them were less than 2 centimeter, and size of the tumor steadily decreased from 18 millimeter to 8 millimeter. And the 5-year survival for this population was more than 100%. So you can imagine that those who have got cancer in this population, actually they have lower risk of dying than the general population. And that led to the whole concept of NIFT-P, because once you label somebody as a thyroid carcinoma, then again the anxiety is there. There are people who are ready to treat, and then whole concept of total thyroidectomy, hemithyroidectomy, central compartment comes into play. There is a morbidity associated with this. There is a cost associated with this, and that is why the whole concept of NIFT-P came. And the ATA recommendations says that patients with low risk, these are the patients who have low risk of recurrence within the differentiated thyroid carcinoma. And there is an element of observation alone which can be done for these patients because of the low risk of recurrence that they're there. We did our own study and we looked at the population level outcome of early thyroid cancer. And in this, we studied 28,261 thyroid cancer between 1975 and 2016. And inclusion criteria was less than 4 centimeter nodule. And this was a dynamic benchmark impacting disease specific overall survival by decision tree modeling and tested by the Cox-based model. And here we looked at age, gender, and tumor size because these are the things which are available in the SEER database. Now, here, give a little bit of time to read this table. Look at, there are total 28,000 patients who were receiving thyroid cancer treatment, and there were patients who did not receive any treatment. So we are looking only those who received treatment. Now, if you come to the bottom, how many patients died? So of these 28,000, 129 died. That is 27.6%. They may have died. And if you look at what are the causes of death, so if you look at the causes of death, majority, that is the 91% of the patient who received some treatment, they die of non-thyroid cancer related things. And 9% of the patient, they died related to thyroid cancer. And the B, that is the bottom one, it is for those who did not receive treatment. And there again, if they did not receive treatment, 87% or almost 88% they died of competing risk, not because of thyroid cancer. Similarly, those who died of thyroid cancer was 12.4%. That means even if somebody is treated for thyroid cancer, their risk of dying of other cancer or other is more common than the thyroid cancer itself. And then we did the analysis and we found that it is not only T1A that is less than 10 centimeter, but even less than 2 centimeter, that is up to 1 centimeter and then 1 centimeter, 2 centimeter, treated group, untreated group. And this is the population level data. If you look at the survival, it is similar. So we concluded in our study that there was no significant difference in risk of disease-specific death between T1A and T1B. And therefore, the whole concept of observation can be extended to not only up to 1 centimeter, but also up to 2 centimeter in selected cases. And now you have the ATA guidelines which are available. And there again, there is recommendation that less than 1 centimeter can be observed, needle test need not be done. So we have to understand that even ATA guideline has come full circle from a radical treatment to more conservative treatment for thyroid cancer. Now, this is based on the study was the Japanese study, which that was done between the timelines between 2005 and 2019. 4635 patients were clinically diagnosed with the low risk in the Kuma hospital. And what was really interesting, that of the 2,896 who underwent active surveillance, and 1739 underwent immediate surgery. And of the surveillance, 242 patients in the active surveillance group have undergone conversion surgery. So the conclusion was that there was no difference in the incidence of unfavorable events between the surveillance group and the immediate surgery group. And the prognosis of the patient in both the groups are excellent, and therefore they recommended active surveillance as a first line management for the low risk papillary carcinoma. And I have already shared the table which mentions what is the ideal candidate for observation. Now, what are the social issues when we talk about the when we talk about the early thyroid nodules? The social issues are that by calling a patient that you are suffering from cancer has a huge social and financial burden. The out-of-pocket cost for the thyroid cancer diagnosis and treatment is humongous. 16 to 15% rates of patient-reported financial burden. An independent risk factor from financial burden is younger age, lack of health insurance, and annual household income of less than 49,000. So the bankruptcy incidence at 1 year after cancer diagnosis is highest for thyroid cancer. So that is 9.3 per 100,000 person per year versus other cancer. So you can imagine that the thyroid cancer has the highest bankruptcy rate compared to the other fatal cancer, which we think could be more life threatening, and 4.39 fold higher than the control individual aged 35 to 49. And this is based on the cost and financial burden of thyroid cancer on the patients in the US, a review and direction for the future research. Now, this is another rising cost of thyroid surgery. As we know that the tumor size is decreasing, we are having more screen detected thyroid cancer. However, the cost of thyroid cancer surgery is progressively rising year by year, and that is going to be a big strain on the healthcare system in India and internationally. So, in conclusion, the incidence of thyroid cancer is more in females compared to males. Higher socioeconomic and educational status in a population may increase thyroid cancer diagnosis rates. The phenomenon of overdiagnosis seems to be the most plausible explanation for the substantial burden of thyroid cancer in Kerala and other developing states. If the rise in thyroid cancer is not curtailed, it will lead to major financial burden on healthcare system and economic welfare of the people. And for that, strict adherence to the thyroid cancer guidelines, like what Dr. Dabholkar presented, the Indian guidelines for various societies, may help reduce the rates of overdiagnosis and consequently overtreatment. Thank you so much.
Sir, thank you, Poonam here, sir. Sir, great presentation. I think that's not needed also to say. We all know. Sir, I think 2 points I wanted to make. One was that we saw that this is so much of financial burden it causes. In fact, we all feel that thyroid cancer is a small surgery, half an hour surgery, 1 hour surgery, and it won't have so much of financial burden. With the presentation you just did, one thing which is very important in our setup also, in oncology setup, that how do we convince these patients and how we can be medico-legally also safe? Because whatever said and done, because in real life scenario, when we have to take a decision for observation also, that is always there. So how should we go ahead, and how stringent these guidelines can be, at least our Indian guidelines, where they can save us if we are not going with active intervention, and that patient develops sometimes nodal metastasis or it progresses fast.
Yeah. So, Poonam, very excellent question. And we all understand that there are autopsy studies that were done in Sweden, and there people who died of unrelated causes. So they didn't die of thyroid cancer, they died of unrelated causes. When autopsy was done, almost there are many studies, and the range may go up to 25% to 30% where the occult primary was detected. So that means thyroid carcinoma in an occult level can peacefully coexist and live with us. And that is why the ATA guidelines have also come a long way. from a lobectomy to observation and all that is being done, but in a carefully
Yes.
selected patients. The patients who have posteriorly based nodule or the nodule in the groove area, the patient's age also is a factor, then rapidity in the increase. So all those factors are there, and there is a possibility that can be exercised. What is most important, the doctors themselves have to be convinced. It is not about patient getting convinced. It is the doctors have to be convinced that it is an indolent disease in certain numbers. Now, how do we identify the indolent with the non-indolent? There are criteria. And we also understand that even if you put the patient under observation for 1 year and you do the sonography and serially observe any morphological changes or size changes, even if you defer the surgery for 1 or 2 years, nothing is going to happen. So all this is there in the ATA guideline. It is there in the ISTS guideline. There are many publications. They have looked at it. And I think it is a matter of how you convince the patient and how you are able to inform the patient depends. Because these days, particularly the thyroid, these breast carcinoma patients, they come with less than 1 centimeter nodule. The needle is put, and then Bethesda 2, Bethesda 3, all kinds of anxiety happens to them. So I think if the doctors are convinced, they will be able to convince the patient, and now you have emerging evidence for that.
Right. Thank you, sir.
Thank you, sir,
So-
for excellent presentation, and we also could learn a lot. And for everyone, when I was a student of sir, I could remember every patient used to come with thyroid cancer, papillary thyroid cancer result. The first thing sir used to say, congratulations. So, so it was the obviously one of the best cancer to happen, and we should be very much conservative approaches are increasing day by day. So thank you, sir, for brilliant presentation.
Thank you, sir. Thank you, sir.
Thank you.
Asim, please take over.
Thank you, Pankaj sir, and Dr. Saurabh Datta, Dr. Poonam Joshi. Now we'll move on to our next session. The next session is on evaluation of solitary thyroid nodule. And the speaker for the topic will be Dr. Shivakumar Thyagarajan. Sir is Professor, Head Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. Welcome, sir.
Thank you, Komal.
And now I would introduce the session experts. Dr. Arvind Krishnamurthy. Sir is Professor and Head Surgical Oncology at Cancer Center, Adyar. Welcome, sir. Dr. Guru Charan Sahu. Dr. Guru is a consultant at Head Neck Oncology at TMC, Kolkata. Next, we have Dr. Neha Mittal. Madam is Professor in Pathology at Tata Memorial Hospital, Mumbai. Next, we have Dr. Ratan Shetty. Sir is Associate Professor, Head Neck Surgical Oncology, ACTREC, Navi Mumbai. And Dr. Shreya Shukla. Dr. Shreya is Assistant Professor Radiology at MPMMCC, Varanasi. Welcome all. Now over to Shiva, sir.
Thank you, Komal.
Just a small announcement before we start. So this sessions that we have kept is the talk followed by an expert session. So the experts can bring up any specific points they want to highlight, they want to discuss about regarding the pertaining guidelines that are being discussed on the talk.
Right. So, Asim, can I proceed?
Yes, please.
Okay. So, good afternoon to all. After the wonderful talk by Pankaj sir, we just next move on to the first chapter from the guidelines issue. That would be on evaluation of solitary thyroid nodule. I would like to thank Asim for this opportunity and the organization for this opportunity, and also congratulate everyone for this effort to conduct this particular program. So these are the session experts that have already been alluded to. And we will, as we go by, we will take, everyone's, opinion regarding the various aspects in the evaluation of solitary thyroid nodule. So we all are aware that the solitary thyroid nodule and is seen in up to 8.5% of the population. Now, as we go along, the word solitary thyroid nodule, which we're most often familiar with, and the thyroid nodule, these two nomenclatures will be used interchangeably. And it's more common in women than in men, as we have seen in the previous presentation, which probably gives rise to the higher number of these thyroid malignancies being detected in women compared to men. The prevalence varies with the method used for detection for these thyroid nodules. With palpation, the incidence is 4 to 17%, and it's been reported up to 12.2% in certain literature, especially that from India. And when the method used is the ultrasonography, the incidence, there's a wide range from 19 to 76%. And obviously, the percent is more because of the sensitivity of the ultrasound compared to palpation. And out of these thyroid nodules, the incidence of malignancy varies from 4 to 20% across various series that have been published in literature. Now, does it mean that we have to evaluate all these thyroid nodules? That is the most important question, which, as we are left with following the previous presentation. And as per the existing guidelines, the most commonly followed guidelines or the familiar guidelines that we are used to is the American Thyroid Association guidelines and the NCCN. But we in particular are more familiar and use the American Thyroid guidelines often. So as per that, the nodules more than 1 centimeter, which are palpable or non-palpable, with high or intermediate suspicion on ultrasonography, are the nodules which needs to be evaluated further in the form of doing it an FNA, which has to be done using an image guided method. So the intermediate and high risk nodules are the ones which needs to be evaluated because they carry a greater risk of malignancy. And if the nodules which are low risk or the very or are of low risk as per the ATA guidelines, those nodules need to be evaluated further if they are more than 1.5 centimeters in size. And for the very low risk, they need to be evaluated if they're more than 2 centimeters in size. So nodules which are cystic need not be evaluated, with an FNA as such. So these are the the size criteria which we need to follow, and the ultrasound criteria as to which thyroid nodules need to be evaluated once we come across them. Now, before we go ahead any further, there's certain clinical aspects that we need to be familiar with, which will also help us to take that decision as to who will require further evaluation. That is family history of thyroid malignancy, those with compressive symptoms in the form of hoarseness or dysphagia, presence of lateral neck nodes, especially signs and symptoms of distant metastasis. Many a times in the clinic, we come across patients who come with bone mets, who present to you with pain on the particular area where they have metastasis, and on further evaluation, it is brought to light that it is a metastatic bony lesion from the thyroid. History of prior radiation to the head and neck region or radiation exposure like the Chernobyl incidents or the various other incidents that have happened, especially the one like the post-tsunami incident, nuclear exposure in Japan, and the male gender and hard palpable nodules. So with these clinical history and findings of this nature, one should be highly suspicious of the thyroid nodule that the one that they evaluate. So following that, what are the investigations that we do? So the serum TSH is the first initial investigation that we would proceed with. So once we do a serum TSH, we have to see whether the TSH is subnormal, that is at the lower range, or whether it is high or normal, that is whether it is hypothyroid or whether it is hyperthyroid or U or hypothyroid. Now, when it is high normal, that is when it is euthyroid or hypothyroid, We will come to that flowchart subsequently. Now we'll see just with when the TSH is subnormal, that is when it is hyperthyroid. So that is the only in a situation wherein we need to do a radio. We could consider doing a radionuclide thyroid scan using iodine 131. Now, when that is done, we could have three situations in hand. One, you can have a hot nodule, you can have a warm nodule, or you could have a cold nodule. Now, if the nodule is hot or warm, most of the time there's no further evaluation that is essential unless clinically or radiologically, that is on ultrasound, if it is felt essential. So that patient needs no further evaluation, except for maybe the patient would require some symptomatic treatment for the if the patient has an overt hyperthyroidism. But if the nodule is cold, that is the time when the patient would require an ultrasound guided FNA, because the chances of malignancy in such a situation is higher. Even in a hot or warm nodule, though it is very less, there might be up to 4% chance that they may harbor a malignant foci. But then that would be essentially picked up with further evaluation in ultrasound, and only if necessary should an FNA be done. Or in these situations when the nodules are hot or warm, they can be just be observed. So that is very important that we understand this. And many a times we do get questions and as to whether iodine scan, the radionuclide iodine scan, should be done routinely. The answer should be it should not be done routinely. It should be done only in select situation, especially if the serum TSH is subnormal, meaning that the patient is tending to be a hyperthyroid situation. Only in those circumstances should a radionuclide iodine scan be considered, not otherwise. Now, what is the role of various serum markers in the initial evaluation of a thyroid, solitary thyroid nodule? The two commonly done are serum thyroglobulin and calcitonin. So, routine measurements of these serum markers should not be done as they are insensitive and non-specific for thyroid cancer, especially the serum thyroglobulin. And there is insufficient evidence that is available in literature to promote their routine use in an evaluation of the thyroid nodule. So it should not be done upfront in the evaluation. Same with serum calcitonin. It should not be done routinely unless there is a familial history of medullary thyroid carcinoma, or even if the patient says that there's a family history of thyroid cancer, one could consider that the most common familial thyroid cancer is medullary compared to a differentiated thyroid cancer. So in those circumstances, one could consider doing a serum calcitonin. Or many a times, if the FNA is, if the pathologist is not certain as to what the malignancy is, like for example, is suspicious of DTC. Sometimes we get a differential diagnosis. It could be a DTC or a medullary thyroid cancer. In those situations, only it can be done just to have a clear picture. But otherwise, upfront, there is no role for a serum thyroglobulin or a serum calcitonin to be done. The other situation that we often see is that the PET incidentallomas, because if the patient may undergo a PET scan for a primary from other sites, for example, like what Sir said, CA breast or CA lung, CA pancreas, or whatever, and there's a incidental pickup of these, of the PET FDG within the thyroid nodule. So what should be done in those situations? So the need for evaluation in such situation is to be considered if the uptake is focal within a nodule of greater than 1 centimeter in size. If the uptake is diffuse, along with an ultrasound confirmation of no, highly suspicious features of the nodule on ultrasound, then there's nothing that requires to be done. But if there's a focal uptake like the one that you see on your screen, then the chances of that nodule being malignant is higher, up to 33%. But if it's diffuse, then nothing needs to be done further. So only in those circumstances should these PET incidentallomas be considered for further evaluation. Now, coming on to further imaging as to how do we, go about, the interpretation of the various imaging. First, And the most often and the most important imaging modality that we utilize in the evaluation of solitary thyroid nodule is the ultrasonography. And the features in the ultrasonography are very important to note, because that is what is going to give us a, an insight as to whether that nodule is benign or malignant. So the USG needs to be performed with high frequency machines, and the findings are operator dependent. And that is why it is very important that we need to have highly experienced sonologists who can help us understand these findings better. And ultrasound USG findings should be reported using a synoptic template like the Tirad system. We'll just come to that in a moment. And this is because it's because of the fact that it's sort of a common language which the pathologist can use to make their colleagues, the surgeons, understand as to what is the type of nodules that what is the nature of the nodule that they have assessed, and what are the chances that it could be benign or malignant. So, and also it is very important for better communication across specialties, to understand as to how we can go ahead further based towards evaluating and treating these patients, and also for reporting and understand in reporting of these nodules uniformly, so that it will be useful for research purposes as well. So what are these
Why presenting the
ultrasound?
guidelines? Why is presenting a lecture?
Ma'am, I'm presenting the guidelines only. All these are from the guidelines. I'm not presenting a lecture. These are all in the guidelines, that chapter 1. I'm just doing that, and these are based on the guidelines. And I'm just coming to that one by one. And what are the ultrasound findings suggestive of, what are the ultrasound features that are that is suggestive of high risk features? That is presence of microcalcification taller than wider, absence of halo, irregular margins, hypoechogenicity, solid nodules, and intralesional not intraocular, that is a typo error, intralesional vascularization. Now, the thyroids, these are the essential findings of the thyroids. And what do the thyroids say is the composition, echogenicity, shape, margin, and the echogenic foci, right? And and based on that, the scores are given, and the overall score starting from 0 to 7 or more. Based on that, the patients are graded as thyroids 1, 2, 3, 4, or 5. And the thyroid 4 can further be subdivided as thyroid 4A, B, and C. So thyroid 4 and thyroid 5 are the ones that needs to be evaluated further. That is what the guideline says. So, and we are, we need to understand this to understand the guidelines, right? So that is, so ultrasound should be reported with the in a synoptic manner using the Tirad system in this format, so that the clinician can understand the nature of the thyroid nodule. So when multiple nodules are seen clinically or on ultrasound, FNA should be done. Like for example, you have a single nodule, then then the question of evaluation is based on all these factors. Now, when you have a patient with a multinodular goiter, when the patient has more than one nodules, how do you evaluate? Do you do an FNA for all these nodules? Now, in that situation, the FNA should be done on the nodules which are greater than 1 centimeter and that appear most suspicious on an ultrasound. Nodules that do not meet the criteria for performing an FNA should be kept under ultrasound surveillance. So not all the thyroid nodules that you pick up on an ultrasound needs to be, FNA. That is the most important thing, right? And is there a role of FDG PET? What does the guidelines say? Both the the ATA guidelines and the ISTS guidelines tell us that the FDG PET should not be routinely performed for evaluation of an solitary thyroid nodule. There is also no role in performing routine iodine scans to evaluate an solitary thyroid nodule that we have already seen. Should we do a CECT? In the evaluation of a thyroid nodule. CECT can be considered in the presence of multiple neck nodes that is picked up clinically or radiologically, that is an ultrasound, or locally advanced tumors on clinical examination or an ultrasound, or in the presence of compressive symptoms such as hoarseness and dysphagia. Now, that is about the imaging aspect of it. Now, we need to know about FNA. So essentially what is being, what is being aimed at delivering in this lecture is the guidelines that are available, and that is, and how to go about evaluating a solitary thyroid nodule. What do we have in the guidelines based on the evidence, and what needs to be done for the thyroid nodule? Should every thyroid nodule be evaluated, or do we evaluate only certain thyroid nodules that have features which are pointing towards that thyroid nodule being benign or malignant? So that is what we need to understand. So we have seen what are the ultrasound features that could point towards the malignancy, and how an ultrasound should be reported based on the thyroid scores. Now, FNA should be done using a 24 to 26 size needle, and we should not do no aspiration should be done. No aspiration technique needs to be adopted, because if you do an aspiration technique, you might have blood coming in it and your FNA will be non-diagnostic. So you'll have to repeat the FNA. So it should be a no aspiration technique. The FNA must be reported using the Bethesda system for reporting thyroid cytopathology, right? And now we have the Bethesda, the third version of it, the Bethesda 2023 being the latest. We had the first one being introduced in 2009. A revision of it was done in 2017, and 2023 we have the latest. Now, how is the 2023 different? It has discontinued certain terminologies like unsatisfactory, follicular lesion of undetermined significance, or suspicious for a follicular neoplasm. And it has made it much more simpler. And the NIFPT division, which was there in the 2017, is not there. And it gives us a risk of malignancy for non-diagnostic, benign, ATP of undetermined significance, follicular neoplasm, suspicious for malignancy, and malignant. So non-diagnostic is Bethesda 1, benign is Bethesda 2, ATP of undetermined significance is Bethesda 3, follicular neoplasm is Bethesda 4, suspicious for malignancy is Bethesda 5, and malignant is Bethesda 6. And that's the risk of malignancy with the range. Now, what is the criteria for adequacy of FNA? And this FNA should be done using image guided. That is what most of the guidelines say, and that is what even the ISTS guidelines tell us, that the FNA should be done image guided, and the adequacy of the FNA should be confirmed at the side of by the cytopathologist on site. That is where the radiologist is performing the sonologist is performing the ultrasound, and it should. How do what is the criteria for adequacy for an FNA? It should display at least 6 groups of follicular cells, and each group is composed of at least 10 cells, preferably on a single slide. Now, if this criteria is ascertained, then that is an adequate FNA being done, and the pathologist will be able to tell you, give you the possible Bethesda category to that, that nodule that you're evaluating. Now, and what, each of these, how do you proceed with each of these categories is given here in the management table, but we'll come to the flow chart in a few slides. And what we need to understand is the risk of malignancy for all these different Bethesdas, may vary across institutes. It need not be the same. Overall, it is more or less the same, but it need not be the same, right? So the risk of malignancy may vary from institute to institute, but you need to know what is the risk of malignancy for across these, Bethesda category in your institute. That is also very important, apart from knowing what is there in the literature. And this is what I just spoke to you about the Bethesda 2009 and 17. And 2017, it was divided. You had 2 risk of malignancy groups. One, the NIFP with the NIFTP, and then the one without. We'll not go into that detail in this particular session. Now, this is the flow chart that is there in the chapter as well, right? And this essentially sort of summarizes what I've just said so far. Okay, so the solitary thyroid nodule, the thorough clinical history and evaluation, looking at the factors that I just mentioned in a few slides earlier, is important. Then you should do a serum TSH, right? And based on your serum TSH, whether the TSH is subnormal, that is low, whether the patient is tending towards being hyperthyroid, or whether the patient is euthyroid or hypothyroid. We need to go further. So we have already seen the patient is hyperthyroid or low TSH, a radionuclide scan can be considered. Hot nodule or diffuse uptake, no suspicious features on ultrasound, only follow-up is needed. If the patient has a cold nodule, then these patients will require an USG of the neck. That is, the thyroid and also the lateral neck needs to be evaluated. Based on the nodule features and the size criteria that we just discussed earlier, we need to consider whether USG guided FNA needs to be done or not. So based on that, if we do an FNA, that needs to be, the ultrasound features needs to be reported using the Thyroid system in a synoptic way, and the FNA needs to be reported using the Bethesda system. Now, if we are now based on the each Bethesda category, what do we have to do? Now, if it is non-diagnostic, that is Bethesda 1, we need to consider repeating the FNA, and that has to be under USG guidance. If it is Bethesda 2, that means it's benign. The patient can be kept on clinical and USG follow-up. That should be sufficient, unless and until the patient requests for a surgery for cosmetic purposes. That's a different scenario altogether. But otherwise, the patient can be kept on follow-up. Now, ATPA of undetermined significance, that is Bethesda 3. What has to be done? We can have three things. One is we can consider repeating the FNA again using an USG guidance, or we can just keep the patient on surveillance, or the patient could be considered for lobectomy. So any of these three options can be considered, but then it's very important that we need to discuss with the patients about these possibilities. It depends on how many FNAs already been done prior, because there's no point repeating the FNAs multiple times, because that adds to the anxiety, and it's also a painful procedure, whatever said and done. So these three options have given in across the guidelines and needs to be discussed with the patients and has to be considered depending on the patient that is sitting in front of you. For Bethesda 4, the options, and also the other point is for Bethesda 3 and 4, you need to know what is the risk of malignancy at your institute for these different categories of Bethesda. That also will help you in advising the patient as to what needs to be done. For Bethesda 4, either a lobectomy or hemithyroidectomy is advised. Now, we will come to the differences between the AT, like what Madam presented in the previous slides. What are the differences between ATA and ISTs? So in the ATA and even the BTA, the British Thyroid Association and NCCN, for the Bethesda 3 and 4, which are mostly considered as the indeterminate nodules, the molecular testing is advised. But in the ISTS, the molecular testing is not, is not put up in these flowcharts for the reason that it is not available routinely and across centers in India, and also the cost aspect of it. So because of these reasons, it's not mentioned here. So for Bethesda 4, it can be lobectomy or hemithyroidectomy. For lesions that are suspicious for malignancy, that is Bethesda 5, Bethesda 6, surgery in the form of a lobectomy, hemithyroidectomy, or a near total or total thyroidectomy, depending on the size criteria and the end status of the neck, further treatment can be considered. Now, malignancy in multinodular goiter, the incidence of people with MNG is quite high, but and there are huge number of patients who are at risk as well. And also we had seen that when there are multiple nodules, how do we need to evaluate? So we need to know that the incidence of malignancy in MNG has been in multinodular goiter has been reported to be 7 to 21% in literature, including Indian literature. Hence, patients with multinodular goiter need to be evaluated thoroughly and carefully and treated appropriately, because many times we do see in practice, and many of you all will see that it is operated considering it to be multinodular goiter, but then in the final report malignancy is mentioned, and then there is confusion and chaos as to what needs to be done further. So just because you have multiple nodules, it needn't be just multinodular goiter all the time. It needs to be evaluated thoroughly, like what was mentioned so far. Now, molecular testing. Now, though it's not mentioned, it's important we understand, how the molecular testing have been, why it has been suggested in the other literature, and of course, we have told the cost considerations and the unavailability on the routine basis, we have not, it's not been mentioned in the ISTS. Now, the molecular testing, there are both rule in and rule out tests. A test can be rule in malignancy, that is the likelihood of that nodule is malignant or not. That is called as a rule in test. A rule out is the likelihood of that nodule is benign. So for Bethesda 3 and 4, when the range of malignancy is between 13 to 35, and rule out malignancy would be suggested, which has a high sensitivity and high negative predictive value. And for Bethesda 5 category, when the risk of malignancy is 67 to 83%, a rule in is suggested, which has a high specificity and a high positive predictive value. Now, these are the various, molecular testing that has been suggested over the starting 2009, and there are various, publications which helped, understand the importance of these molecular testing that were published over the years. That has been, just for your understanding. We have the Thyroid, we have the Affirma, and Thyroid has version 1, 2, and 3. Now, just to give you the understanding that the sensitivity and specificity for these sensitivity of these Affirma is higher, whereas the specificity is lower. So the negative predictive value is higher, whereas the positive predictive value is lower, right? We need to understand that. Now, how does this positive and negative predictive value important? That is, I mean, how do you interpret that? Before that, we need to understand that the institutional prevalence for thyroid malignancy for these indeterminate nodules is very important. Based on that, your positive predictive value and negative predictive value will vary, because the positive predictive value will decrease if the prevalence is low, and the negative predictive value will decrease if the prevalence is higher. So that basic understanding is important. So that is why we need to know what is the prevalence or the incidence of malignancy in the various thyroid nodules at your institute. That is very important. None of these molecular tests help rule out malignancy in any indeterminate thyroid nodule. And these tests are not available in India, and hence data from the use of these nodules, or these panels, sorry, on Indian population is also not available. And they cost anywhere between 3,000 to 6,500 US dollars, which means it's anywhere close to 3 to 6 lakhs just to evaluate as to whether these nodules are malignant or not. But there are molecular tests which comes at a very lower cost, less than a lakh or even lesser, half of that. But that too is not available on a routine basis, and it's not, the data from that test from a larger population is yet to be made available in public domain. Now, this is what I just mentioned, that we don't have Indian data on the various molecular aspects of the thyroid nodules. This is just one study which just summarizes the various Indian studies. All of these are IHC based studies, which tells us about the various molecular markers that have been studied. The most commonly studied is the BRAF V600E mutation, but not based on these molecular testing that the Affirma or the gene expert the Affirma or the Thyroid that we just mentioned. It's just for completion's sake. Now, coming on to the slide as to what is the difference between the 88-2015 and the present ISTS guideline. Now, which thyroid node? There are two basically the differences that we have kept. The thyroid nodule, which thyroid nodule should be evaluated? Thyroid nodules greater than 1 centimeter in greatest dimension with high and intermediate suspicion, and nodules of 1.5 centimeter with low suspicion on USG needs to be evaluated, is what mentioned. So here we have mentioned that only greater than 1 centimeter nodule with high and intermediate risk needs to be evaluated further. So ISTS guidelines have not recommended FNA for thyroid nodules with low suspicion on ultrasound. That was based on the consensus among the ISTS task force that was taken. That was the one difference that is highlighted. The second difference I've already spoken about, the molecular markers for Bethesda 3 and 4 thyroid nodules. The molecular testing may be used to supplement malignant risk assessment, is what the ATA says. The ISTS 2024 has not recommended because the molecular tests help rule out malignancy in an indeterminate thyroid nodule. However, the tests are not available in India. As I mentioned, the cost of these, the Affirma and the Thyroid, but and also not affordable, and we don't have data from any Indian population as to what are the mutations that are more commonly seen in what are the panels that needs to be done in a that is commonly expressed in malignancy in Indian population. So that data is still evolving, is not well understood, based on which data might become available in the future, and that is one thing that is why it is not being recommended. So to conclude, a thorough clinical history and evaluation needs to be part of the evaluation of STN. Documentation of the vocal cord status is very, very important, because it is important to understand as to whether the patient has compressive symptoms, one, and also it is very important for medical legal aspects. Nodules more than 1 centimeter in size with high and intermediate suspicion of ultrasound need to undergo FNA, and FNA needs to be done by image guidance, that is USG, and reported using Bethesda system for reporting thyroid cytopathology. Ultrasound finding needs to be reported using a synoptic template using the TIRAD system. Serum TSH needs to be done to assess thyroid status, and then based if the patient is hyperthyroid, and only then a radionuclide iodine scan can be considered. Routine measurement of serum thyroglobulin and performing FDG PET is not recommended in evaluation of solitary thyroid nodule. Evaluation of Bethesda 3 and 4 nodules using molecular markers is not recommended in the Indian context due to the high costs and unavailability. We'd like to invite you all for the FHNO 2024 as well, which is to be conducted in Mumbai in the month of October, that is between 18th to 20th. And thank you all for your patient listening. Asim, we can open up the question for the expert panel as well, and we can discuss, because I think we have a lot of time.
If the expert panel is saying something, I will wait. Otherwise, I want to make a comment.
Yeah, please, ma'am, go ahead. Before the expert panel says.
Shiva, very well put up. And I think any surgeon or anybody seeing a thyroid nodule, what to do the next, what is optimal, when to poke a needle, what to expect from the radiologist, what to expect from the pathologist. I think even the general ENT and the general people learn this much very well. I think we should be in a better position or feel good about these guidelines. Second point which I want to make about is a molecular marker. 6 years back when I spoke at World Congress of Thyroid, I outrightly, overwhelmingly criticized, or I wouldn't say criticize, but I said this is not for India. But 6 years later, when I spoke, this time I spoke on a molecular markers testing available in India. It's at about 25,000. Most of the panel is a very complete panel. But as you rightly said, we are lacking the data. So I want to ignite the young minds that these guidelines which Shiva presented, and probably Niti's prospect study, where all these basic investigations like sonography finding, FNAC finding, other history and all that, put up in a nanogram, and then finding out the risk of malignancy. And if the malignancy risk is upward of, say, 85%, you will operate. So operating or not operating, probably we may not require molecular markers. But how this particular cancer is going to behave in a particular individual, whether he has a genetic predisposition to for a bad behavior, and also to apply the targeted therapy early, I think molecular markers will play an important role in this scenario. And that's why I personally feel that we should start doing, especially the tertiary care centers and Tatas and Kedwai and Amrita and all those centers should start doing the molecular markers, because now it is available at a 25,000 rupees, or maybe it will come down further. So my message is, yes, we are not ready to use it routinely, but something has to start somewhere. And I think that this is the area where molecular markers should be studied, and we may at the end of 10 years, may have a very, very encouraging results for their use. That's all I would say. Again, I congratulate you and Asim both for having a wonderful session. Thank you.
Yeah. Dr. Neha, you want to say something? Please go ahead.
Good afternoon, everyone. Thank you, Dr. Shiva, for that wonderful talk, and thank you, Asim, for the opportunity. I have a few points to make, and I think I must advocate. I'm a pathologist, so I have to be the advocate for molecular pathology here. So I have a few points to make. First, I think whenever we are sampling a cystic lesion, I think I would reiterate that one, ultrasound guided FNA is the way to go forward in thyroid FNA. And two, if we are aspirating, then we have to re-aspirate whatever is residual. That is very important. Whatever is left off after aspirating the colloid, whatever is left off of the nodule must be re-aspirated, and in all probability should be sampled separately labeled, so that that is the area that cyst with mural nodule, and that mural nodule is the focus of tumor so many times. Otherwise those cells get drowned in that cyst fluid, and we may miss the malignancy there. Number two, we, as Dr. Shiva highlighted, that it is very, very important to understand the risk of malignancy in thyroid nodules in your own catchment area. The risk of malignancy varies according to the hospital and the catchment area of that hospital, and that must be established by looking at your own cases by doing an audit. Number three, that during surgery role of frozen section. So avoid frozen section for many reasons for primary diagnosis in thyroid. One, because that papillary nuclear features are a harbinger of fixation. And because frozen tissue is fresh tissue, so even papillary nuclear features are not well developed in frozen section. So frozen section, if at all, has very limited role in thyroid surgery or thyroid treatment of a patient. However, the main role that is there is nodes. For nodal metastasis, if you want to confirm, if you want to look at central compartment metastasis, bulky central compartment metastasis to decide for lateral neck dissection, then those are the roles in which you can decide based on frozen section of the nodes. But for primary diagnosis, stay away for it for most reasons. One section does not suffice to talk about capsular or vascular invasion in follicular pattern regions, and nuclear features of papillary are not well established in frozen section. Now, coming to molecular pathology of thyroid. So the entire follicular thyroid pathology, all the different names and all, if you see, actually boils down to 4 genes, 2 of which are driver mutations and 2 of which are acquired. So the driver mutations are the BRAF and RAS, and the acquired mutations are the TERT and the P53. BRAF is equal to malignancy. Anytime you have BRAF in a thyroid, FNA or whatever material you are testing for, it is equivalent to malignancy. It straight off means that this is a malignant lesion. You can straight off decide based on what surgical extent do you want to plan. RAS is not equal to malignancy. RAS in thyroid can happen from follicular adenoma to poorly differentiated thyroid cancer. So that is a basic concept that is very important to understand. And that is one of the main reasons why your FNA based pre-surgery FNA based molecular tests are not giving you the information or the result that you want it to. Most of the BRAF are PTCs. Those PTCs get very well FNA'd, and very well sampled on FNA. And because of the very distinct nuclear features, we are able to label it as category 5 and 6. What ends up being called as category 3 or 4 Bethesda are actually those RAS lesions, where architecture, which means capsular or vascular invasion, decides malignancy, and not just the presence of tumor cells in the FNA. And in those cases, even finding RAS mutation with your preoperative molecular tests will not tell you whether it's a malignant lesion or not. And hence your treatment will eventually be based on whatever were your clinical and radiological features. I'm sorry, bad throat. That is why this is very important to understand that what are you going to use the molecular classification for. The other thing is that post-thyroidectomy molecular classification is highly underrated. That is also should be used, because if you see, the molecularly defined entities behave differently. Your BRAF positive tumors are PTCs, will come back with locoregional metastasis, will come back with nodal metastasis, but practically never with distant metastasis. Whereas your RAS mutated lesions, if malignant after resection, will come with distant metastasis and never with nodal metastasis. So it has implications for the surgical extent and the follow-up of the patient if used in the correct context. TERT, anytime the patient has BRAF or RAS co-mutated with TERT, there are studies to indicate that the patient should undergo total thyroid irrespective of the size of the lesion, because TERT is a indicator of the patient coming back with distant metastasis as well as anaplastic transformation. So these are important points as far as the molecular. So even post-thyroidectomy, molecular does have its significance, and pre-surgery molecular has its caveats, and hence has to be used in the right context depending on what information you want from it. The tests are getting better. MicroRNAs in RAS mutated tumors actually can differentiate between benign RAS versus malignant RAS. The Thyramir that you showed, the Thyramir test that Dr. Shiva showed, actually has those kind of microRNAs to decide whether the RAS mutated lesion is benign versus malignant. But that test is a very newly developed test and has not been let loose on the general population for us to understand its sensitivity and specificity. So just to tell you a little about the molecular. The other thing is that there are now, according to the new guideline, areas where molecular is compulsory. One situation is an anaplastic thyroid carcinoma. Every single anaplastic thyroid carcinoma now has to undergo BRAF testing. IHC is good enough. If you don't have IHC, you can do molecular, because MEK inhibitors have worked beautifully in some of these cases. Hence, BRAF IHC is essential in anaplastic thyroid. Similarly, we do not use the term microcarcinoma anymore. So any tumor which is even less than 1 centimeter but has extrathyroidal extension should be tested for BRAF, because if that is BRAF positive, it becomes an intermediate risk tumor according to ATA rather than being a low risk. So these two situations, molecular is essential even post thyroidectomy. In other situations, we can look at whatever information we want from it and whether the molecular will help us giving that information.
Yeah. Thank you, Dr. Neha. That was a fantastic insight into the various molecular markers in an FNA and even otherwise. I totally agree with what you just said. So we'll just go with opinions and comments from other experts. I think Guru Charan had just first initially raised his hand, and then we'll go with the rest of them. Yeah, Guru Charan.
Good afternoon, Shiva sir. Excellent presentation and excellent demonstration of things. So just wanted to discuss one point regarding your presentation, and according to ISPS, there is in this flow chart. Is there any role of near total thyroidectomy in this era right now in thyroid malignancy or Westchester 3 or even Westchester 4 reports, even if we get? Is there any role of near total thyroidectomy?
So we are not talking about, subtotal thyroidectomy. I think that's what you're worried about. Your near total thyroidectomy, meaning sometimes you might leave behind a small nubbin, as what Dicrusa would put it. And some amount of tissue at the entry point where you're worried that you might, damage the nerve. So that is what we are calling as near total thyroidectomy. So what is the typical, explanation or definition of near total is you leave behind, 1 gram of tissue. But who has measured that 1 gram of tissue? It's just a assumption, or it's just said that way. So near total meaning, you could, even if you do happen to leave behind for certain reasons like that, that is an accepted surgery. Even in the ATA 2015, I know it's it's almost 10 years, 9 years now. So near total thyroidectomy was mentioned as a procedure which can be done for a differentiated thyroid cancer, but we just need to look forward to 2024 whether they do away with near total thyroidectomy or just retain it. But what we need to understand, that's a great point that you raised here, because many of them would be thinking in similar lines. What do you mean by near total thyroidectomy? Is that you don't willingly leave behind any thyroid tissue? That is not what is recommended. But if you happen to leave behind some amount of thyroid tissue, small nubbin of sorts, which is, there's no dimension that can be given. That's why 1 gram was mentioned earlier. But that is also okay, because that that can be taken care of in your subsequent radioactive iodine ablation, that if the patient goes ahead and receives. But not willingly leaving behind tissue anywhere and everywhere. That is not what is being said. I hope that clarifies. Yeah.
Shiva, that 1
Yeah,
gram, the 1 gram or whatever we are talking about, is basically at the ligament of Berry where the nerve enters the larynx. And if the surgeon is not confident that he can completely resect without damaging the nerve, he is justified in giving a functional nerve rather than worrying about that small amount. So this near total, in that case, he should write that he has left behind a small amount to these areas rather than writing a near total. So I think I agree with Dr. Jatin Shah that there is no near total. Either it is hemi with hysterectomy or a total. But all these other situations are that surgeon was skeptical about like damaging the nerve and everything, and he has left behind. He should be frank enough to write so that when your post-operative radioactive scan is done, the RAI guy can correlate that yes, surgeon has written that note and this could be that, and then it can be ablated or whatever. So I personally feel that this near total thyroidectomy should not be utilized routinely, and if the surgeon has done kind of a thyroidectomy where he has left behind a particular tissue and that is only at the ligament berry, I think he should mention in a note that I have purposely left behind a small chunk of thyroid tissue which was covering the nerve in a lieu that I should not damage the nerves. So I think near total per se should not be utilized term, and we should discourage our residents and trainees to use that term, because I know that in teaching hospitals and other many hospitals, this is very routinely done, even general surgery. And this term for a head and neck cancer or a thyroid association surgeon should not be utilized that loosely. That is what is my comment.
Yeah, point taken. Point taken. This is there in our ISTS guidelines. It is there in 88/2015, and it's the point here is that the surgeon has to understand what that near total thyroidectomy is meant, like what all is being discussed so far. So near total thyroidectomy shouldn't be a reason to do less leaving behind too much tissue in the thyroid bed. That is not what it is. As what was said, so discussed so far, it is just at the ligament of Berry at the entry point if the surgeon is worried or that needs that a small amount of tissue can be left behind. And as what was mentioned rightly, that needs to be documented as well. Dr. Arvind Krishnamurthy sir, would you want to say something on this?
Sometimes the pyramidal lobe, if the surgeon has not purposely looked for, though it stands out many times. So on the pyramidal lobe could be left behind and there can be update. But near total,
that is a different issue, ma'am.
We had a good discussion on this.
Yeah. Dr. Arvind,
you can give some comments.
I know. I agree with Dr. Jyoti, madam. I think Professor Shah really hates the term near total for some reason. I agree. I guess it's just a larger philosophy. I think they say either it should be a lobectomy or hemithyroidectomy or a total thyroidectomy, and I largely agree. When experienced surgeons do a near total, they really understand, as madam really said, that to safeguard either the parathyroids or more likely the recurrent laryngeal nerve. Yeah, I had a few other points to make. But Shiva, I really enjoyed your talk. I really enjoyed the article as well. Actually, thanks to Azim, for organizing this. I really had read through the entire journal actually, and I must congratulate Dr. Jyoti and the entire team KK. Everybody really put in a lot of efforts. After 2015, I think it's been some time. Of course, we've been getting updated periodically through other sources, but I think this is a very useful document in general. And I just wanted to make some sort of observations basically on, I think you really mentioned about PET detected incidentalomas in the journal article. Just wanted to reiterate some points on this. By and large, I think what's happening is in the oncology setting, especially when oncology hospital treats multiple cancers, there is a lot of usage of PET CT scans, FDG PET CT scans. And we tend to pick up a lot of these thyroid nodules, which are incidentally detected on PET.
there seems to be a little difference between what the West sees and what we have seen, because we have actually studied this to some extent. While the incidence is around 1 to 4% in the Western series, I think we tend to see, possibly, of course, this is maybe a bias of a tertiary care institution, our pickup of incidental PET detected nodules were close to 11%. And the incidence of malignancy seems to be much higher in PET detected nodules vis-a-vis ultrasound detected or any other detected, and maybe close to around 15 to around 50% or so. But again, what we have observed is a lot of the times, only about 14% of the focal incidentalomas were evaluated, and the final incidence of malignancy was actually 10%. And the reason was, I think, a majority of the times in our institution, or for that matter, any tertiary care institution, a PET-CT scan is generally done for some hematolymphoid malignancies, advanced lung cancers, etc. Wherein what really happens is the treating surgeon or the treating clinician doesn't really chase those thyroid nodules. And that's the reason why in our series we found slightly lower incidence of malignancy in the PET detected incidentalomas as is quoted in the literature. So this is one interesting finding that we sort of observed, and I thought that and you did really make a small mention about the PET detected incidentalomas in the journal article, and I thought I could share some of the insights here as well. Shiva.
Right. Thank you, sir. That was a great point. Dr. Shreya Shukla wanted to say something, and then we'll come to you, Ratan.
Yes, so good evening, everyone, and thank you for that very comprehensive and excellent presentation, sir. I just wanted to bring to light a small but very important radiological point. So we have been discussing about nodules less than 1 centimeter and whether we should pay any heed to them, whether we should FNA them. And then in our last session, Dr. Poonam had raised the concern about what should be done, whether there should be active surveillance, whether they should be treated. So as a radiologist, we also come across these nodules less than 1 centimeter very often. My suggestion to the radiologists were that if they could be more precise in their reporting. So Dr. Shiva had mentioned about the need of synoptic reporting, the need of mentioning the Thyroid score in the report. Above that, if we see a solid hypoechoic nodule which has a Thyroid score of, let's say, 4 or even 5, if we could add to this by mentioning the high-risk features in a nodule less than 1 centimeter. Now, these high-risk features include the presence of nodule in the thyroid isthmus. So thyroid isthmus is only 3 to 4 mm. So if a nodule even of, let's say 7 mm or 8 mm is present in the thyroid isthmus, it is going to abut the capsule and probably even invade the capsule. So that is extrathyroid extension. Then a nodule in the posteromedial aspect of the right lobe of the thyroid, which is probably abutting or invading the recurrent laryngeal nerve. Then a nodule in the left lobe of thyroid, which has, or a right lobe of thyroid, but it has an ipsilateral cervical node. So a nodule along with a suspicious looking node. And finally, a nodule along the medial aspect of the right lobe of thyroid, which is abutting or probably micro-invading the trachea. So if these 4 pointers to a small nodule, but a high-risk ultrasound feature, if mentioned, probably will help you decide better whether to go this way or that way, whether to be conservative or be a little vigorous in planning the treatment of the patient.
Shreya, I really appreciate the comment you made. But our general, I mean, I have about 44 years of experience in head and neck. And I personally feel that when I was a president of FHNO and secretary subsequently, the synoptic reporting of the Bethesda and oral cancer, we were printing out, and at every conference we were distributing in the delegate bag for the clinician to take it home and discuss with his pathologist to give a report in this fashion to really help our patients and to plan everything properly. But I must say, I'm really sorry to say that in thyroids, in head and neck, I mean in thyroid, somehow this synoptic reporting is not uniformly given by any radiologist, and I don't know why. I think that a young girl like you should take up this as a mission and see that the synoptic reporting of a thyroid cancer be given in this fashion, that risk of malignancy is written, what are the features which are high risk is written, all these 4 sites which you have said about that is written. So I will urge you that you make a synoptic reporting form and give it to us, that we will distribute this to ISTS conference at every time. Will you take up this lead and make a synoptic reporting form for us?
Of course, ma'am. Thank
Nicely.
you so much. Thank you for
Yeah,
the
because
opportunity, ma'am. It
I
would be
have a frustration. My own hospital, my Reliance Foundation hospital, does not give a reporting in a thyroid's grade. Believe me, I don't want to name both the radiologists, but they are not giving. I have gone over to them and asked them, and then they say maybe this, maybe that, because they are not routinely practicing.
Yeah.
So if this is the situation of the leading head and neck institute, I don't
Yeah.
know what must be happening at every place. And I think that as a society, the way we have written guidelines, I think our next point is Bethesda classification, synoptic reporting, and your thyroid. I think we should give it at every conference and highlight that you go back and talk to your radiologist, talk to your pathologist, and get the reporting in this form. I think we should do it. So you are
agreed,
you are
ma'am.
the one chosen for writing the synoptic reporting of thyroids. Okay.
Yes, ma'am. I'll try to do a
Okay.
good job.
Thank you
Thank you,
so much.
ma'am.
Thank you.
Thank you, Dr. Shreya and Madam. Ratan, you wanted to say
Yeah,
something?
yeah, excellent talk, like always, sir. Just wanted to ask you regarding fat detected incidental tumor.
Yeah.
What does the guidelines say regarding focal uptake in fat, and especially in lethal disease like say pancreas or say with extensive tongue involvement? Should we be chasing these nodules even if it is Bethesda 5 or 6?
So that's a great point that you raised, Ratan. But I think
Yeah.
if you come up with I mean, it's a matter of philosophy here, and your philosophy has to be decided for your particular institute that you're working at. And it depends, and it should be based on the prognosis for your index cancer during the evaluation of which you have come up with, where this incident tumor was detected. And based on that, further evaluation or anything else that can be, done for this patient. And we shouldn't blindly go chasing this, as you said, rightly said, any thyroid nodule when, for example, a patient has a CA, stage 4 CA pancreas or CA lung for that matter, and this thyroid nodule is picked up, and we shouldn't be just chasing that in every patient. So maybe we should understand as to which patient needs to, be evaluated further in that situation. I think it's a niche discussion, and it's a separate topic by itself, I guess.
Yeah.
And
Yeah.
I'm open
Yes, sir.
for comments and questions on this. We have
Thank you, sir. Yeah,
20 more minutes to go.
yeah, I believe that the primary malignancy should guide the treatment. If it is a very lethal
Exactly.
disease, then there is no point in chasing. If it's
Yeah.
a curable cancer, potentially curable cancer, then I think we should address it.
Right.
Thank you,
That's
sir.
right.
And then
Yeah.
one more point, sir. The Europeans never agreed with the ATA up till last year, 2023 guidelines. They have also recommended surveillance for tumors less than centimeter. So
Right.
2023
Right.
European guidelines also does not recommend FNA for less than a centimeter. Thank you, sir.
Great. That's nice to know. Thank you, Ratan. I think we have a few questions from the other participants as well. Before we go there, there's one question here as to whether the TERAD system also applies for pediatric thyroid cases. Dr. Shreya, would you want to take that question? Dr. Shreya?
Yes, sir. So,
Yeah.
yes, I'm here. Yes, so there is no mention of exclusion or inclusion criteria in terms of age in TIRADS. So we are using TIRADS only for reporting nodules in pediatric cases as well.
Yeah, and also the presentation of the pediatric thyroid nodules are slightly different. But this is a great question because there's not much on the pediatric thyroid cases of the reporting of those nodules in using the TERAD system. Probably one of the reasons could be that most of these pediatric cancers present in an advanced stage with bilateral neck nodes and also sometimes distant metastasis. So the clinical presentation is slightly different in a pediatric age group compared to how it would in an adult. That would be one reason that comes to my mind as of now. And there was one question as to how to deal with. Sorry, yeah. Anyone want to say something else? Yeah, Guru
Shiva
Charan.
sir, Guru sir. Yes,
Yeah.
sir. I just wanted to ask Dr. Shreya or any one of the expert panel, what is the role of all those scores like McGill thyroid nodule score, where the three reported systems, they indicate the nature of this nodule and they characterize whether what is the probability of malignancy when the score increases for more than 19, for example, in that McGill node score. And what is the implication in real life scenario for this? Any experts, any comments on this?
Anyone wants to? I'm not sure what score you're talking about, Guru Charan.
So it's a McGill thyroid nodule score where they have seen the clinical parameters, the ultrasound and radiological parameters, as well as cytological parameters, and they reported the system into different scoring methods. And after giving scores for each of the points, they have taken lot of points and they characterize these Bethesda 3 and 4 nodules with the risk and probability of malignancy in these nodules with this particular score.
I think there are scores of publication as to how to evaluate a Bethesda 3 and 4 nodule because of the fact that because of the cost of all these molecular tests, and people are trying to assess ways and means to understand the risk of malignancy in these Bethesda 3 and 4 nodules. But I have not come across any guidelines, recommending that. It might be a publication which has seen certain things being useful for them, but it's not routinely practiced. But it's good to know that you brought this up. Maybe people can just go back and read. Dr. Arvind, you want to say something?
No, I just wanted to, in fact, I think I just wanted to say that Dr. Neha made some excellent points regarding molecular markers. I'm really impressed. Just wanted to understand, of the 4 markers you mentioned, Madam, P53 as well. I think you spoke about all other markers except P53. I just wanted to understand in clinical practice or how significant it would be P53 since you mentioned it in this context.
Thank you for that comment and the question. P53 is a marker of poorly differentiated thyroid carcinoma or high-grade differentiated thyroid carcinoma. So P53, as I said, these are the 2 acquired markers. So P53 may be acquired over and above BRAF or RAS mutation as another driver, especially in poorly differentiated thyroid carcinomas. Also, P53 mutation is commonly seen in oncocytic or previously known as Hurdle cell lesions. So these are the 2 areas where P53 mutation, but I didn't speak about it much because it's not a targetable, and we don't have evidence regarding what is to be done. Again, the treatment will be based on the histology of that lesion.
Right. Yes.
Oh, thank you.
Yeah. So there's one.
Shreya, I want to take your extensive knowledge about molecular because I'm always 10 steps ahead. The way now we have the guidelines, we should be having a clear picture where we should be putting our funds or where the research should go for a molecular markers. As far as I understand, to diagnose a cancer, we don't need it. But you are suspecting anaplastic or on FNSC anaplastic and medullary, we need the molecular markers. In between these 2, in a well-differentiated, we want to find out which are bad behaving or which are ugly or which are going to behave badly. That is where we need to do the molecular markers, right? Am I correct? I'm clear to you? Said for diagnosing whether it's a cancer or not, we are not ready. We should not put our money there. For anaplastic and undifferentiated and poorly differentiated, we should do it so that we can target which targeted agents will be used. That also we can go first hand, and we also can downstream them in a neoadjuvant setup. But in between these 2, the one which are going to behave, even though they are well differentiated, or maybe locally advanced, or they will fail us somewhere and revision surgeries will be required. That is where we should study the molecular marker. Am I correct in my statement? Just tell me that.
So
a must, not a must, and in between we should start.
Okay, so I'll try to answer your question. The thing is that your ATA guideline was last updated in 2015. Most of the molecular information regarding thyroid started from around 2016 or 2017. So basically, right now, what I will say is that we are at a stage where we have acquired the knowledge of how, which thyroid nodule, which type of thyroid cancer, is driven by which molecular abnormality. But as of now, we do not have the wisdom to use it in clinical practice. That will come with integration of studies with molecular as well as clinical findings, as well as Bethesda classification, and then seeing the outcome of the patients, whether studies which actually differentiate thyroid carcinoma patients based on molecular findings are very few. Plus, you all know that, if you start a study or PTC, maybe your next generation is only going to finish it. Even with those.
Yeah, that is why I'm saying, okay, we will not even put our money of 25,000 rupees also there. But where it is a must, we should give a message that in this group, see, there are two aims now: to increase to decrease the mortality and anaplastic and give them a decent life without complication, and to avoid the recurrences in a intermediate group where you fail after doing your primary treatments because you don't know the genetic landscape of that patient. So do you think that our country should be basically focusing on these two groups?
So as of now, I told which are the indications in which it is compulsory. Anaplastic thyroid, yes,
I said that anaplastic compulsory.
And definitely for any patient.
Papillary not required, but the ones which are going to behave badly, the intermediate.
Any patient who is willing to afford that much money, and you are going conservative with your surgery based on.
I'm not gone conservative. I've gone for total thyroid. I've gone for total thyroid, and I don't know how he's going to behave eventually because I don't have his genetic genetic.
Yeah.
You
So,
can,
ma'am, I think
based on the histology, you have
Right.
aggressive variants of PTC. You have to see which category that patient has been characterized on histology.
So I think there's no simple answer to this because it's pretty complex here. I think maybe
Or maybe we are
going
ready to
evolve.
In a good surgery done. If patient comes with some recurrence locally or this thing, these are the patient we presume that they are badly behave, and that's why we can do a genetic testing at that stage. I don't know. I'm widely thinking where we can just start and where we should be doing it so that we have a data also.
Yeah,
we have to
Dr.
create
Neha,
data, right?
Yes,
yeah, we have to create data, but then that has to be based on protocol. Dr. Neha, would you want to complete, as to where the, molecular testing for thyroid nodules in the evaluation can be done usefully? I'm sure it's easier said than done. Yeah, please go ahead.
So in the current guideline, if we see in pre-operative setting, it is done for Bethesda 3 and 4. So in Bethesda 3 or 4, now according to the 2023 Bethesda classification, molecular testing can be done in Bethesda 3 or 4 cytology directly, and you may not go the lobectomy way. But if I discuss this also has a regional split. I think Dr. Ratan made that comment, and I think that has happened. This is the policy which is followed in US. If we talk to anyone in US, any pathologist, this is what is being done absolutely in every single case in most of their centers. All Bethesda 3 and 4s are going for ThyroSeq version 3 or Afirma. So but if we come to Europe, this is not happening. Europe still.
MSKCC, even MSKCC doesn't do.
Yes, MSKCC doesn't do because they also they are also doing to a certain extent. It's not that they don't do, but yes, they also have a very strong thyroid pathology team. So Dr. Ronald Gosain and all are there, so they also follow age old processes of having Bethesda classification on this system. But even in US, most of the system thyroid cytology driven is the process. After thyroidectomy,
I think it is covered under insurance also, and patients are educated and demanding also.
Yes,
because it is covered by insurance, so the insurance pays for it. So that makes a lot of difference.
Yes,
right.
It must pay, but still, for patients out there, this is more expensive. And in fact, I read a beautiful study in which they've compared actually, and they've found out that 80% of the patients for whom it was done, it was not needed, and out out of the patients in which it was done, in 8 out of 10 patients, it overtreated. It led to overtreatment of those patients. You know, the preoperative molecular. So it is very important for the surgeon or the treating clinician to understand what will be the implication of the molecular information that they are trying to get.
I'm convinced that in India we are not ready for a preoperative setting. So that is what I made.
Yeah.
Right? From all this discussion, it is clear that we are not prepared for preoperative, even if it is available.
I think we are far away from that. There is lot of
now you come to the second point which you are talking about.
Yeah, Dr. Neha, please complete.
And affordability in our this thing becomes a very limiting factor. We have to choose patients very carefully.
Right, right. Great points. I think we just have 7 more minutes. And there was one question which Nina has been waiting patiently to make a point. Before that, there was one question on management of multifocal and multicentric PTCs, which will be dealt with in the subsequent talk. So I'm not going to venture into that. And Nina, if you would you want to make your point before we move ahead? Nina, would you want to say something? Okay, that hand has been lowered. Sorry about that. I think we didn't get time to talk in between. Neha, Dr. Neha, would you want to complete before we go to anyone else?
Yeah, just one point. I think Bethesda classification was being discussed that we should be reporting in Bethesda and TIRADS. I think reporting in that system is one step. The next step should be auditing the process. That is also very important, that you understand that your Bethesda 3s and 4s, what are they actually eventually turning out to be. And in the new classification in this regard, it does not suffice to just call it Bethesda 3 or ATP of uncertain significance. You have to give a comment that where is the focus of atypia. So if it is nuclear atypia that the nuclear atypia has to be specifically to turn out to be malignant later on. So degree and area of atypia has to be specified.
Right. Great, great points, Dr. Neha. Any other, panelists, expert panel wants to make any other comments before we wind up? So I just would like to, go back to my, concluding slide as well. And that is what we would again like to reiterate and conclude, is that a thorough clinical history and evaluation need to be part of the evaluation of a solitary thyroid nodule. Documentation of the vocal cord status is very important, especially medico-legally and even clinically. Nodules more than 1 centimeter in size with high intermediate suspicion needs to undergo an FNA. FNA needs to be done by image guidance and reported by Bethesda system. Also, the ultrasound finding needs to be reported in a synoptic template using Thyroid system. Serum TSH needs to be done to assess thyroid status, and only if it is hyperthyroid status do we need to do a radionuclide scan. Otherwise, it's not routinely done. PET scan should not be routinely done. And evaluation of Bethesda 3 and 4 nodules using molecular markers is not recommended in the Indian COSTEC, as we have discussed elaborately now, and it can be considered in a protocol setting, and we need to know what the risk of malignancy in your particular settings that are there. So with that, I would like to wind up this session. I would like to thank all the expert panels, panelists, Dr. Neha, Dr. Arvind, Gurucharan, Ratan, and Dr. Shreya and Dr. Jyoti Madam for their inputs. And I would like to thank Azim for the opportunity. Thank you. Over to you, Azim.
So now we'll move on to the next session. The next session is surgery for locally advanced thyroid cancer. The speaker for the session is Dr. Abhishek Vaidya. Sir is Senior Consultant Head Neck Surgery at National Cancer Institute, Nagpur. The session experts are Dr. Devendra Chaukar. Sir is Director of Head Neck Surgical Oncology at Nanavati Max Hospital, Mumbai. Dr. Deepa Nair. Madam is Professor Head Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. Dr. Ashok Das could not join us. Dr. Sarbani Ghosh Laskar. Madam is Professor in Radiation Oncology at Tata Memorial Hospital, Mumbai. Dr. Shreya Shukla, Assistant Professor Radiology at MPMMCC Varanasi. And Dr. Ipshita Dhal. Dr. Ipshita is Associate Professor in Pathology at MPMMCC Varanasi. So Dr. Abhishek Vaidya, over to you.
Thank you very much. I'll just share my slides right away. Right. Is my screen visible?
Yes, yes, it is visible.
And can I be heard well?
Yes, yes.
All right. So once again, thank you to the entire team of MPMMC. Thank you to Asim, Komal for this wonderful get-together that you've academic thing that you've arranged based upon the launch and the introduction of the ISTS guidelines. And we divided the guidelines into several chapters, and the chapters which have dealt with our treatment of advanced thyroid cancers and management of NEC. So the agenda for today is treatment of advanced thyroid cancers, and I've taken the liberty to remove that from surgery for advanced thyroid cancers. From that, I've just kept it treatment for advanced thyroid cancers. So these are the session experts. We have 3 surgeons. I believe Dr. Ashok Das hasn't been able to join. We have a radiation oncologist. We are going to speak to all of them later. We have Dr. Ipsita Dhal, who's a pathologist from MPMMC, Dr. Shreya Shukla, who's a radiologist from MPMMC. In surgeons, we have Dr. Devendra Chaugar, Dr. Deepa Nair. Dr. Chaugar is ex-professor and head of TMH currently at Max Cancer Center, Mumbai. And Dr. Deepa Nair is professor at TMH, Mumbai. And Dr. Sarvani Ghoslaskar is a professor of radiation oncology at TMH, Mumbai. So there we go. To begin, we know that the incidence of thyroid cancers is on the world, is on the rise the world over. I mean, this has been dealt by amply. Most of them are differentiated thyroid cancers. Most have excellent prognosis. However, locally invasive disease will be seen in about 15% of these DTCs, and it portends a worse prognosis. Locally invasive disease is seen more commonly in other subtypes, such as medullary carcinoma, where extrathyroidal extension may be seen in 1/3, and up to 2/3 may have heavy nodal burden. Anaplastic carcinomas are rare, but they're all locoregionally advanced. So locoregionally advanced tumor is like the crouching tiger who's heading to, who's about to strike you. But in this talk, we are mainly dealing with locally invasive thyroid cancer of the differentiated thyroid cancer type. And this was the ISTS guidelines chapter, surgery for LATC. So the methodology has been already been dealt with by Dr. Dabolkar, but nevertheless, here it is. All authors began with a narrative review. I referred to the guidelines of ATA, NCCN, American Head and Neck Society, which has a specific guideline for locally advanced thyroid cancer, and the BTA. We also searched Google and PubMed for pertinent literature and classified this according to levels of evidence. We had several online meetings where consensus was drawn. Pertinent clinical questions were then framed, and consensus guideline was given as answer to these. So what were these questions? These questions are: what constitutes locally advanced thyroid cancer, and what is the problem statement? What is the appropriate preoperative evaluation of locally advanced thyroid cancers? What is the goal of surgery? What is the surgical approach to the involved recurrent laryngeal nerve? Is there a role of intraoperative nerve monitoring during surgery for locally advanced thyroid cancers? What is the surgical approach to tracheal, laryngeal, or esophageal involvement in locally advanced thyroid cancers? And what is the role of adjuvant therapy following surgery in locally advanced thyroid cancer? So this adjuvant therapy, we briefly mentioned adjuvant radioiodine, but that is a part of some other panel. So we'll discuss about adjuvant RT here. And finally, is there any role of neoadjuvant therapy in locally advanced thyroid cancers? So let's tackle all of these points one by one. Firstly, what is the definition of locally advanced disease? So unfortunately, there is no exact definition. Most texts consider locally advanced or invasive as something which is invaded the thyroid capsule and into the surrounding structures. So following features may be considered: extrathyroidal extension, which may be into the strap muscles, recurrent laryngeal nerve, trachea, and esophagus. And there are some texts which consider heavy nodal burden in the central or in the lateral compartments, also a part of locally advanced disease, but this definition is not routinely or uniformly accepted. So extrathyroidal extension may be minor, which may be into the strap muscles, soft tissues, or recurrent laryngeal nerve, or major, which is into the trachea, larynx, and esophagus. And just how common is this? So most of the data comes from the West. Extrathyroidal extension into muscles and soft tissue is by far the commonest. and accounts for 2/3 of all LATC. Recurrent laryngeal nerve involvement accounts for about 1/3 to half of all LATCs. Tracheal involvement accounts for about 1/5 to 1/3 of LATCs. Involvement of the larynx and esophagus is less common, accounting for just about 10%. Indian data is similar, and we saw two papers who had brief mention of this. One of them is from Orissa, the first one, which said that the laryngotracheal invasion in PTCs was to the tune of 10%. The other paper, which is from TMH, which mentioned about extended thyroidectomies, that was for locally invasive cancers, which accounted for 11% of all thyroidectomies. So this is quite similar to the 13 to 15% prevalence of invasive thyroid disease that we have in world literature. So let's move on to preoperative evaluation. We know that the thyroid nodules come in all kinds and shapes. So it is very important to have a high index of suspicion and raise the red flag whenever you see the following: extremes of age, rapidly growing nodule, long-standing goiter with a sudden increase in size, compressive symptoms in the form of dysphonia, dyspnea, or dysphagia, any nodule which is very hard in consistency or fixed to the adjacent structures, vocal cord palsy, and therefore do a pre-op laryngoscopy in everyone, and associated lymph nodes. So if you look at preoperative laryngoscopy, and this is what Shiv also mentioned, that is absolutely mandatory in all cases of thyroid cancers. There are some points behind it. This is the most robust marker for invasive disease, and 70% in locally invasive is involved versus only 0.3% of palsy in benign. So that's the huge difference that you will get in benign versus a malignant based upon one single finding. Moreover, 1/3 of the patients with unilateral vocal cord palsy are asymptomatic, so they will be detected only when you do a laryngoscopy. Further, asymptomatic fixed vocal cord may go undiagnosed, as I say, because they are 1/3 will be asymptomatic unless you do a laryngoscopy. So ideally, this is to be done with a flexible laryngoscopy, but you can also do it with a Hopkins rod telescopy or even with an indirect laryngoscopy mirror. Nevertheless, what you use, it is an absolutely mandatory step. How about imaging? Ultrasonography is basic, but when in the slightest of doubts, do a CT scan. So CT scan is recommended for retrosternal extension to know the relation to adjacent structures, larynx, trachea, and esophagus, to assess palpable and impalpable cervical adenopathy, for tracheal invasion, and also for distant metastatic deposits. Now, disclaimer, though we haven't included this in the guidelines, I personally prefer a cross-sectional imaging in all cases of CA thyroid, and maybe I'll ask the experts what they feel about it a little later in this discussion, or maybe any one of you can chip in now. Would you do cross-sectional imaging in all of your carcinoma thyroid cases? Maybe Dr. Chaukar or Dr. Deepa Madam can answer that.
Yeah, hi, Abhishek, can you hear me?
Yes.
Yeah, so no, not all. If you have those small thyroids which are either incidentally detected or moving well, and there is no absolute indication of, or there's no indication that it is going to be locally invasive, or there's no. So then for that, we don't do a CT scan. But if they are the gross nodal disease or there's a large thyroid, if there's a little retrosternal extension, even for a goiter with retrosternal extension, we'll get a CT scan. But yes, I agree with you. The threshold for a CT scan nowadays is slightly lower than what it was earlier, but not all comers.
Perfect. So I think this is which is also reflected in the guidelines. You do a CT scan only when you have symptoms or signs of invasion. So how about tracheal assessment? For suspected cases where there is tracheal involvement, you do a contrast enhanced CT with a multiplanar reconstruction and a virtual bronchoscopy, or you do a flexible tracheobronchoscopy to assess disease which has an intratracheal intraluminal component. So for each of these sections, I'm first going to enumerate the evidence and then what our guidelines say in specific. Other investigations, MRI is complementary to CT, and you would do it only when you have suspected laryngeal invasion. And just to answer that query, if there is early involvement of the larynx, you would do an MRI. Upper GI scopy is to be done for suspected esophageal invasion. PET CT scan, as Shiv also mentioned, is not recommended. There is, however, a caveat in locally advanced thyroid cases. You might do this to rule out dedifferentiation in very advanced thyroids or in elderly people. So if you look at the guidelines of the ISTS regarding preoperative evaluation, preoperative laryngoscopy should be done in all cases, and especially in those with compressive symptoms. Cross-sectional imaging of the neck and chest, which is CT or MRI scan with IV contrast, is recommended only in cases of suspected local invasion, compressive symptoms, bulky nodal disease, or retrosternal extension. If there are preoperative symptoms, which suggests laryngotracheal invasion, or if the preoperative imaging raises suspicion of laryngotracheal invasion, then a flexible endoscopic evaluation of the larynx and the trachea must be done preoperatively. If there are preoperative symptoms or imaging suggestive of pharyngeal or esophageal invasion, a flexible esophagoscopy or an endoscopic USG may be considered. And these are the important guidelines regarding the preoperative evaluation. We now move into locally advanced disease. Before we move on to individual subsites, let's see how do they fare in general. And this is a relatively recent data from MSKCC. So if you look at 10-year disease-free survival, and they've divided into 3 types. When there was no macroscopic ETE, only microscopic extrathyroidal extension. When there was microscopic extrathyroidal extension involving the straps alone, that is minor, or major ETE. And if you look at these percentages, only microscopic ETE or minor macroscopic ETE did not have much impact on survival, but only when the ETE was major did it have any impact on disease-free survival. Mind you, this is an impact only on disease-free survival. Most of locally advanced thyroid cancers do not have an impact on overall survival, the only exception being that of tracheal invasion. Okay, so we now move on to locally advanced involvement. The tumor is involving the recurrent laryngeal nerve. So recurrent laryngeal nerve involvement, as I said, accounts for about 1/3 to 2/3 of all cases of locally advanced thyroid cancers. Most importantly, 1/3 of these may be asymptomatic. So the important factors which are to be taken into consideration are: what are the pre-op symptoms and the pre-op laryngeal function? What is the degree of nerve invasion, location of nerve invasion? Is there contralateral disease? Are there any patient preferences regarding his voice? Adjuvant treatment options available? And the IONM analysis. And we are going to factor all of these as we go ahead. A lot of decision-making that we do regarding the involvement of the recurrent laryngeal nerve comes from these 2 important papers, one from Japan, the Nishida et al. Group, and from the Mayo Clinic, which is the McAfee. So what both of these found was that if there is a preoperatively functioning nerve and the nerve was found to be involved at surgery, there is no difference in survival between nerve resection and preservation, provided patients receive post-op radioactive. So as long as the nerves were preoperatively functioning and as long as they received post-operative radioiodine, there was no difference in survival whether you resected or preserved the nerve. So that's the data. No difference in survival between the 2 groups and no locoregional failure due to preservation of the nerve. So this has found way into most of the guidelines. And one of the guidelines that we specifically looked at, the ATA unfortunately does not have a dedicated segment for locally advanced thyroid disease. So when we set out to compare ATA versus ISTS, we really could not fill up the tables because ATA does not specifically deal with locally advanced thyroid cancers. Nevertheless, we have compared this with the AHNS consensus statement, and 3 distinct scenarios may emerge. When the recurrent laryngeal nerve is encased by tumor, if the ipsilateral cord is paretic or paralyzed, then resect the nerve. If the contralateral cord is paretic or paralyzed, then resecting the nerve would obviously lead to catastrophic issue and may lead to tracheostomy, so spare the nerve. And as said, if the cord was mobile pre-op, then spare the nerve. If the RLN is minimally adherent, then dissect around the RLN. You can let there be minimal crummy tissue on the nerve and preserve the nerve. So this is found way into the ISTS guidelines, and this is what we say about recurrent laryngeal nerve involvement. When there is bilateral normal vocal cord functions preoperatively and intraoperatively, recurrent laryngeal nerve is minimally adherent to the tumor, not invading or encasing, just minimally adherent, always preserve the recurrent laryngeal nerve. when there is preoperative vocal cord palsy and intraoperatively recurrent laryngeal nerve is encased by tumor, recurrent laryngeal nerve sacrifice may be considered. Now, there is a recent caveat to this. I'm going to once again get the surgeons in on this. Some say that if you are using an IONM, and even if the preoperative vocal cord was palsied, but if the involved nerve shows signals, then you should still try to preserve the nerve. Dr. Deepa, Dr. Ashok Das, Dr. Devendra Chopra, if you could just come and chip in on this.
So Abhishek, good afternoon. Deepa here.
Yeah.
The palsy, there is some interesting data. Hello, can you hear me?
Yeah, barely, but we can.
Yeah, so there's some interesting data coming out in some small series retrospective of yours, which shows that sometimes this nerve entrapment may lead to some preoperative vocal cord palsy, but release of that entrapment during the surgery by either dissecting the lobe or releasing something which has entrapped the nerve, like a vessel or something, or a clip in revision surgeries, may lead to return of function of the nerve. I personally have not seen that happening, but there is a thought process to this. And there's a group in Serbia which actually talks about exploring cases and releasing this entrapment and having some amount, 50% of cases having return of function. So there is some data suggesting that.
Right. So the important caveat here is that if your IONM intraoperatively shows some activity, only then you should preserve a preoperatively palsied nerve. Otherwise, for all practical purposes, whenever there is a preoperative vocal cord palsy and intraoperatively the nerve is encased by tumor, you sacrifice it. When there is bilateral normal vocal cord function preoperatively, but at surgery you find that the nerve is encased by tumor, the tumor should be shaved off and the recurrent laryngeal nerve should be spared as long as there is no gross residual tumor. If you're leaving behind gross residual tumor, you should consider sacrificing the nerve. This is once again a considered guideline. If a functioning encased nerve is the only site of gross residual disease, which is R+, and it is not possible to shave off the disease, then as I said, consider nerve sacrifice with primary nerve repair. So if you're able to shave off most of the gross tumor, preserve. If you're not able to shave off most of the gross tumor and you have gross tumor left behind, which is R+ resection, and if this R+ is the only site of gross residual disease, only then you should consider a nerve sacrifice. If you've done a nerve sacrifice, you should do a primary nerve repair. The next guideline is whenever there is contralateral vocal cord palsy preoperatively and intraoperatively, the ipsilateral recurrent laryngeal nerve is encased by tumor, the tumor should be shaved off and recurrent laryngeal nerve be spared. Obviously, you have to make informed decision making with the patients, and if there is gross residual, then you might take the patient's opinion and advice whether he would want that recurrent laryngeal nerve resected, a temporary tracheostomy, and later a lateralization procedure of the cord. Whenever you resect the nerve, you should always attempt some kind of reconstruction. It should be an immediate reconstruction. There are several ways to do immediate reconstruction. When stumps are available, you can do an end-to-end anastomosis. If stumps are not available, you can do a cable graft, or you can do anastomosis to ANSA or vagus, which may be selective or non-selective. Too much details, too much for this talk. But especially in the elderly, also consider a medialization procedure such as a thyroplasty or an injection laryngoplasty, because the effect of the nerve reconstruction may take a little bit to come back. So the ISTS guidelines regarding the recurrent laryngeal nerve continued. Whenever nerve is sacrificed, an attempt should be made to repair or reconstruct the sacrificed recurrent laryngeal nerve. The options include end-to-end anastomosis, cable graft, or an ANSA to RLN anastomosis. No method has been shown superior to another. We just showed that in the previous slide. If the contents are near, do an end-to-end anastomosis. If the contents are far, you can do a cable graft, which can be ANSA or greater auricular nerve. ANSA cervicalis to recurrent laryngeal nerve anastomosis or vagus to recurrent laryngeal anastomosis, which is selective or non-selective reinnervations, can be done. And in the elderly, consider an immediate medialization thyroplasty to decrease the risk of aspiration. So that's the algorithm in brief. We'll begin from the left-hand side. If the recurrent laryngeal nerve is encased or invaded, preoperatively ipsilateral vocal cord palsy, resect the nerve. And reconstruct. The central column, if there is preoperatively bilateral vocal cord mobile, then you have two situations. If shaving is possible and if shaving is not possible. If shaving is not possible, or if there is gross residual disease left behind on the nerve, and if the encased nerve is the only site of R plus resection, resect the nerve. If shaving is not possible, but there are also other sites of R plus resection, you would do no good by resecting the nerve. You should consider shaving as much as possible and preserve this nerve. Second column, bilateral vocal cords mobile, still onto that column, but shaving off is possible, then of course you should shave and preserve the nerve. And needless to say, if there is bilateral or contralateral vocal cord palsy, then you should shave and preserve the recurrent laryngeal nerve so as to avoid the disastrous complication of a tracheostomy. So about intraoperative nerve monitoring, I think Dr. Anuja is here, and she had written this very detailed article on the use of intraoperative nerve monitoring, and she recommends intraoperative nerve monitoring in locally advanced thyroid cancers. So as given in the guidelines of ISTS, IONM helps in identifying the nerve in distorted anatomy. It can provide prognostic information about the functional status of the nerve during and after the removal of tumor during surgery. It can also help when not to guide, and we've already raised that point. Dr. Deepa spoke about that. Despite these advantages, the utility of IONM in the Indian scenario is restricted by its cost and limited availability, and therefore we recommend that IONM is desirable, though not mandatory, to have as an adjunct in surgery for locally advanced thyroid cancers. However, it cannot replace the anatomical identification of nerve and careful surgical techniques. Dr. Deepa, Dr. Devendra, sir, do you want to come in on this? We have said that IONM is desirable, though not mandatory for LADCs.
Well, I think, Abhishek, you complete your talk and then we'll discuss all these points once we get to the discussion.
So as regards to locally advanced tracheal involvement, this occurs in 1/3 of the patients with thyroid cancers. However, intraluminal disease is rare, and tracheal invasion, especially the intraluminal disease, is the only thing which has an impact on survival. There are 4 stages according to the Shin and Grillo's classification. Stage 1 is when the tumor is abutting the external perichondrium of the trachea but does not extend into the trachea. That's stage 1. Stage 2 is when the tumor invades the rings of the trachea or invades the tracheal cartilage but has not lifted the lamina propria. Stage 3 is when the tumor has extended into the lamina propria of the tracheal mucosa without mucosal invasion. And stage 4 is when there is gross intraluminal tumor, when the mucosa has been destroyed or elevated. And these are different kinds of surgical options which are available depending upon what is the stage of the Shin stage. The first one is shaving. You do an extraluminal tangential excision. Second is a wedge or a window or a resection. This has to be reconstructed with a flap. And the third is a circumferential resection or a full thickness resection with a primary end-to-end anastomosis. So which do you do when? And this once again comes from guidelines from the McAfee data. They compared survival of complete resection versus shave resection with microscopic residual disease or gross residual disease. So as long as the preoperative disease was Shin 1 and shave resection was done, there was no difference in survival. Similar data come from the Nishida group, and they found that in Shin 1, in patients who underwent shave procedure, there was no difference in local or regional recurrence with or without shave resection versus circumferential resections. Whereas for Shin 2 or more, there was a much higher rate of recurrence. And this was like really significant, 79% versus 8%, and also a decrease in the mean overall survival when less than a circumferential resection was done. So this has been incorporated into the ISTS guidelines. For superficial tracheal invasion, Shin 1, a shave resection can be done. For Shin 2 and above, where there is deep or intraluminal extension, full thickness resection needs to be done to ensure safe margins. Now, whenever we are saying a full thickness resection, this may be either be a window or wedge resection, but this is to be done only for a small length of tracheal invasion. and a small part of the circumference is involved. Circumferential resection with end-to-end airway anastomosis gives better margins, and it is better for intraluminal tracheal disease involving greater lengths or almost the entire circumference. Let's move on to laryngeal involvement. Both laryngeal and esophageal involvement are rare, only seen about 10 to 15% of all LATCs. Management has to be individualized. If there is cartilage invasion, you can do a partial laryngectomy. And partial laryngectomy will be possible in about in 50% of the patients whenever there is only superficial cartilage invasion. Total laryngectomy is to be done for airway obstruction, luminal hemorrhage, intraluminal invasion, or lack of laryngeal function. So once again, in the ISTS guidelines, we have kind of encompassed this as shave procedures should be done only when the lesion is abutting and not invading the laryngeal cartilages. Partial laryngectomy may be done for invasion of the laryngeal cartilages when the disease is lateralized. And total laryngectomy is to be done whenever there is intralaryngeal involvement across midline or cricoid involvement or intraluminal hemorrhage. Let's move on to locally advanced esophagus. The options are excision of the muscular wall, partial esophagectomy with or without laryngectomy, or you might go the whole hog and do a gastric pull-up or jejunum flap. Now, the thing is that in most of the cases, the esophageal involvement is restricted to the muscularis only, and you would do well just by excision of the muscular wall. So this is reflected once again in our ISTS guidelines. Most commonly, esophageal involvement is restricted to the muscularis, and excision of muscularis of the affected segment is all that needs to be done. Esophageal luminal mucosal involvement is rare, but requires to be treated with partial esophagectomy, partial or total esophagectomy, and reconstruction. We now move on to vascular involvement. We'll straight away move to the guidelines of the ISTS. Most commonly involved is IJV. Usually, IJV involvement occurs due to bulky nodal disease. Occasionally, there may be a tumor thrombus extending directly from the tumor into the IJV and into the mediastinal major veins. Carotid is less commonly involved, but this may occur due to central compartment nodes or by the gland itself. If there is a single IJV involvement, it can be resected without any major issue by the resecting surgeon himself. For bilateral major vein resection or tumor thrombus in a major vein, especially in an intrathoracic vein or carotid involvement, resection has to be planned with reconstruction, and it is desirable to have a vascular surgeon standby in such cases. This does not become a criteria for unresectability. Rather, a vascular surgeon with reconstruction is to be arranged for. We now move on to the role of adjuvant therapy. The role of EBRT is less well established in locally advanced thyroid cancer, and we'll come to this discussion at the end of my talk. The current usage and recommendations for EBRT is based upon a few retrospective studies. I picked up the largest retrospective study, which is 1297 patients, and it showed that when EBRT was added to RAI for T4A papillary thyroid carcinomas, it led to a better locoregional free disease survival, disease-free specific survival, and recurrence-free survival. Now, this has also been reflected in the AHNS consensus statement, which recommends EBRT in select patients above 45 years of age, which have a high likelihood of microscopic residual disease and a low likelihood of responding to radioactive iodine, especially those with gross extrathyroidal extension, poorly differentiated histology, or revision surgery for persistent tumor or recurrent disease. So the ISTS guidelines say that patients with LADC should receive high-dose adjuvant radioiodine, and this is to be dealt into a completely different part of this workshop today. So we'll deal with that later. But adjuvant EBRT may be considered in addition to radioactive iodine for patients with LADC, with gross residual disease which was left behind, or poorly differentiated histology. The next point is neoadjuvant therapies. There are several neoadjuvant approaches which have been tried so far. Most of them have not been useful. There has been recent interest in the usage of TKIs or multikinase inhibitors, and we'll briefly mention that. So this came in the form of two important trials, both of which use TKIs not in the neoadjuvant setting, but in a adjuvant radioactive iodine refractory setting. This is the first trial, decision trial, which used sorafenib And it showed that the progression-free survival was 10.8 months with sorafenib as compared to 5.8 months with placebo, and this was statistically significant. The more promising drug was lenvatinib select trial, which showed a very impressive PFS of 18.3 months with lenvatinib versus 3.6 with placebo in RAI refractory recurrent or residual thyroid cancers. Now, this robust activity of lenvatinib has prompted its use as neoadjuvant chemotherapy, and there are only small trials which have until now come to the fore. So based on this, the guidelines recommend that there is limited or no role for conventional chemotherapy in neoadjuvant setting in locally advanced thyroid cancers. As regards to TKIs and lenvatinib in particular, there is emerging role, but currently to be used only in trial settings. We are now moving to two topics which are not part of the guidelines. Nevertheless, we'll quickly go through them and then we'll open the house for discussion. The first of them is stage surgery, and this comes from the publication by Randolph et al. And they would consider staging the surgery if there is an intraoperative loss of signal in during intraoperative nerve monitoring, or if there is an extensive locoregional disease such that R1 resection, such that R0 or R1 resection is not possible and requires an R plus resection, so that you would stage the disease or use a neoadjuvant lenvatinib. There is also emerging role for palliative tracheal stenting in patients who have extensive tracheal invasion, who are not candidates for surgery or are unwilling for surgery. So these were the two things which are not included in the guideline section. So to conclude, advanced thyroid cancers are a challenging part of thyroid surgery. Optimum pre-op evaluation is must. Surgery remains the mainstay. Some of the goals of surgery are preserve recurrent laryngeal nerve whenever possible. If recurrent laryngeal nerve is resected, it has to be reconstructed. Intraluminal intratracheal invasion is rare, but this demands a circumferential resection. Esophagus involvement usually only requires muscular excision. Whenever larynx is involved, if it is only abutting, you could do away with partial procedures. IONM is recommended in advanced or recurrent settings. Staging surgery is an option which is coming more frequently in literature. And neoadjuvant TKIs are on the anvil, but currently should be used only in the trial setting. So thank you so much. That concludes my talk, and maybe we can have all the session experts here to briefly comment on some of the points here, and then we can move to specific cases.
Right. Abhishek, great talk. Devendra here. Can you hear me? Hello?
Yes, Devendra, we can hear you.
Right. So
can hear you, sir. Can hear you.
Yeah. So Abhishek, great talk. You covered the topic very well. So my first, let me start with investigations, and you covered them well. You said CT scan for locally advanced thyroid cancer, cross-sectional CT scan. Sometimes when there is tracheoesophageal involvement or TO groove involvement, and you're suspecting esophageal involvement, MRI is a good additional modality to look at esophageal involvement. If you don't have esophagoscopy or EUS, so more than esophagoscopy, Abhishek, we use EUS, which tells us the extent of involvement into which layers of the esophagus and how much you need to excise and what would be your plan for excision. So EUS is a good modality. If you don't have that, then MRI is a good modality for esophageal involvement, better than a CT scan. Yes, so two things. MRI.
So can I make a comment here just because you are on a CT scan, Devendra?
Sure.
Yeah, so the another indication which is very important is the central neck nodes. CT will be definitely superior. Ultrasonography cannot pick up the central nodes very efficiently because the thyroid is in situ. And if you really want to know preoperatively high-end patient, or you want to just have idea about central neck nodes, central neck compartment nodes, I think CT should be supplemented to USG. You have a better idea preoperatively.
Right. So Abhishek, and to complete my investigations, we always do when there is tracheal abutment by the tumor on CT, we do a bronchoscopy to see whether there is, lifting of the mucosa or there is intraluminal extension. So bronchoscopy, oscopy, plus minus EUS. If you don't have that EUS, then do an MRI to see esophageal involvement. So that's the investigations that we do.
Perfect, sir. We mentioned EUS. We were also cognizant of the fact that EUS may not be available everywhere, and that is the reason why we mentioned esophagoscopy as well.
That's right.
Yeah. Can I have more comments? Yes.
Abhishek, can I make a comment here?
Yes, ma'am.
There is, I think you have referred in the chapter in the guidelines, you've referred to external beam radiotherapy very sparsely. And I think that's one of the reasons because of the recent publications as well as because of the availability of targeted therapies and immunotherapy. I think the use of external beam radiotherapy in the West has gone down. And also because of the fact that we don't have any level 1 evidence. We have systematic reviews which have actually got all kinds of mixed studies. People do not make use of external beam radiotherapy. And of course, as a radiation oncologist, I would also refer to my surgeons about when I would want to use external beam radiotherapy. But having said that, I would also like to say in the locally advanced thyroid cancers, as per the ATA guidelines as well as the AHNS guidelines, I think the important role for external beam radiotherapy is in those elderly patients where you've done whatever surgery you could possibly have done. You've removed the nodes, you've resected the primary disease, but at the same time, perhaps your limit for going back in again may be restricted, as well as these may not be good candidates for any of the molecular therapies or targeted therapies. That is one area. And definitely the involvement of the upper aerodigestive tract, especially the trachea. There is evidence to suggest that possibly you should use external beam radiotherapy to prevent the disease from coming back locally. We all understand that external beam radiotherapy essentially is a loco-regional modality of treatment. It will not do anything to the overall survival, but definitely it will improve loco-regional controls. Having said that, I'm sure I also as a radiation oncologist will not jump in to treat a patient, especially a young patient with a differentiated thyroid cancer, unless there is a very high chance that this patient may have a radioiodine refractory disease or the ability to concentrate iodine is going to be poor. Only in that case will I jump in. But for the elderly, we should keep this at the back of our minds, and definitely with the involvement of the tracheoesophageal tree, and especially if the disease is going into the tracheoesophageal groove, that even the surgeon may find it consequentially difficult or subsequently difficult to go in. I think external beam radiotherapy should be kept in mind. The other place where we may have a role to play is in those elderly people above 45 years of age, where you have a high burden of central compartment disease. And if for whatever reason you see that there is no radioactive iodine avidity. So these are the instances where I would think that even today, with the availability of systemic agents, we should think of external beam radiotherapy. And I think that is one part that needs to be covered. And the other thing is, when you talk about the role of external beam radiotherapy for gross residual disease, there is mixed literature. We really do not know how effective external beam radiotherapy is in that particular situation. And especially today, because I've done it, it's not that I've not done it, but we are not very effective when there is gross residual disease. It may be better to do an R1 or just, minimal disease left off at the trachea and things like that, rather than to have an R2 disease with gross disease. So these are my comments for the advanced differentiated thyroids. And of course, you also have the instance of adverse histologies, which again cause for a lot of, Neha may be able to tell you about it, because these adverse histologies, different publications again tell you what should be the proportion of the tall cell variant, and not all tall cell variants are bad. So all these things have to be kept in mind when you're considering external beam radiotherapy for differentiated thyroid cancers. And of course, for PDTCs, you may consider it even with radioactive iodine. So these are my comments. Thank you.
Yeah, thank you, ma'am. Ma'am, we know that you have a trial accruing regarding
Yeah, exactly.
the use
Sorry, I
of.
forgot about it.
Yep.
Yeah, so we have the Thyroid study. We've completed accrual of the patients, and because it's a thyroid cancer study, of course, we are going to be we still have to wait for some more time before we can publish the results. Gauri is the PI, and in that we've talked about locally advanced disease as being the T3, T4s, as well as patients who've got advanced extra what you call central compartment disease with extranodal extension. So, classically in the thyroid, as against other head and neck squamous carcinomas, we really never talk about the lateral compartment, because classically these are disease that can be resected. You have fallback therapy with radioactive iodine and things like that. But the situations that I spoke about are essentially the places where you should definitely keep external beam radiotherapy in mind, because today we are again treating with very conformal modalities of treatment, and toxicity levels are much lower than what have been reported in the past. Thank you. And
So
I
in a
think you made
nutshell,
the
would you
presentation.
add to these recommendations for adjuvant EBRD?
I just don't like the loose terminology used about gross residual disease.
Okay.
I would rather have you specify there where in the adjuvant setting would you use you definitely use adjuvant radiation therapy, and that's essentially with involvement of the upper brachioesophageal group. Then you have this group which has a low propensity for radioactive iodine avidity, and so these and the central compartment lymph node disease. If you want, I could write up this thing and send it to you as a small thing, madam. I actually have to congratulate Dr. Jyoti Dabolkar and the entire team led by her to bring out this manuscript. But I would also like to suggest that we improve the indications for adjuvant.
I wish,
we'll bring that out as an addendum.
since the role of EBRT was small, I wish I had asked you to go through this chapter where EBRT was mentioned. I think probably we could have improved it further. But nevertheless, Sharbani, there is always a revision is going to happen.
Yeah.
So please, your comments will
We'll
definitely
just
be
put it
included.
together and give it to you, madam, because
Absolutely,
I
absolutely, absolutely.
little more
Wherever.
specific. Yeah.
Not in this chapter, but wherever, even in anaplastic and all that. You please read carefully and keep your comments ready.
Yeah, sure, madam. Because the other thing that I have to say, of course, anaplastic is another side, PDTC is another indication, and also the adverse variants, we have to take them with a pinch of salt. And I wish there was more data available about the correlation between the adverse molecular markers, like what you call BRAF and TERT, with the use of adjuvant radiotherapy, but we don't have that data in literature. So that's one thing, especially for the differentiated thyroid cancers. I'm not talking about MTCs now. Thank you.
Thank you.
Okay.
Lovely.
All right. Any other comments, if we can have? Are there any questions in the chat?
Abhishek?
Yes.
I already did a little brainstorming in the previous session of Shiva.
Yeah.
That, we cannot just completely brushed away the molecular markers role. My question to the pathologists on the panel and all the seniors, whoever is,
yeah, ma'am,
can
I just
we,
have a
at the first bad behavior of the cancer, like it is done well, total thyroid and all, everything was done, and RAI was given, and if the cancer fails and it comes back in a short time or whatever, are these the situation where we must make it a point that molecular testing has to be done at that stage at least?
Okay, so maybe Dr. Ipsita, if you can take that, or Dr. Neha. Quick,
So
and
that
then
we
we
know
have a race. Yeah,
so
yeah,
we
ma'am.
know-
We got your question. I'll ask one of them to answer, and then I have a few case scenarios. So we have about 20 minutes left. We'll quickly go through them.
please show your
Ipsita,
case scenario.
Dr. Ipsita, do you want to take that? Okay. Maybe we'll take that as a comment later. Dr. Shreya, do you have something to say?
Yes, sir. Thank you so much for your talk, sir. There's just a little question that I wanted to raise. So, I wanted to ask that we talk about the depth of tracheal invasion, and we take it as a responsibility to very categorically mention it in our reports. But there is not much discussion about the length of tracheal involvement. So of course, it makes a major change in your management plan. So if you could just throw some light on that, we would take that more as an important section in our reports then, the length of tracheal involvement.
Okay, so we've included that in the guidelines when we say that we will do, obviously, when there is a superficial level of tracheal involvement, which is a depth, then you would do a shave resection. When there is a deeper, you would do a more complete resection. So that resection may be a window or a wedge resection or a circumferential resection and anastomosis. So we've dealt with that part in the guidelines. We say that window resections are to be done only for small lengths. We haven't quantified that. We haven't qualified that. But that is about it. Maybe one of the surgeons can answer that. And
Abhishek, if I may.
Yes.
So, Shreya, to answer your question, the problem with the CT estimation of tracheal involvement is always there's a slight overestimation, and especially when it is shin 2, shin 3, there's always a slight overestimation. So, it's a good point. When you have a shin 1 or a shin 4, generally there's not so much of a problem clinically because shin 4 is intraluminal, and that's what we see during surgery. I mean, during the bronchoscopy as well. Shin 2 and 3 are something which are very, I think, fluid. And something which you call shin 3 may end up actually having only a very small component because most of the times these tumors are adherent to the tracheal wall but can be shaved off very easily. And actual cartilage involvement is on a very small area. So I think there's a bit of a problem in terms of the overestimation of the involvement of the trachea on imaging. But I'm not sure giving a length of that involvement may benefit us extremely during surgery because we still go based by our intraoperative findings. That said, if you have a long length of tracheal segment, especially which is intraclavicular, we would avoid surgery in such cases because we know that it will not be a safe resection anastomosis in those cases.
So Deepa, Devendra here. So I have a little different view. Shreya, you said correctly that, apart from the depth, and Deepa, I agree with you, sometimes that can be over or underestimated on CT, but you must count the rings of trachea that you feel are involved. And these are assessed by two ways. One is your CT or MRI or a cross-sectional imaging, and second is the bronchoscopy. Preoperative knowledge of the length of tracheal involvement is important because that will decide how many tracheal rings you can excise and do a primary anastomosis. So a pre-warned or pre-known thing is always better.
Abhishek.
Thank you.
Yeah.
Dr. Abhishek, am I audible?
Yeah.
Yes, Dr. Ipsita.
Hi, Dr. Abhishek. Thank you for your comprehensive and very interesting presentation. I just want to add a few points on the histological features. As Neha ma'am has very beautifully discussed the molecular part, the few histological important findings that we as pathologists should note in a thyroid pathology report is the percentage of various adverse histological parameters like the percentage of tall cell variant, the percentage of columnar cell change, as Deepa ma'am has mentioned this, that if it is more than 10%, and some literature says if it is 10 to 30%, in the case of a PTC, if the tall cell change or columnar cell change is 10 to 30%, then it behaves actually like a tall cell carcinoma. I mean, it has poor prognostic significance. Similarly, there are other unusual or under-recognized tumors in the recent thyroid. They are also very important because they behave very differently. Means their prognosis is very different. For example, cribriform morular variant of thyroid carcinoma, it mimics a follicular carcinoma, and similarly sclerosing medullary mucoepidermoid carcinoma with eosinophilias. These are very rare tumors, but they should be kept in mind while looking at a case of thyroid carcinoma because the prognosis is different. And secondly, another point I would like to highlight here that there is a new entity, relatively new entity that has been entered in WHO thyroid tumor classification. That is a bit confusing entity. Am I audible?
Yes, you are. Go on, please.
Yeah. Thank you. It is invasive encapsulated follicular variant of papillary carcinoma. And this entity is much debated in many of the head and neck CMEs now and then, because the name itself is confusing, but it is actually a follicular variant of papillary carcinoma. The prefix invasive encapsulated has been added to this because this tumor is a encapsulated tumor. It has a very thin fibrous capsule around it, and it has few areas of invasion that if you closely look, you find few areas of invasion, but though in low power they look like a follicular adenoma maybe, but on further sectioning and extensive crossing of the capsule, you find few areas of invasion. So we call it invasive encapsulated follicular variant of papillary carcinoma. So this entity has to be kept in mind because it has different biological behavior. It has rare nodal spread and it has different molecular profile. So this entity has to be kept in mind. So these 2 points I wanted to highlight.
Okay, perfect.
Hi,
Dr. Kumar,
Abhishek.
sir.
Can I make a
Yes, sir.
comment?
Yes, sir. Please, sir. Please.
This was regarding the comment made by Dr. Jyoti Dabolkar, madam, and I think so. And this was a bit of a suggestion regarding molecular marker. I think so. One of the things we may, and especially these are the tumors we look after here. You have those bigger tumors with whole lot of patients where upfront surgery becomes a challenge. And in these patients, already we are giving those TKI before surgery. Now, either we shy away from keep saying, that we need to enroll in trial, which will never happen here, and at least we have not seen happening, and keep waiting from someone to say from abroad that we do it, or we put in a subtle manner in a guideline, and which also makes it different because there are some evidences and we do practice it. I'm giving, yesterday I had given a TKI with a similar situation for the patient upfront with, a CA thyroid, having trachea and esophagus, getting involved. So that may allow a structured way of having those molecular testing done here and having those TKI becoming important and molecular testing therapeutically, not prognostically, becoming important here. Second part is that also sensitization of the molecular testing in long run, that we do have high risk patients where you have a high chance of recurrence, and many times doing those biopsy of that time is a challenge.
Correct.
For example, having bone.
Absolutely.
And then your biopsy, your surgery specimen is old, 2 years, 3 years, or 5-year old, and doing molecular test is a challenge again. And you do have many of these treatment which is based on that. So again, I repeat, I don't say that every patient one should be doing it, but having them in a guideline in a way that whoever uses it, they are also considerate and responsible where they do this testing will be useful. That's again my comment.
Kumar,
Sir, I just wanted to ask you, please correct me if I'm wrong. Our TKI is not agnostic to molecular markers.
Can you repeat, Abhishek? Sorry.
So are TKIs such as lenvatinib not agnostic to molecular markers? I mean, irrespective of the molecular aberrations, they are likely to work because they are multi-kinase inhibitors. Just wanted your opinion on that.
Absolutely, what you're saying is right. So lenvatinib and cabozantinib is mutation agnostic, but in case if it is RET positive and NTRK positive, you have far safer drug and far more effective drug.
Right.
So if you fix out of 10, yes, ma'am.
Kumar, even in the previous session, I don't know whether you were there, the pathologist was very brilliant. And I was trying to tell her, which I want to talk to you also, and you give a comment at the end of my suggestion, that molecular marker is not here to, are not here in India. I'm not ready for that. I want that, molecular marker may not be used for diagnostic purpose in a well-differentiated carcinoma. They're absolutely must for an anaplastic and undifferentiated carcinoma. In between this group, should you say like the talk which Abhishek presented, locally advanced, where they present locally advanced or they recur eventually after doing the initial surgery? We must do the molecular marker and then appropriately use these agents and probably downstage the tumor and then operate if the need be. Do you think we are there already?
Madam, first part of it, it's available or not?
Available. It's available with Med Genome. Its cost is 25,000 rupees.
Ma'am, I'll comment that. I do this test very commonly. I do in thyroid also, but I do in lung cancer a lot. And a whole lot of them. I totally agree with you what you said. In fact, there are more than 24 labs who does it in this country. More than 24. And cost varying from 13,000-14,000 to, madam, what the number you said, and maybe more, depending upon what big panel you want.
No, 25,000 covers most of the profile is complete. Believe me, profile is complete, and collecting and sending the samples and everything is done by the company. And I tell you, I feel that please, this generation, these people who are on this panel and this program of ISTS guidelines should not brush away the molecular marker role completely out. I think we have to be judicious, but we as a senior in the faculty,
Ma'am, that is a great point.
should start doing something about it, yeah. I'm restless. I'm restless.
We only have about 7 minutes left.
Abhishek, you show one case which you presented in London, please.
Unless we have any other
no, you please go
anyone.
ahead. You go ahead. Go
okay,
ahead.
So we'll quickly show you a few cases to reiterate what we've discussed through the day. This is a very routine patient, 25-year-old female.
Be little concise.
Yes, young female, Bethesda 3, Thyroids 4A, taken up for surgery. At hemithyroidectomy, you found that the nerve was encased. So quickly, sir, or Dr. Devendra, sir, or Dr. Deepa, madam, how would you tackle this? Preoperative local cord mobile. That is a clinical picture, exactly the clinical picture.
So clearly you said it in your talk, if the nerve is encased by tumor, you need to shave off disease if you can, leaving only microscopic disease if that is the only site of disease. And the principle is not to leave gross disease behind. A pre-op functioning nerve first should be tried and preserved at all cost. Second, you should not leave gross residual disease on that nerve. And third, you are allowed, you can shave off the disease only if you're leaving what is traditionally called as the red beefy nerve, very microscopic residual disease, and then remove the tumor. And only point that I would like to make here before is I don't agree with those flowcharts. Whether opposite cord is not mobile and you have gross disease on this nerve, you need to shave off. I really don't know if how many people have shaved off the nerve and that nerve is functional. I really don't know. I've not seen if you shave off the nerve with a knife, that nerve is anyway going to go. You need to talk to the patient preoperatively that this is a locally advanced disease and I need to do what I need to do, because otherwise it's going to come back with a vengeance and you'll land up with a laryngectomy.
Yeah, so that's a great point. So you need to have discussion with the patient.
So really you need to make that decision preoperatively or take consent that this is aggressive disease. I need to be more aggressive.
And Devendra, today I know it is a disaster that the patient may require tracheostomy for some time.
Yeah.
But after 8-10 days,
you can do
procedures which we have, Kashima procedure, partial.
So we have 5 minutes. This is a young girl who underwent hemithyroidectomy for a Bethesda 3 Thyroids 4A nodule. Surgeon notes say that there was an irregularity on the trachea. Histopathology is Papsia thyroid. In the post-op CT, you can see that there are central compartment nodes. There is no tracheal invasion, but there is soft tissue enhancement on the surface of the trachea. I spoke to the radiologist. He labels it as Shin 1. There is no lesion in the contralateral lobe. So how would you proceed with this? Hemithyroidectomy undergone.
So I would plan this patient for a total thyroid because it's a 13-year-old female.
Yeah.
She would require a completion, and nodal disease is known, but these are patients who will respond very well, and you have to do a total thyroid and give REI in these cases. Generally, I wait for around somewhere 2 to 3 months after the first surgery for the fibrosis to settle down before I go in for the next surgery. With respect to the approach, generally I use the lateral approach in a patient who's been operated previously. It depends on whether I need to go in the ipsilateral bed. If that bed is clear, I would not generally open it. But here, since there's disease on the prefrontal area, you will have to somewhere approach the brain. And I would base my addressing the operated bed on intraoperative findings as well as the preoperative sonography.
Okay. So great. We have this another patient who has a thyroid mass since a year, multinodular disease, level 2 nodes on the right, vocal cords are mobile. CT scan and USG shows multiple nodules, hypoechoic, bilateral neck nodes. Ipsita, or maybe I'll bring Ipsita in for another case. We have 3-4 minutes. At surgery, extensive lateral compartment nodes, both sides, extensive central compartment nodes, extrathyroidal extension to the cricothyroid and to the sternothyroid muscle. The left central compartment tissue is adherent to the esophagus. What would you do? Both the RLN are at risk due to the central compartment, but preoperative vocal cord were normal. Would you stage this resection, and how would you manage this esophageal adherence?
What was the age, Abhishek?
29-year-old male.
Okay.
Bethesda 6.
Right. So here, Abhishek, now you're in trouble. Esophagus, if you have not done a good imaging preoperatively, but majority of the cases for esophageal involvement are usually in the muscle fibers. You can dissect the muscle fibers and get that out. Usually that's not a trouble. It's never invading the lumen of the esophagus, or majority of the cases. So that you can tackle. The more important question here is the bilateral recurrent laryngeal nerve. Now, if the nerve can be shaved off on one side with getting a good plane and leaving a red beefy nerve, and the signal is there, then you go to the opposite side. If you lose signal, I would stage this procedure. And when I come out, I would talk to the relative saying that I may have to go in and do an aggressive surgical resection. Because if you're going to leave gross residual disease in this young man, he's going to recur there at the point of entry of the nerve, and he will in future land up with a total laryngectomy. But
that's a great
buy him
point,
time.
Sir.
You can stage the procedure and go in at the second time if the nerve recovers on this side after your shave excision.
Okay, just a hypothetical question, not in this case, but let's say the bilateral neck nodes were adherent to both the IJVs. What would you do? The lateral neck nodes.
Same thing. Resect one IJV, reconstruct it, and wait for collaterals to develop on the opposite side of the same side, and then go in at a later stage and tackle the opposite side.
But would you do reconstruction of the less involved IJV and then resect both at the same setting?
Whichever side you decide, you must reconstruct the IJV.
Yeah. Okay. Perfect. So, role of nerve monitoring. How would you
show one of the case of TKI, no?
Yes, madam. We have 1 minute. We'll just take that. Role of nerve monitoring, ma'am. Sir, ma'am.
Enough question.
I always use nerve monitoring in locally advanced thyroid cases. It helps me, especially when I know that I'm expecting some sort of recurrent laryngeal dissection, then I always tend to use it. It helps me prognosticate. I have done stage surgery based on nerves, a loss of signal in cases. So short answer, I use it for all LA.
We have a minute left. Dr. Ipsita, that was a pathology of that young male with that multiple neck node involvement. Do you want to quickly comment on that?
Yes, Dr. Abhishek. Can you please repeat your question? Sorry.
That's the unfortunately, that's the only pathological picture I got from my pathologist. PTC, does it look to be a poorly differentiated or an aggressive variant?
This is not a pathology slide. This is actually a aspirate. So this is a FNS smear, cytosmear.
We don't even know that, right? So
so it's a cytosmear. It does look like a thyroid malignancy, but I'm not very sure whether the nuclear features of PTC are there or not. So and looking at the
this was
nuclear
reported as a tall cell variant. Dr. Sarmani Madam, would you advise adjuvant radiation in addition to RAI for this?
You know, I would look at what the nuclear medicine physicist physician actually tells me. If they're going to consider RAI therapy just because of age, and if you've managed to resect completely, I may wait. But if it's not avid, it's not concentrating iodine, and you've not been able to resect, I may still consider, especially because if this is more than 10 or 30% of the tall cell variant, despite the age.
Yeah, so this was reported as tall cell. He underwent both radioactive iodine and EBRT. So that was the last case, and I think that brings us to the end of this session. Thank you very much, all the session experts, and I hand over the reins to Dr. Asim.
Thanks, Abhishek.
Thank you, Abhishek.
Thank you, Dr. Abhishek. Now we'll move on to the next session. The next session is on radioactive iodine in differentiated thyroid cancer. And the speaker for the session is Dr. Archie Agarwal. Madam is Professor in Nuclear Medicine at Tata Memorial Hospital, Mumbai. For the session experts, we have Dr. Deepak Balasubramanian. Sir is Professor, Head Neck Surgical Oncology at Amrita Institute of Medical Sciences, Kochi. Dr. Venkatesh Rangarajan, Sir is Professor, Nuclear Medicine at Tata Memorial Hospital, Mumbai. Dr. Apurva Garg, Sir is Consultant, Head Neck Surgical Oncology at Indian Oncology Cancer Institute, Indore. Dr. Kumar Prabhash, Sir is Professor, Medical Oncology at Tata Memorial Hospital, Mumbai. Dr. Sanskriti Murthy, Madam is Assistant Professor in Head Neck Surgical Oncology at Kidwai Memorial Institute of Oncology, Bengaluru. Dr. Mitali Dandekar Lal, Madam is Senior Consultant Head Neck Surgical Oncology at Paras Cancer Center, Patna. And Dr. Shwetab Sinha, Assistant Professor in Radiation Oncology at ACTREC, Navi Mumbai. So welcome all, and over to you, Dr. Archie.
Very good evening to all of you. At the outset, I would like to thank Asim, Dr. Jyoti, Dr. Pankaj for having me here. And I'll be speaking on radioactive iodine treatment in differentiated CA thyroid. So in this lecture, which is all based on the ISTS guidelines that we have made recently, I'll be speaking on goals and timing of RAI. How do we prepare a patient for radioactive iodine? What is a pre-therapy and a post-therapy scan? How do we treat with radioactive iodine as per the risk stratification? And how do we follow up after RAI treatment? So before going into the lecture, a little bit of basics. And when we are looking at radioiodine, there are two types of isotopes that we commonly use with iodine. One is iodine 123, the other is iodine 131. Now, iodine 123, this is only used for diagnostic purposes. So when we want to do a diagnostic scan, a pre-therapeutic scan, we can use I-123 iodine. But this 123 iodine is not available in India till now. So we don't use I-123 iodine for pre-therapy scan when we are looking at DTC. But what is available with us is I-131, and this has both a beta and a gamma component. So when we have a beta, you can treat the patients, and when we have a gamma, we can do diagnostic imaging. So this is helpful both for therapy as well as for diagnosis. And this is what we use in India for both diagnostic as well as therapeutic purposes. So we all know the goals of radioactive iodine after total thyroidectomy are three: remnant ablation, adjuvant therapy, and radioactive iodine therapy. So when we are looking at remnant ablation, we want to destroy the residual, presumably benign thyroid tissue. This will eliminate the thyroid gland as a source of thyroglobulin. And this will facilitate the detection of recurrent disease by measurements of serum thyroglobulin and RAI scan. So it will make serum TG estimation and RAI scan more sensitive. Adjuvant therapy, when we have suspected but unproven microscopic disease and we want to destroy it, we do this adjuvant therapy. This is intended to improve disease-free survival and will also decrease the risk of recurrence. Coming to RAI therapy, this is when we know that there is persistent or metastatic disease and we want to treat it with radioactive iodine, and this will improve the disease-specific and the disease-free survival. So what are the benefits of radioactive iodine? Particularly in high-risk patients, it will decrease the local recurrence by about 50% of the patients who are treated with radioactive iodine as compared to those who are treated with surgery alone. It improves the survival. It prolongs disease-specific survival and progression-free survival in patients with lung or bone metastasis. So when we look at prognostic classifications of DTC, there are two types of prognostic classification that we are looking at. One is the TNM classification that looks at risk of cancer-related death. The other is ATA risk stratification, which looks at the risk of structural recurrence. So the TNM classification, the latest one, the 8th edition, in that we have 1/3 of the patients that are downstaged as compared to the previous edition, the 7th edition. That is because more than 90% of the patients have either stage 1 or stage 2 differentiated CA thyroid, where the risk of cancer-related death is less than 2%. Whereas when we are looking at risk of structural recurrence, the low risk category will have a risk of recurrence of less than 5%. The intermediate has a wider range from 5 to 20%, and the high risk category has a risk of more than 20% is the rate of recurrence in the rate of structural recurrence in the high risk category. So more than 80% of the patients with DTC are low risk, so the risk of recurrence would be low. But the risk of recurrence in the intermediate group, it varies widely because the risk of recurrence has a wide variation from 5 to 20% of the patients. Approach. The expected benefit of post-operative RAI therapy depends upon the individual risk of the patient. So if we look at differentiated thyroid cancer, low risk, we all know that papillary CA thyroid, low risk, which are intratumoral, less than 4 centimeters in size, don't have a gross extrathyroidal extension, have microscopic or less than 5 lymph node metastasis, and all absence of any aggressive features of vascular invasion. This would form the low risk category in papillary cancer thyroid. And in follicular, when we have well differentiated, when we have a capsular invasion, which has only less than 4 foci of vascular invasion, this also is in low risk category. And also minimally invasive follicular CA thyroid comes under the low risk category. And the risk of recurrence here is less than 5%. So retrospective studies have not demonstrated mortality benefits when we give post-operative radioactive iodine in this low-risk category. That is because the structural disease persists after surgery in only less than 2.5% of the patients, which can be cured by further surgery or I-131 treatments. And the risk of mortality in these patients is less than 1%. So follow-up in this low-risk category can be reliably be based on serum thyroglobulin level estimation only. So how have we come to this conclusion? So there were multiple retrospective studies and a very large retrospective of 10 years. It showed that there was no significant effect of RAI adjuvant therapy on overall or disease-free survival. Then we also had 3 systematic reviews by Sauka, Sachs, and Lamar, I-131 adjuvant treatment on disease-related mortality in this group of patients. So on one side, we were looking at whether we need to treat low-risk patients with radioactive iodine or no. And on the other hand, there were studies and prospective trials which were going on to see whether we can reduce the amount of radioactive iodine that we give for remnant ablation in these patients. So 2 important trials in this category were the estimable and the high-low trials. The estimable 1 and the high-low trial. So these were prospective large RCTs, non-inferiority design done in low-risk patients, both at more or less the same time. And what they did was they categorized all low-risk patients and they treated one group with 30 and another with 100 millicuries, and they prepared them also in 2 different ways. One was the thyroid hormone withdrawal that we routinely follow. The other is the recombinant TSH. So when they looked at the results, they showed that there were the post-ablation success rates at 6 to 9 months between low-dose radioactive iodine and the standard high-dose radioactive iodine, that is 100 millicuries with or without recombinant TSH, was similar. So when they saw this 30 and 100 millicuries, when we give for remnant ablation, it is similar. So we can treat patients with 30 millicuries when we are looking at remnant ablation. We also had the 5-year follow-up, and they showed that the same favorable outcome was observed whatever the initial protocol that was used for ablation. So if we look at estimable, they concluded that stimulated TG that was done at the time of RAI ablation was highly prognostic for persistent structural disease. And 98% of the patients with low-risk thyroid cancer who received post-operative RAI had no evidence of disease. No relation to the preparation method or activity used for ablation was seen. And the proportion of patients with recurrence was in accordance with the 10-year rate of recurrence of 1 to 2% that is expected for patients with low-risk thyroid cancer. Similarly, with the high-load trial, they looked at the recurrence rates at 3 years, 5 years, and 7 years, and the recurrence rates in both the treatment groups, that is 30 millicuries, and the low dose RAI, that is 30 millicurie, and the high dose 100 millicurie, were similar and they were not different. So both these trials, they showed that 30 millicurie suffices for remnant ablation in low-risk thyroid cancer. Subsequently, in 2022, this very important trial, the Estimable 2 trial, was published in NEJM. Now, this was a prospective randomized phase 3 trial, and patients with low-risk DTC post-total thyroidectomy were taken in this trial. More than 700 patients were randomized. The one group was the RAI group, where the patients received 30 millicuries, the other RAI thyroidectomy. So the primary objective was to assess whether no RAI was non-inferior to RAI therapy with respect to the absence of composite endpoints that included functional, structural, and biological abnormalities at 3 years. So they looked at RAI scans, they looked at ultrasound, that was structural, and biological, the TG estimation, and whether these patients had any abnormalities at 3 years, whether they were treated with 30 millicuries or not treated with any radioactive iodine. So in the results, they showed that 730 patients were evaluated at 3 years after randomization. And in both the groups, the no RAI and the RAI group, the event rates were similar in both the groups. And more than 95% of the patients in both the groups did not have any events. They also concluded that events were more frequent in patients with a post-operative TG of more than 1 nanogram per ml during thyroid hormone treatment. So both these, this Estimable 2, it showed that even if you don't treat a patient with radioactive iodine when in the low-risk category, these patients will do well. So they concluded that the follow-up strategy that did not involve the use of radioactive iodine was non-inferior to an ablation strategy with radioactive iodine regarding the occurrence of functional, structural, and biological events at 3 years. So to conclude the low-risk DTC, most patients of low-risk DTC will do exceptionally well after surgery. Either lobectomy or total thyroidectomy suffices. Disease-specific survival rates are in excess of 99%, and structural disease recurrence rates of less than 5% after either low intensity, that is only surgery, or after high intensity treatments, that is you do surgery and treat them with radioactive iodine. So most patients with low-risk thyroid cancer are surgically cured, and outcomes cannot be improved by radioactive iodine. These are best managed by serum thyroglobulin and reassurance. So no RAI is needed in the low-risk DTC category. Coming to intermediate and high risk, intermediate, we all know aggressive histologies, tall cell, solid, columnar, all these will come under aggressive histologies. When you have lymph nodes that are less than 3 centimeters in size and more than 5 in number, these will form the intermediate risk category. Multifocal papillary thyroid carcinoma, now multifocal in the ATA, it says it is low risk, but in other like the ETA and others, it says that it is in the intermediate risk category. But even when in the intermediate risk category, it has a low rate of recurrence. So maybe 5 to 6%, but the aggressive histologies are at the higher rate of recurrence. And high-risk disease, when you have metastasis, when you have macroscopic invasion to perithyroidal tissues, when the lymph node size is more than 3 centimeters, follicular thyroid cancer with extensive vascular invasion, poorly differentiated CA thyroid, and elevated post-op serum levels of thyroglobulin, all these will come under the high-risk category. And these are the 2 categories where you definitely have to treat them with radioactive iodine. So in patients with intermediate risk DTC, the risk of persistent disease and recurrence is higher than in patients with low risk DTC, but the risk of cancer-related death is low. So this is a heterogeneous group where the risk of recurrence varies from 5 to 20%, and thus a protocol for initial treatment is frequently defined on a case-to-case basis. So depending upon the type of risk stratification or the risk category that the patient have, you can treat the patient with that amount of radioactive iodine. When you're looking at aggressive PTC histologies, I think it was discussed in the previous talk as well. So when they are tall cell variant diffuse sclerosing, we need to treat them with radioactive iodine. But many of the tall cell variants will not take up radioactive iodine because of the loss of sodium iodide importer. And as Dr. Sarbani said, we can treat them in addition to RAI, we can treat them with EBRT. But improved overall survival is seen in aggressive PTC histologies after radioactive iodine treatment. And the intermediate risk factors with definite indications for offering RAI are aggressive histologies, increasing volume of nodal metastasis, and advancing patient age. So the dose needed for intermediate risk group when they have these aggressive histologies varies from 100 to 150 millicuries, but when they are multifocal and a low level of lymph nodes, then they can be treated from 30 to 50 to 100 millicuries. Coming to the high risk category, it represents 5 to 10% of all patients with DTCs, higher risk of persistent and recurrent disease, higher risk of mortality from DTC, and the initial treatment should aim to eradicate all tumor foci. So retrospective studies have shown improved disease-free and overall survival after I-131 administration in high-risk category. And this is the category that we definitely have to treat with radioactive iodine. The dose could vary from 150 to 250 depending upon the type of disease and the distant metastasis that the patient has. So coming to the protocol that we use when we are treating a patient with radioactive iodine, the patient undergoes near total or total thyroidectomy. And if we want to wait for the endogenous TSH to rise, we will wait for 3 to 4 weeks. We will do a pre-treatment diagnostic scan. Now, whether to do a pre-treatment diagnostic scan, it's debatable. Some people are happy, treating the patients directly after total thyroidectomy and when the TSH is more than 30. But we always, we are comfortable when we see what we are treating. And so this pre-treatment diagnostic scan, it will give information on the presence of iodine-avid thyroid tissue. So once we have done a diagnostic scan, the patient will receive radioactive iodine depending upon the type of disease that the patient has. So if the patient is receiving 30 millicuries, there's no need of isolation or no need of an admission process. The patient can be discharged the same day. But if the patient receives more than 30 millicuries, then we have to admit the patient in an isolation ward. And depending upon the radiation levels, when the radiation levels are lesser and we can discharge them, then the patient comes out of isolation. And when the patient comes out of isolation, that is the time when we do the post-therapy scan. Now, this post-therapy scan, no additional iodine is needed. The iodine that we gave for therapy, that is enough. And till 8 to 10 days, we can do this post-therapy scan. So not in a hurry. Once the patient is out of isolation, that iodine that we gave for the therapy, that is enough for us to do the post-therapy scan. In fact, because we have given so much of radioactive iodine, when we are doing a diagnostic scan, we are doing only with 1 to 3 millicuries. But when we are treating a patient, we give anywhere from 30 to 200 to 250 millicuries. So this is a very highly sensitive scan, and it often happens that you are missing out on the metastatic lesions when you do a diagnostic scan. But the post-therapy scan, it is the scan which will actually define your subsequent treatments and will actually risk categorize the patient. So this post-therapy scan is a very important scan and should not be, it should definitely be done. So how do we do this pre-treatment diagnostic scan? The TSH has to be more than 30. Now, there are 3 activities that we can use, amounts of radioactive iodine that we can use. One is 100 microcurie. Now, this is obsolete. 100 microcurie is very low dose and it gives no information on the whole body. So you can just image the neck and nothing else. Moreover, you need a rectilinear scanner to image this. So this is obsolete and we don't use it. The next is 1 to 3 millicurie, and the other is 3 to 5 millicuries. Now, when we give 3 to 5 millicuries, this is a high dose of radioactive iodine. And when we do 3 to 5 millicurie scan for diagnostic purposes, this can cause stunning. Now, stunning is inflammation of the thyroid follicular cells after the patients have received 5 millicuries of radioactive iodine. And this can lead to lesser uptake when we are treating the patients with higher dose of radioactive iodine. So we don't want stunning. We don't want, and we want a whole body information. So the best option is to do a 1 to 3 millicurie scan, which will not cause stunning and also will give us a whole body information. So what are the prerequisites? 2 main requisites for radioactive iodine treatment. One is TSH stimulation, more than 30 micro-international units per ml. This is enough, and we need a low iodine diet. Now, both these are done to enhance the uptake of radioactive iodine. So the dose that is delivered to the thyroid bed as well as to the metastatic sites will be higher. And that's why we want this TSH stimulation and a low iodine diet. So how do we do this TSH stimulation? There are two ways of doing the TSH stimulation. One is endogenous, another one is exogenous. So when we are doing endogenous, the most commonly used was stop LT4 or the levothyroxine or the eltroxin that we are giving, or after total therapy, don't start it for 3 weeks. And by 3 weeks, you will have a TSH of more than 30, and then you can do a diagnostic scan or treat the patient. Another way is stop LT4, switch to LT3, that is triiodothyronine, and this is now available in India under the name of Linorma by Abbott. So you can start LT3 for 2 weeks, then followed by withdrawal of LT3 for 2 weeks. So this will, give a better quality of life as compared to stopping LT4, because the patient becomes very, very hypothyroid. And when the patient is given LT3 for 2 weeks and then off LT3 for 2 weeks, the quality of life is better. So, this we can do easily, and you may ask your nuclear medicine physicians to go for this because LT3 is now available in India. And exogenous, we all know, is recombinant TSH. This can be done immediately after surgery, but we want to wait for 5 to 7 days for the patients, for the scar to heal and to come out of the surgical thing. And then we can give recombinant TSH and treat the patient whenever we want. Another thing about giving recombinant TSH is we can only treat with 100 millicuries, because that is FDA approval for radioactive iodine. When we are using recombinant TSH is only for 100 millicuries. So when we do a pre-treatment scan, we are checking at the TSH. It should be more than 30. We look at the serum TG, do anti-TG antibodies. Pregnancy and lactation are a complete no-no. They are a contraindication when we are treating when we are giving radioactive iodine. And there should not be any iodine interference, because if there is any iodine interference, then this radioactive iodine will not go to the sites that is supposed to go, and we will not have any benefit of radioactive iodine. So low iodine diet is recommended for 2 weeks prior to radioactive iodine treatment. And what should be avoided? IV contrast studies for 4 to 5 weeks. Now, here to mention that, after total thyroidectomy, we don't want any CT scan. I think someone was asking in the chat box whether IV contrast study preoperatively. Preoperatively doing an IV contrast study or a CT scan is absolutely fine, because these are all water-soluble contrasts and they are eliminated from the body by 3 weeks. So we won't have any interference when we are doing a radioactive iodine treatment. Seafoods have to be avoided. Certain vitamins, expectorants, drugs, and food supplements which contain iodine have to be avoided. Local dental applications also have to be avoided. Iodized salt that is used in cooking is absolutely fine. On the table, it should be avoided. So these are some simple measures which should be which the patient should be asked to follow. And please don't stop milk, bread. These are all not fortified with iodine. They do not contain iodine, and that can be had. So just check the labels when you are prescribing any medication and see that if it doesn't contain iodine, that is more than enough. And this is only for 2 weeks prior to radioactive iodine treatment. So coming to a diagnostic scan, when we do a whole body pre-treatment scan, we want to look at whether there is uptake in the thyroid bed or outside the thyroid bed. So if there is uptake in the thyroid bed, we can just do a remnant ablation and treat with 30 to 50 millicuries, also depending upon the HPR, because if it is an aggressive variant, you want to give higher, even though there is only thyroid bed uptake. Whereas uptake outside the thyroid bed, metastatic, so the patient might need anything from 100 to 200 to 250 millicuries. So now, what are the approaches for choosing the dose of I-131? How do we come to this 30, 50, 100, and 150? Now, the approaches for choosing the dose of radioactive iodine are 3: fixed dose approach, tumor dosimetry, and maximum tolerated dose. Now, the most commonly followed is the fixed dose approach, because it is easy, and we know that if the patient has lymph node metastasis, we would treat with 100 to 150. If the patient has an aggressive variant histology, we would treat with 100 to 150 millicuries. Lung, we would treat with 200 millicuries, and bone metastasis, we would treat with 250. So this is a very easy approach to follow. Whereas tumor dosimetry, now for tumor dosimetry, we have another radioactive iodine isotope, that is I-124 iodine, which is a PET-based agent. So we can do a PET-CT with I-24 and look at the dosimetry as to the amount of radiation or the amount of grays that we want to deliver to the thyroid bed or to the metastatic sites, and depending on that, we choose the dose that we want to treat, or the maximum tolerated dose, that is the upper limit based on the blood and whole body radiation absorbed dose. Now, but there have been studies which have shown that all approaches yield similar results, and thus worldwide a fixed dose regimen is usually followed. So the fixed dose, I already told you, for remnant ablation, we would treat with 30 to 50. Nodal lung aggressive variants anywhere from 100 to 150. For lung, we would also go up to 200 millicuries. Skeletal metastasis anywhere from 200 to 250 millicuries. So showing you a few examples. Now, this was a 42-year-old lady, papsia thyroid with lymph node metastasis, fell in the intermediate risk group. And this is the whole body pre-treatment diagnostic scan with we have done with 3 millicuries. And as you can see, this is a anterior view, and this is a posterior view. And you can see that this is there's only neck uptake that you are seeing. Rest all what you are seeing is the physiological uptake. Some uptake in the bowel, the bladder, nasopharyngeal activity. That is all normal physiological uptake. So what we are concerned is we are seeing some remnant uptake here in the thyroid bed. So this patient was treated with radioactive iodine. So radioactive iodine is given orally. It could be in the liquid form when the patient has to drink it with a straw in a fume hood like this. It can also come in a capsule. So the patient can also be given a capsule. So basically it is an oral treatment. And because she was treated with 100 millicuries, she had to be put in an isolation ward. And this is the radiation monitor with which we monitor the dose, the level of radiation that the patient is, the emissions from the patient. So this is how the patient is monitored in an isolation ward. Once the patient's radiation levels are to the permissible limits of discharge, we discharge the patient. And then we do a post-therapy scan. So then this is how we have done a post-therapy scan. And you can see that there's uptake only in the thyroid bed, else everything is physiological uptake. There are no activities elsewhere. So this is a non-metastatic case with only uptake in the thyroid bed. And with subsequent follow-up, she'll be completely treated. Sometimes bowel uptakes may cause a problem. And when we are not sure that whether it's in the bowel or it's in the vertebrae or the spine or the pelvis, then we can always do a SPECT CT and see where the uptake is lying. So that will give us a clarity as to whether it is just physiological uptake or uptake in the metastatic site. So this patient just had a remnant uptake in the thyroid bed and was subsequently completely treated of thyroid cancer. Another example, so these are all post-therapy scans. So you can see this patient has diffuse lung metastasis and also some nodal metastasis. And this is a patient with multiple skeletal metastasis post-radioactive iodine treatment. And to show you an example, this is a pre-treatment scan, a large remnant in the thyroid bed, treated with radioactive iodine, and you can see the post-therapy scan. The first follow-up is done at 6 months, and you can see some uptake. The patient was, because the TG was high, the patient was treated again. And this is the second follow-up again after 6 months, and you see that the patient is completely treated, and there is no uptake in the thyroid bed, and the TG is also within normal limits. So how do we follow up these patients? Now, TSH suppression, it is done during follow-up to decrease the risk of recurrence. Earlier, I mean, for many years, we have kept the patients in very low levels of TSH and made them hyperthyroid, but that is not needed. And for high-risk category, till the patient comes into the, we have this dynamic risk stratification, till the patient is treated of whatever the high risk factor was and the TG comes to normal and you're not seeing any uptake on the radioactive iodine. Only before that, you will keep the patient under low levels of TSH. Otherwise, don't make the patient hyperthyroid. And subsequently, the patient can be put in low normal levels of TSH. Similarly, with the intermediate risk group and low risk, because if the patient is undergoing a lobectomy, you will just supplement whatever is needed. And even if the patient has undergone total thyroidectomy, you'll just keep the TSH under the low normal range only. So coming to follow-up of differentiated CA thyroid, we do I-131 scan at the first follow-up till the patient is completely treated and the TG is normal. We will do a 1 to 3 millicurie diagnostic scan, thyroglobulin estimation. Anti-TG antibodies always should be done with thyroglobulin because if the anti-TG antibodies are high, you can have false, wrong thyroglobulin estimation. And if the anti-TG antibodies are high, then the patient has to be followed with ultrasound and radioactive iodine scans. Serum calcium estimation is a must because sometimes the patient's calcium levels are low because of removal of the parathyroid glands along with the thyroid nodule that is, or the total thyroidectomy that is done. So we don't want tetany or low calcium levels to occur when the patient is in an isolation ward. So we always test the serum calcium and then send the patient inside whenever we are doing radioactive iodine treatment. Ultrasound neck is necessary and in patients, particularly in patients who have lymph node metastasis. So how do we follow up these patients? So once we have treated the patient, the first follow-up is at 6 months. So we can have three types of scenario. The first is a normal radioactive iodine scan. That is, we are not seeing any abnormal uptake. The TG is undetected or is less than 1. So this is excellent response. Such patients, we will just start on T4 and follow up after 1 year for TG estimation. And the other one is when you have an abnormal uptake on the RAI scan and the TG is raised. So this patient, we all know, has structural incomplete response. So will be treated with I-131 again, and we will follow up at 6 months for the disease status. And similarly, this follow-up scenario will be followed up. Another scenario that we can have is having a normal radioactive iodine scan and the TG is raised. So this is biochemical incomplete response. So in such patients, we will, in such patients, we will look at the TG. We will measure the TG at 3 months. And also, sometimes you may plan to do a RAI scan because first time, when your TG is raised, but your scan is normal, you're not very sure whether there's iodine interference. So if you suspect that there was iodine interference, you can plan these patients for a repeat RAI scan and also look at the TG. And if your TG is rising and your RAI scan is still negative, then you know that this is rising TG with RAI negative scan. So it is a tennis. And you should plan, if you have FDG available, you should plan FDG because this is a whole body scan and will give you a complete scenario of the sites of disease that the patients have. If you don't, then you can do an MR or CT, but FDG is a very good imaging modality to triage the patients. It will tell you whether the disease can be treated with surgery. So if there is only one site of disease or one painful met, the patient can be treated with surgery and external RP. But if there are multiple sites of disease, then tyrosine kinase inhibitors are the way to go about. So what are the contraindications and side effects of RAI? Pregnancy and breastfeeding, this I already told you, are absolute contraindications to RAI therapy. And in men also who receive a cumulative dose of more than 400 millicuries, they will have temporary reduction in the sperm counts and infertility. But this is transient and it will normalize after a few months. But in young patients, if they want to do sperm banking, that can be advocated to these patients. Side effects of RAI are very few, and in most cases, they are transient. So most of the times, you'll just have sialadenitis, which usually recovers, and it's transient. The risk of developing second malignancy, though is present, though it is very small, and theoretically, yes, the patients can have a second malignancy after multiple lines of RAI treatment, and breast, GI cancers, leukemias. These are the ones that you should be on the lookout for. But it is the risk is very, very small, and multiple studies have shown that. So this is a normal diagnostic whole body scan in a patient who was treated with 30 millicuries. You see that there's no uptake in the thyroid bed or no outside the thyroid bed also. There is no uptake of radioactive iodine. So this is successful remnant ablation. Absence of visible RAI uptake on subsequent diagnostic scans. The uptake in the neck is less than 1% and undetectable stimulated serum TG or less than 1 nanogram per ml. This is stimulated TG. So if we compare the ATA and ISTS, what are the differences in radioactive iodine? So the post-operative RAI diagnostic scan, the ATA recommends that I-123 or I-131 both can be done. But because we don't have I-123, as I already told you, I-131 is the diagnostic scan that is done throughout India. Then when this ATA guidelines were formulated in 2015, they said that for low risk, RAI remnant ablation is not routinely recommended, but if done, 30 millicuries is generally favored. But now we have the estimable, it's an RCT, prospective RCT, which has shown that there's no benefit of giving radioactive iodine in low-risk patients. So in the ISTS guidelines, we have not recommended radioactive iodine in low-risk category. And if there are any doubts, or additionally, if you want to read, you can go and read our chapter in the Journal of Head and Neck, Journal of Head and Neck Physicians and Surgeons. So what is the take-home message? Preparation for RAI therapy is important. TSH more than 30 suffices. You can do either thyroid hormone withdrawal or recombinant TSH. And now we have LT3. So LT3 is a good substitute to have a better quality of life as compared to complete withdrawal of LT4. A low iodine diet is generally recommended 2 weeks prior to giving radioactive iodine. Treatment with RAI in low risk, it's not needed. In intermediate risk, as per the risk stratification, so it can vary. If you're just doing a remnant ablation in multifocal PTC, then it can range from 30 to 50. But if you're looking at aggressive variants or lymph node metastasis, it can go up to 150 millicuries. High risk will definitely need RAI ranging from 150 to 250 millicuries. TSH suppression should be done as per the risk stratification, and follow-up is done with whole body I-131 scans, serum thyroglobulin, anti-TG antibodies, and neck ultrasound. Thank you very much for patient hearing, and I'll be happy to hear to all the comments and the questions that are there, please. Thank you. So the experts, yes, sir.
Archie, that was a very, very nice presentation, Archie. In fact, it was a very perfect review. So anyway, you have covered most of the things, but I thought I will make some interesting comments. Okay. So I have been positively involved with this radioactive iodine therapy since the last 35 years. And what I see, and I'm sure many of my colleagues will accept or agree to, we have come a very, very long way from the what's called as a total thyroidectomy with lymph node dissection followed by 150 millicuries of radioactive iodine and suppressive dose of thyroxine. From that approach, we have come a long, long way. And I'm very glad that these changes have definitely taken place. So I will just make some points. The point number one is that about this 100 microcurie. So now that we all know that, 30 millicurie has come out as a very golden number below or above. But before that, there were two issues which used to confound many of the people. Like what is the residual amount of thyroid which is left behind after the surgery? To get that estimate, people used to do some sort of a dosimetry or even what we call as a thyroid uptake. We are very well aware of thyroid uptakes in thyrotoxicosis treatment. So since it's a post-surgery, so it used to give 100 microcurie and we used to look at the uptakes. That some people went to the extent of doing the uptakes to do some dosimetry, but now fortunately, we have now come to this period of empirical treatment where this 30 millicurie has become the golden number. And as you rightly said, 30 millicurie is more from a legislative point of view. So 30 millicurie will not be the cutoff for inpatient and outpatient, say in a country like Japan or Germany, it will be different. So as it stands, 30 millicurie can be given in the OPD way. The other thing is we all understand how important the thyroglobulin and TSH are, and these two tests are available in the TMH campus right from 1987. And what we are now talking of, when we talk of not only ATA, we talk of all the guidelines, we are talking of the 4th generation thyroglobulin and the 4th generation TSH. So one of the things is that wherever you are using, whatever you're using, thanks to my ex-colleague of RMC, Velumani, he who started this ThyroCare, now TG and TSH is available with 1 or 2 days of reporting right from any part of the country. So this has become a very, very big advantage. And because we have TG and TSH, there is so much of flexibility in our way by which we can work. The next thing is recombinant TSH. Recombinant TSH, yes, it's very useful. And I know centers in the country where recombinant TSH is being used as a package in very good situations, especially when you are working out the patient on a follow-up large dose scan. But considering the fact that it is very, very expensive, even for Indian standards, and since the last 1 year, we now have these T3 tablets. Earlier, we used to have the Cytomel tablets. Now we have an Indian product. And the cost is almost 1/100th of it. Now one tablet is approximately 10 rupees. So this is something which we should take the best use of. And I feel really we should justify the use of recombinant TSH because it has some other limitations also. And when you use triiodothyronine in tablets, there is no restriction. You can actually give any amount of dose. Next is the non-iodine 131. The question is, you talked about evidence in which patients have done very well who have not received no iodine, especially when they are in the low risk group. Actually, that is perfectly right, and I have no problem. Only thing is, I don't want you to blame the wrong person. Like what I'm saying is, you can say it is more inconvenient to go and get a radioactive iodine. But it is not, don't tell me from that, don't create that radiation phobia in this subgroup, basically, once there is a cancer induction, this radiation related issues really don't hold water. And so that being the point, I see Dr. Jatin Shah. What I would like to say is that recombinant, this radioactive iodine, one inconvenience which is very practical in young women is that they will have to be forced to maintain contraception for a very long time. And when it does not really give any big advantages, I feel it need not be given. But let us not make radiation phobia as the important point of not giving radioactive iodine. I am perfectly okay with it, and now we have evidence for it. The next thing is, from the Indian perspective, we still are lucky, or you can say whatever you can say, that we are lucky or unlucky. We still, as nuclear physicians, we will get to see the entire spectrum. We will get metastatic disease, we will get remnant, we will get all this, because India is so large and we have this issue. So my question is that how good are we in radioactive iodine in our country? In 1988, there were just 1 or 2 centers in the country. Today, there are 75 licensed centers which give high dose therapy. And there are 450 centers in which you can give what's called as a low dose therapy or a 30 millicurie therapy. So radioactive iodine is now very, very easily, extensively available in our country. One important point is, in metastatic setting, 2 populations are great beneficiaries of radioactive iodine. One is lung metastasis, whether it is in the pediatric population or in the adult population. And second thing is especially about pediatric population, I would like to say that in pediatric population, the post-therapy scan completes the staging of the disease. You will find a large number of children, especially those who have lymph node metastasis. When you do the post-therapy scan, you will see the lungs lighting up. And that's why I feel in pediatric group, you should be generous in your approach, do the right thing, and treat adequately, because these people are going to do extremely well. Bone patients, as you mentioned, their quality of life will definitely improve and many of them become disease-free, but there is a sizable population who still will have persistent disease. Then the very specific point I would like to say is about surgery. We have to acknowledge, Archie, that the quality of surgery has gone up very well across, at least we should talk about India. I remember in late 80s and early 90s, the amount of hypocalcemia which we used to handle in the ward, and that was really a big headache. Today, we hardly find those things, and we find perfect surgeries. In fact, that's why we should acknowledge in this group that the surgical techniques has greatly grown in our country, thanks to all our masters who have taught their juniors and make them masters. Last but not the least, I would like to say that some of the newer peptides, namely RGD and FAPI, these two really have great potential. So let us not underestimate them. I'm sure Dr. Kumar will be talking about these things in the future, in the sense that when we talk of non-iodine concentrating DTC. So in tennis, so I feel these things are really going to come up in a very, very big way. So I feel that, yes, we are going to do very well. And as a matter of fact, in radioactive iodine, India, now availability is not the issue. Reasonable amount of rationality is available. I want all of you to make the best use of the situation. Thank you very much.
Thank you, sir. Excellent comments. Very nice. I would like the other experts to make some comments. Dr. Kumar, Dr. Jatin Shah.
Hello, Madam. Hello, Madam. Shweta, we are just
Shweta, please.
Just taking Dr. Rangarajan sir's point forward regarding painful bony metastasis from thyroid cancers. I think that is one area probably where the response rate to RAI is suboptimal, and now we have an excellent option for those patients in the form of SBRT for these painful bony metastasis from thyroid cancers. I think thyroid is now one of the very standard recommendations. It is based on a randomized trial from Canada, the SC24 trial, which also included around 15 to 20% of thyroid patients. And it has shown that the pain relief with standard palliative radiotherapy can be enhanced with if we do highly conformal stereotactic body radiotherapy. And it is particularly important in these patients who, most of them have a significant life to live. We want to give them better quality of life. So So in these patients who respond suboptimally to radioactive iodine, patients with soft tissue component in their bone metastasis, weight-bearing joints, compression, SPRT now is a very standard treatment for these patients, along with, of course, surgical fixation and interventional radiological procedures. So I would like to know what has been our experience with painful bone metastasis with RAI, madam.
Okay, so when we have treated RAI with external beam RT, that has always been our experience in when we were in RMC, both me and Dr. Rangarajan when we were in RMC, and always these painful bony metastasis, you either want to give them radioactive iodine or treat them with EBRT first, reduce the pain, wait for 15 days, and then treat them with radioactive iodine. And so I think definitely EBRT plus radioactive iodine definitely works wonders for these patients, or it's still better for these patients. And
Excellent.
I think now, even with the tall cell variants and all others, we are going ahead with radioactive iodine and EBRT. So I think that's the way to go about. And let's see how the results come out when we have treated these aggressive variants with RAI and EBRT.
Yes, madam.
Excellent presentation, ma'am, and wonderful commentary given by Venkat Rangarajan, sir. So I wanted to ask, ma'am, two things. Like now we have trials that are showing that in low-risk thyroid cancers, we may not give RAI.
Correct.
So what policy are we now following at TMH? Like, are we observing all, or there is a select group of patients to whom we are offering RAI? And also one more thing I would like to ask you is that at what percentage of uptake do you send the patient for resurgery after the scan?
Okay. Okay, so Apurva, taking your first question, yes, in low-risk thyroid cancer, in Tata, we have following this policy and not treating them with radioactive iodine. We are just observing them after a lobectomy or total thyroidectomy. Now, in patients who have like multifocal disease, now multifocal disease, I feel the ATA says multifocal disease as low risk, but if you look at other risk categories, the multifocal is in the low intermediate risk. So I think this is one category where, we still are going ahead and treating them with 30 millicuries. Minimal ET also comes under low risk, so we are not treating them. The lymph node metastasis, where the size of the metastatic focus is about 2 mm, less than 5 in number, we are not treating them with low risk. Intrathyroidal, less than 4 centimeters in size, we are not treating them. So it's only multifocal that we are not sure of, multifocal, sometimes we are treating them, but I think we have to analyze our results and see how these patients are doing even after treating them with 30 millicuries, because I'm sure some of the multifocals we have observed and some of the multifocals we have treated with radioactive iodine, and it's high time, I think, we look at our results and see how these patients are doing. But definitely most of the I would say 90% of the patients in the low risk categories are not treated with radioactive iodine in Tata Memorial Hospital.
Thank you.
And your second question was what, Apurva? I forget.
Like how much percentage uptake?
Uptake. So, now the surgeons, I think, most of the patient referral that we have is from Tata Memorial. So in Tata, the level of surgery, I mean, it's too good. The precision surgery and the type of surgeries that they do, we don't see much amount of remnant. Only when the patient is referred from outside that we have. But, even 10-15% uptake, we try to treat them with radioactive iodine. Only if the remnant is too high and we have an uptake more than 20%, only then we try and send these patients for resurgery. Otherwise, these patients can be treated with radioactive iodine. But it's hardly, earlier in my course of career, I would see this large remnants where the uptake is more than 20%, but hardly now in the last few years, I've never seen such large remnants where we had the need to send them for resurgery.
Thank you.
I think Sabani had a question. Yes, sir.
If you allow me to make a comment.
Yes, sir, sure.
I think the whole concept of radioactive iodine needs to be thought of as not a, quote, routine after thyroidectomy. In order for radioactive iodine to uptake into the tumor, you have to have a thyroid cell, whether it is benign or malignant, which carries the iodine importer, and therefore it will absorb iodine, and therefore it will have radioactivity. So in the absence of thyroglobulin, radioactive iodine is meaningless. and you don't need to wait for a tracer scan and percentage uptake. The most accurate reflector of thyroglobulin producing cells is serum thyroglobulin in the absence of thyroglobulin antibodies. So if there is no measurable thyroglobulin, giving radioactive iodine is a waste of time.
Yes, agree, completely agree.
So that's the reason why we do not necessarily recommend radioactive iodine in patients with poorly differentiated carcinomas. Now, I grant you that these are mixed tumors where there are components of well differentiated and components of poorly differentiated carcinoma in the same tumor, and the radioactive iodine will work on the well differentiated component of the tumor. But that is not your big problem. The big problem is the poorly differentiated component where radioactive iodine is not going to do anything. That patient needs external radiation, not radioactive iodine.
Thank you, sir. Thank you. Excellent comments. Dr. Kumar, you were to make a comment?
Hi, Dr. Archie, and I agree with all the comments made. And we know that as far as average treatment is concerned, surgery remains the main treatment and followed by radioactive iodine, and that's what we should be following. There's a fair number of patients, especially in our part of world, which is upfront not resectable, and there where it becomes in the definition of radioactive iodine refractory, and that is something we need to keep in mind, which is uncommon other part of the world. And apart from that, we do have some TKIs where you have a radioactive.
Jyoti ma'am, you are audible.
So,
yes, please go on.
So we have a fair number of patients who, in advanced stage setting, they come back and they do become radioactive iodine refractory. We do have some good treatment options in that setting. The oral TKI, which talked about a bit, depending upon which indication, what kind of genetic changes we have, and it's important to do molecular profiling because in a certain group of patients we have some very good drugs which is available, which can be given based on that, and one should keep that option open in these group of patients. So yes, we do have some of those treatment in some of those hopeless situations where earlier we didn't have those options.
So Dr. Kumar, even in the NACT setting, would you use for unresectable CA thyroid, you would give lenvatinib or any other treatment in the NACT setting and then send them for surgery?
Yes, we are already doing it. And that's the reason in last comment also I suggested that we do, and I do concede that, outside we don't see these situations commonly, and we also don't see commonly, but we see it is not so uncommon for us. And it is almost, I'll say a month, one patient. And in last 2 weeks, we have seen 2 of them by different group of people. So these are situations which we encounter where we don't have R0 or R1 resection possible. And then I do agree there can always be a debate that what happens after that, will be able to do surgery or not. That we have seen that we are able to in a certain group of patients, and that how do we define as we go by, we'll learn. But anyway, if you don't have surgery possible upfront, those patients, if you don't give them a TKI, they go for by and large PAL care. So in those situations, again, those TKI becomes useful, and yes, we need to, as we go by, define which group of these patients we call neoadjuvant, because this definition of giving TKI, they are part of the randomized trial who are unresectable upfront. They have gone for TKI, but here what you're asking is, can they go back for surgery? Especially with those newer TKI, when 7 out of 10 patients has got significant shrinkage of tumor, we call partial response. Then we know that we have got some effective treatment, which was not the case earlier, where 1 or 2 out of 10 patients used to respond to the treatment. And that is why there is a keen interest in this approach at this moment. I'm not saying for resectable patient, please go ahead. Absolutely no doubt that they should go ahead for surgery where again TKI has been explored and there maybe fiddling outside clinical trial is not a good idea. But if you do have unresectable tumor upfront where you are going to leave those thyroid tissue there as a R2 resection upfront, that then yes, thinking about this option is a fair option.
Thank you, Dr. Kumar. Well taken. All the points well taken. Yes. Anyone else wants to make a comment?
Yeah, I'm Dr. Samskruti here. Archie ma'am, thanks a lot for such a wonderful presentation. Ma'am, tennis is probably one of the most difficult things that we find in clinical scenarios. So, could you please comment on role of empirical radioiodine treatment, especially when we still do see a structural disease like nodes or small lung nodules, which are suspicious, but we cannot FNA or biopsy to prove anything. So in these cases, would you advocate empirical radioiodine?
So in tennis, when it's not showing any uptake on the radioactive iodine scan, people have treated with empirical doses where, sometimes they have seen the TG coming down, but the structural disease remains as such. We don't believe in empirical treatment, and no patient of tennis is treated with radioactive iodine in Tata Memorial Hospital. We don't believe in that because it doesn't have any effect. And I think there are studies which have shown that it does not have a good effect on anything when the radioactive iodine just washes down and is eliminated from the body without having any effect. So it's of no use giving empirical radioactive iodine. So what we have to do is do an FDG, and if it is surgically amenable and treatable, because again, lymph nodes sometimes may have, multiple times you might have these recurrent, the patient might be having lymph nodes very often, and whether the patient can undergo surgery or EBRT can be done or multi TKIs can be given, that has to be seen, and not radioactive iodine.
Okay. Thank you, ma'am.
Ma'am, can I ask a question?
Please.
Archie ma'am, this is
Yes,
Guru Charan.
Yeah,
this is
go ahead.
So just wanted to a quick question, a very practical scenario that is in presentation in the tertiary cancer care centers in India. For example, a 30-year-old lady got operated outside for a thyroid multifocal disease, underwent total thyroidectomy, and presented to us with a nerve palsy on one side and opposite tracheoesophageal groove 1 into 1 centimeter nodularity present, CT suggestive of imaging suggestive of multiple central compartment nodes, but not in the neck, lateral neck. Those are subcentimetric nodes in the central compartment.
Okay.
So what should be the correct rationale of management of such diseases? Because surgically, this may be challenging to go into the thyroid band and remove those subcentimetric nodes and the tissue present near the tracheoesophageal groove. So what should be the practical and evidence approach for the management of such patients?
Okay, so see, I would suggest whenever you can go in for surgery and remove whatever you can, that would be the best way. Because if you are leaving a lot of disease behind, then to treat with radioactive iodine, multiple lines of therapy would be needed. And, sometimes when there is benign and normal thyroid tissue, that is very difficult to ablate. So you're treating them with 100, 200. And whenever there is normal thyroid tissue present, then, most of the iodine will be going to this normal thyroid because they take up a lot of radioactive iodine, and you will not be treating the metastatic sites or the disease sites. So it's always better to do the surgery, whatever you can, remove this, then treat with radioactive iodine. And I think in such patients, EBRT also can be helpful. And I think Dr. Sarbani, if you want to make a comment regarding this, when there's a lot of disease left behind, I think we should go with radioactive iodine and EBRT. That should be the way. Dr. Jatin Shah, you want to make a comment, sir? So you're not audible.
Dr. Agarwal, I am truly pleased to hear your comments. I presume you are in nuclear medicine?
Yes, sir. Yes, sir.
To hear these words from a nuclear medicine specialist is very refreshing, because it tells us that modern day radioactive iodine treatment is given with rationale, reasoning, and specific indication. So the patient that we are presented, a 30-year-old woman with gross disease left behind, needs an operation. Now, if you yourself are not capable of doing a good operation, or if you are afraid about injuring the nerves or producing hypocalcemia, feel no bad, let that patient go in the hands of an expert thyroid surgeon to have the proper operation. That woman needs surgery first, anything else afterwards.
Thank you, sir. Thank you. Sir, that's because I work with very good surgeons around me in Tata Hospital.
That's why you are probably popular among surgeons. So I think what you have said all along in the last few minutes since I joined, I will be reiterating in my presentation to follow, because there are so many ingrained misconceptions about managing thyroid cancer, and we need to clarify those.
Thank you. Thank you, sir. I think our time is up and we have exceeded by 1 minute. If there are no more questions, comments, I would like to end this. Dr. Pankaj, do you want to make a comment? I can see Dr. Pankaj joined in.
No, you appreciated the surgeons with whom you work. So I just wanted to take the credit for that.
Sir, the credit is all yours. Thank you. Thank you. Over to you, Komal. Thanks.
Thank you, ma'am. Now we'll move on to the next session. This session is the IPNOS session by Dr. Jatin P. Shah. The topic is precision surgery in differentiated thyroid cancer. And the chairpersons for the session are Dr. Jyoti Dabholkar, madam. Madam is president of ISTS, that is Indian Society of Thyroid Surgeons. And she's ex-HOD of Head Neck Surgery and ENT, KEM Hospital, Mumbai, and currently Senior Consultant, HN Reliance Hospital, Mumbai. Dr. Bipin T. Varghese, sir is Professor Head Neck Surgical Oncology at RCC Trivandrum. And Dr. Pankaj Chaturvedi, sir is Director of IPNOS and Professor and Head Neck Surgeon at Tata Memorial Hospital, Mumbai. I would like to request Dr. Jyoti Dabholkar, madam, to please introduce Dr. Jatin P. Shah.
So, hello everyone. Can you hear me?
Yes, ma'am, you're audible.
Yeah, okay. So, sir doesn't require, Dr. Jatin Shah doesn't require any introduction in this country at least. But I have few things to speak about himself, that the thyroid, and 79 when I was a resident, first year resident, he came to Baroda and he spoke on the prognostic factors about thyroid. And from that day on till today, it's about 44 years, he's teaching the world that thyroid cancer needs to be treated differently. And I remember his progression module from well-differentiated to anaplastic. And he said that time that any research and effort which should be in anaplastic and undifferentiated. That is where we have to reduce the mortality. These cancers are going to behave anyway and needs to be treated in a certain way. And I personally feel that all his life, he has been speaking about this. And this being a Thyroid Society meeting, I want to acknowledge that his contribution to this. And if somebody after Mr. Kocher is to be remembered for the rest of the century or whatever, is Dr. Jatin Shah. And not only he has spoken about this, he was criticized and he has data so well preserved. And he analyzed those data and showed to the world that what I'm speaking is correct and this is my data. I think heads off to you, sir. We really draw a lot of inspiration from you, and please continue inspiring us. Thank you so much.
Thank you, Jyoti. I hope you are able to hear me.
Yes.
Pankaj, are you able to hear me?
Yeah, we can hear you, sir. Very well.
Perfect. Thank you very much. Let me share my screen and I will proceed promptly. Okay. Before I begin, I want to express my appreciation to Dr. Asim Mishra, Dr. Pankaj Chaturvedi, Dr. Jyoti Dabholkar, all the dignitaries on the dais, my colleagues, my friends, and younger trainees. Thank you for inviting me this evening to share with you my views and my views and the views of in management of carcinoma of the thyroid gland. Zoom has quit. Are we still on?
Yeah, we are all on.
Okay, all right. Thank you.
We cannot see your presentation.
But we cannot see your presentation.
Dr. Shah, I think
There's something wrong at Varanasi.
yeah, his screen was frozen. No, we can hear each other. So there must be something at his end, Dr. Shah. He will join again, I guess. So Asim, once he joins as a delegate, quickly convert him into the panelist.
Yes, sir. Yes. He has joined. Sorry.
I am somehow not able to share my screen. Let me try again. Can you allow me to share my screen?
If you can send your presentation on email to Asim, he will be able to.
Okay, because I'm not able to share my screen.
So Asim should receive your email and he will just present it from Varanasi.
Okay,
And you
let me try that. Okay, I will send that momentarily. These are the
Asim,
problems of modern technology.
I know. Asim, are you listening?
Yes, ma'am, we are here.
Yeah, so the way I did it, you did it for sir also. Have you sent the mail, sir?
Yes, sir. It is just coming up. Yes, it has gone.
Okay. All right. So we'll be shortly on the lecture.
Yep. As soon as you are able to share, I'll be able to see it.
Yeah. Asim, he sent it to you, the presentation. He emailed it to you.
Oh, I think we got it. Okay, Jyoti, I think I'm able to share it. So let's proceed. Again, folks, my apology for the technical error. I don't know whether it was at my end, your end, as it may. Let's begin. So the title of my topic is precision surgery, and precision surgery implies something. It keeps on telling me that the Zoom is quitting unexpectedly. I don't know why. Resolve this problem.
Asim, have you got the presentation?
I'm seeing it the screen being shared, but every minute I'm getting a unexpected. So the management of thyroid cancer has been
So shall I share the presentation from Varanasi?
Dr. Shah? Dr. Shah?
Yes, ma'am.
Yeah, so I
Yes,
think Asim is asking whether he can try from there.
Okay, so let me stop screen share, and if
Asim? Asim?
Asim, वहाँ पे your mic is muted. So I think
I think we can start the presentation from here.
Yes.
yeah. So Dr. Shah, your screen is frozen. I think he has to log out first. Log
He
out
did.
as in
Yeah.
stop sharing. Yeah, now this is fine.
Okay. So, Asim, you start. Bring the first slide.
I think Dr. Shah got logged out. He is not
Yeah,
online.
he's not seen.
Yeah. So Asim, he will try logging in again. As soon as he does it, just make him the panelist.
Asim, can you hear us?
Yes, ma'am, we
Pankaj
can hear.
is-
We can
Yeah,
hear.
so make him a panelist and
Yeah, ma'am,
invite.
he has to join. He is still to join. As soon as he joins, we'll make him the panelist.
Okay. Because his presentation first slide is here.
okay, folks, are you able to hear me?
Yes, sir, we can hear you.
Okay, all right. So again, many apologies for this mess up, but be that as it may, all along in the past several decades, the management of next slide, please. You will have to change the slides because I don't have okay. Management of thyroid cancer has been based on preconceived ideas and beliefs. This trickles on from your attending surgeon, from your boss, from your seniors, from your colleagues. And this is simply based on myths and misconceptions. Uh, Sometimes it is based on long-standing institutional or personal philosophies, not supported by evidence-based data. I was making a comment about with Dr. Agarwal about nuclear medicine specialist from Tata Hospital. I had an interaction with one of her predecessors some 20 years ago, and he strongly told me that thyroid cancer cannot be cured without radioactive iodine. So I said, yes, sir. I did not want to argue. Such practices often lead to unnecessarily big operations in those patients who don't need them. And these practices often lead to incomplete operations in those patients who truly need aggressive and extensive operations to eradicate the locally advanced cancer. And the rationale behind such belief is that the surgeon does an operation, whatever sloppy operation he or she does, and then relies on adjuvant radioactive iodine treatment to patch up for incomplete surgery. Next slide. Precision surgery implies that it is practiced with the thorough understanding of the pathobiology of thyroid cancer and its natural history. Precision surgery requires thorough knowledge of anatomy and excellent surgical skills, delicate handling of tissues, and a properly indicated, thorough operation to avoid unnecessary adjuvant treatments. Next slide. So what is precision surgery? It's a surgical procedure undertaken after thorough understanding of the pathobiology of cancer, as I just said, selecting the right operation, performed with superb surgical skill based on tumor and patient factors and risk group stratification to minimize morbidity, complications, and sequelae of the surgery, while maintaining the highest degree of efficacy for cure and avoiding unindicated bigger operations and unnecessary adjuvant treatments. Next slide. So one of the common myths is that every patient with thyroid cancer needs total thyroidectomy. Because people think thyroid cancer is one disease, it is indeed a spectrum of different diseases. It's not one disease. Another myth is that all patients need postoperative radioactive iodine ablation. Postoperative TSH should be brought down to 0, and follow-up requires annual whole-body radioactive iodine scans. These misconceptions have percolated through decades to continue to practice this philosophy and not change any approach based on understanding of biology of the disease. Next slide. So let's look at the first myth. When the AJCC came up with the new classification of thyroid cancer, there was a strong recommendation by endocrinologists to split the T1 tumor into T1A less than 1 centimeter and T1B between 1 to 2 centimeters. In fact, the American Thyroid Association guidelines in 2009 recommended total thyroidectomy for all tumors larger than 1 centimeter. There was no data to support that. Next slide. So we presented data along with others which showed that the 10-year overall survival rate and recurrence-free survival rate for T1A and T1B, meaning less than 1 centimeter or 1 to 2 centimeters, is exactly the same at 10 years. So what are we squabbling about? American Thyroid Association was convinced, and in 2015 they changed the guidelines and recommended lobectomy for intrathyroidal tumors up to 4 centimeters. Next slide. Another myth is that size of the intrathyroidal primary tumor makes a difference. So suddenly, if the tumor is 3 centimeters, it's a big tumor. Therefore, patient should have total thyroidectomy and radioactive iodine. In fact, the risk of local regional failure, distant metastasis, recurrence-free survival, and disease-specific survival are similar for all intrathyroidal patients. Next slide. Here you look at patients with intrathyroidal tumors, disease-specific survival 100%. At 10 years, you cannot make it better. Recurrence-free survival is 98%. And that 2% recurrence is not in the opposite lobe, it is indeed in the central compartment lymph nodes. Next slide. So when you break them down by tumor size, T1 and T2, meaning up to 2 centimeters and 2 to 4 centimeters, superimposed on the green line above, is exactly the same. So there is no reason to squabble about the size of an intrathyroidal tumor. It is those tumors with gross extrathyroid extension, T3 and T4, where you see progressive decline over the years in prognosis. Next slide. And it's not only our data from the National Cancer Database of the American College of Surgeons of nearly 62,000 patients followed up to 16 years show that the long-term survival for papillary carcinoma, whether it's up to 2 centimeters or 2 to 4 centimeters, is essentially the same. Next slide. Another misconception is that multifocal papillary carcinomas are more aggressive and they should be more aggressively treated because they have worse outcomes. In fact, oncologic outcomes are comparable in patients with unifocal or multifocal disease. Next slide. So here is our own data at 5 years on patients undergoing lobectomy for unifocal or multifocal disease. Exactly superimposable lines. Next slide. And go back please. And the recurrence-free survival is also exactly the same. So multifocality is not an adverse feature for prognosis. Next slide. And here you look at 10-year outcomes of patients undergoing lobectomy for unifocal and multifocal disease. All 5 parameters of outcome, contralateral lobe recurrence, nodal recurrence, distant metastasis, disease-specific survival, and overall survival are exactly the same in patients with unifocal or multifocal disease. So the focality is not a prognostic factor. Next slide. Another myth, as I said earlier, was that every patient with thyroid cancer needs a total thyroidectomy. Next slide. So we compared on a matched pair analysis over nearly 900 patients, consecutive patients, with similar demographics and similar tumor criteria undergoing lobectomy and total thyroidectomy. Next slide. So there were 362 patients who had lobectomy and 522 for one or other reason underwent total thyroidectomy. Next slide. If you again look at the 5 parameters of outcome, local recurrence, neck recurrence, distant metastasis, disease-specific survival, and overall survival are exactly the same whether they had lobectomy or total thyroidectomy. The result of this is the 2015 ATA guidelines changed their recommendation to lobectomy for intrathyroidal tumors up to 4 centimeters. Next slide. Next slide. And again, not only our data from American College of Surgeons, 62,000 patients, the largest data ever available. At 15 years, the survival for lobectomy and total thyroidectomy is exactly the same. So that debate is pretty much over, that intrathyroidal tumors, whether they are unifocal or multifocal, are equally well treated regardless of their size, as long as they are intrathyroidal by lobectomy without the need for total thyroidectomy. Next slide. So this is our recommendation for lobectomy. Unifocal tumor confined to one lobe with the opposite lobe normal, whether it is small or whether it is large, as long as it is intrathyroidal, the lobectomy is sufficient. Similarly, whether it is unifocal or multifocal, if the disease is confined to one lobe with the opposite lobe normal, lobectomy is curative. Next slide. We would recommend total thyroidectomy only if there is gross extrathyroid extension, bilateral gross tumor nodules. I'm not talking about microscopic foci, bilateral gross tumor nodules. A goiter with large nodules on the opposite normal lobe, which is not opposite lobe, which is not normal. So bilateral nodules. And the need for total thyroidectomy to justify the use of radioactive iodine, either due to distant metastasis or nodal metastasis. Next slide. So another myth is that you do a lobectomy and the pathology report comes back 1 week later, margin is positive, microscopic extrathyroid extension. The knee-jerk reaction is patient goes for completion thyroidectomy and radioactive iodine. Or if you have done a total thyroidectomy and the margin comes back positive, the knee-jerk reaction is to proceed with radioactive iodine. My response to that would be measure the patient's thyroglobulin before you pull the trigger on radioactive iodine. Next slide. In fact, microscopic positive margin has no impact on disease behavior. Here is our own data at 10 years. The two green lines on top represent patients with negative margins and patients who had microscopic positive margin, compared to those shown in red line who had gross extrathyroid extension. So microscopic presence of margin or a positive margin does not have any impact on outcome. Next slide. For that reason, microscopic positive margin or microscopic extension of tumor to the margin is no longer upstaging the tumor. The AJCC removed upstaging the tumor to T3 due to microscopic extension. So that is no longer upstaging the tumor. In order to call it tumor T3, you must have gross extension. And if it is anterior, it is T3B involving strap muscles. And if it is posterior, involving trachea, larynx, esophagus, or the nerve, it would be a T4 tumor. So the impact of this data was that the staging has been improved and modified to remove the knee-jerk reaction of microscopic extension. Next slide. What matters actually in thyroid cancer management, assessment, and treatment are the importance of prognostic factors. These are prognostic factors from various institutions, Mayo Clinic, Lay Clinic, Karolinska, and Memorial. Surprisingly, all of them show the same prognostic factors on multivariate analysis which impact upon outcome. Patient's age, histological grade, distant metastasis, gross extrathyroid extension, or tumor size. Note that in none of these independent factors impacting on prognosis, treatment of the tumor, extent of surgery, or radioactive iodine is identified as an independent prognostic factor. So what does it tell you? It tells you it is the biology of the tumor which determines outcome, not we do in the operating room, or not what the nuclear physician does in the nuclear medicine suite. That is all a secondary prognostic impact rather than the biology of the tumor. Next slide. So these prognostic factors allow us to develop risk group stratification. Patients who are young, younger than 55, generally females with intrathyroidal tumors up to 4 centimeters, well-differentiated carcinoma, and no distant metastasis fall into the low-risk category. Conversely, older patients, generally men, with larger tumors or gross extrathyroid extension, poorly differentiated histology, or presence of distant metastasis puts them into the high-risk category. And then you have young patients with bad cancers or old patients with good cancers, and they fall into the intermediate risk group category. Next slide. If you look at the long-term outcome, 10-year outcome, in the low-risk group, disease-specific survival is 100%. You cannot make it better, regardless of what you do. In the intermediate risk group, also it is 98 to 99%. It is only in the high risk group that we lose patients with progressive attrition in outcome as years go by. Next slide. So now we come to the administration of radioactive iodine. These are the ATA guidelines of 2015. In low-risk patients, there is no data to support radioactive iodine, as Dr. Agarwal said, that at Tata Hospital, it is no longer being given. And I applaud them for that because we follow the same philosophy. In the low-risk group, again, there is no evidence for tumors up to 4 centimeters, which are intrathyroid, that there is indication for radioactive iodine treatment. Even in the intermediate risk group with microscopic extrathyroid extension, if there is no persistently elevated thyroglobulin, there is no role for radioactive iodine in low and intermediate risk group patients. Next slide. The evidence available for the efficacy of or the role of and the outcome from treatment is shown only in patients with T4 tumors, meaning those with gross extrathyroid extension and those with distant metastases. And even in those two groups, it is not a randomized trial data. It is observational data that shows that there is a role for radioactive iodine. One of the earlier speakers made a comment about the role of radioactive iodine in pediatric patients. And I totally agree with that. Pediatric differentiated carcinoma is highly iodine avid. And in those patients, I would recommend that you do tracer scan. Often you will find miliary occult pulmonary metastases which were not seen because the chest X-ray was negative. And these children will have a very high post-thyroidectomy thyroglobulin. Next slide. And finally, the moment you make a diagnosis of papillary carcinoma, the knee-jerk reaction is schedule the patient for surgery. Do we need to operate on every papillary cancer? Data from Japan by Miyauchi and Sato, as well as Ito rather, as well as our own data show that low-risk intrathyroidal small papillary carcinomas can be left alone because only 10% of them may show minimal growth. 90% will remain stable throughout patient's life. Next slide. Here is our own data as of last year. We now have an active surveillance trial for the past 10 years. We have nearly 620 patients now accrued on this trial. And as of last year, only 11% transition to surgery. So 90% of patients are still being followed. And these all 11% were not due to increase in the size of the tumor. Some patients requested that they would rather have the surgery. Some were scared, afraid, or apprehensive. But the reason of disease progression requiring surgery was shown only in 15 patients out of 560, 2.7% of patients. So 97% of patients can be safely followed on active surveillance without the need for surgery. Next slide. So ATA guidelines now accepts this, that a cytologic diagnosis of a primary thyroid malignancy will almost always lead to thyroid surgery. However, an active surveillance management approach can be considered as an alternative to immediate surgery in patients with low-risk cancers. Next slide. So let us summarize what have we done so far. Thyroid cancer is primarily a surgical disease. Surgery is the most effective and curative treatment for locoregional disease. Proper surgery is crucial for achieving cure and to minimize the risk of local recurrence as well as surgical morbidity. All adjuvant treatments such as RAI, radiotherapy, or systemic therapies are truly adjuvant treatments after complete surgery. Adjuvant treatments do not make up for inadequate or incomplete surgery. And precision surgery is indeed complete surgery. Next slide. Therefore, the initial surgical treatment for intrathyroidal papillary carcinoma is an extracapsular thyroid operation, which may be a lobectomy or a total thyroidectomy. Next slide. Pay special attention to not leaving thyroid tissue advertently or inadvertently behind. The common practice of putting a mixture clamp at the upper pole should be condemned because that's where you leave some thyroid tissue. Identify the superior thyroid artery and its branches above the upper pole of the thyroid gland and take those vessels in the extrathyroidal space. And do not forget the pyramidal lobe. Take it as long as it goes up. And don't leave any thyroid tissue at the tuberculum zuckercandle or behind the recurrent nerve in the tracheoesophageal groove. If you do this, and if you have done a total thyroidectomy, patient will have no measurable thyroglobulin and therefore no need for radioactive iodine treatment because there is no remnant ablation. You have not left any remnant behind. Next slide. So the next step is understanding the biology of thyroid cancer, appreciation of the prognostic factors, and employing risk group stratification delivers cost-effective treatment. Next slide. So thyroid cancer is indeed a predictable cancer which goes along this tumor progression model. All thyroid cancers arise from the thyroid follicular cell, and majority of them will differentiate into a papillary or a follicular carcinoma. Nearly 85% will present to you with that diagnosis. About 10 to 15% of patients will progress further along this tumor progression model and present to you as a tall cell or an insular or even a poorly differentiated carcinoma with its negative impact on prognosis. And rarely, less than 2% of the times, they would progress into anaplastic carcinoma with an ugly outcome, although there is some ray of hope now with newer drugs, and I will expand upon that in a minute. Next slide. Now, as this tumor progression is taking place biologically within the tumor, we don't need a petri dish to show that. There are clinical features that will lead you to think that tumor progression is taking place. Tumor size will get bigger, extrathyroid extension will become manifest, distant metastasis may appear, and mortality will increase. Next slide. So logically, you would ask me a question, what evidence do we have to support this progression model in vivo? Well, first of all, if you look at a patient with a poorly differentiated carcinoma, for example, the tumor has a heterogeneous histomorphology with areas of well-differentiated carcinoma and poorly differentiated carcinoma in the same tumor, implying that the tumor is in transition from well to poorly differentiated carcinoma, piece by piece, cell by cell. Another indirect evidence is that you notice progressive anaplasia in recurrent well-differentiated carcinoma with more aggressive variants appearing with each recurrence leading to poorly differentiated carcinoma or even anaplastic carcinoma. Take, for example, a patient who has 5 or 6 recurrences and pull out all those slides and study each recurrence under the microscope, and you will see progressive anaplasia, and the last one would be a poorly differentiated carcinoma. So we do have evidence to support this progression model. Next slide. Now, based on this progression model, you divide your patients into 3 groups. Those which carry good prognosis, nearly 85% of patients with papillary and follicular carcinoma. Those who carry a bad prognosis, poorly differentiated carcinoma, about 10 to 15%. And those who have an ugly outcome, anaplastic carcinoma. Next slide. So in the good group, carrying good prognosis, your precision surgery is going to be conservative surgery, which is extracapsular lobectomy or extracapsular total thyroidectomy based on the tumor characteristics, whether there is gross extrathyroid extension or bilateral nodules or not. Otherwise, all unilateral, intrathyroidal, unifocal or multifocal tumors will suffice with lobectomy. And here, the precision surgery is just doing that, an extracapsular thyroid operation. In the intermediate risk group with a poorly differentiated carcinoma, your precision surgery is going to be aggressive surgery, which may be a total thyroidectomy and more to achieve a R0 resection. Leaving tumor behind and relying on radioactive iodine or radiation therapy will not give you the desired outcome. Your surgery by necessity must be complete. It may involve tracheal resection, esophageal wall resection, even rarely laryngectomy, but that will save the patient's life. And for anaplastic carcinoma, there is work in progress. Test this tumor for BRAF V600E mutation. If that is present, these patients would benefit, at least some of them would benefit with induction treatment using dabrafenib and trametinib, both of which are BRAF active in BRAF positive tumors. So there is something to be said about anaplastic carcinoma. We have made some progress there. Next slide. Keep going next. Okay. Treatment failure occurs only in those patients who present with gross extrathyroid extension shown in purple compared to patients with intrathyroidal tumors. Recurrence rate, whether it's local, nodal, or distant, for intrathyroidal tumors is in the range of 10 to 15%. But for those who manifest extrathyroid extension, treatment failure, whether it is local recurrence, nodal metastasis, or distant metastasis, occurs in nearly half of the patients. So the message is this is where we need to be aggressive. Next slide. Next slide. Go on. Keep going. Okay. Now, where does extrathyroid extension take place? As I said earlier, if gross extrathyroid extension is anterior, it involves the trap muscles, easily manageable. But if it is posterior, it may involve the nerve, the pharyngeal wall, the esophagus, the trachea, or the larynx, all of which require aggressive surgery. Next slide. The principle of surgery for extrathyroid extension is that you must remove all gross tumor, securing negative margins. Preserve functioning structures if you can, and use adjuvant radioactive iodine or radiation therapy, but only after complete surgical excision. Next slide. If you achieve a R0 resection, you convert essentially an incurable patient to nearly 96% 10-year cure rate. If you leave disease behind, that's going to drop by 30% in long-term survivorship. So the message here is aggressive surgery to achieve R0 resection for patients with gross extrathyroid extension. Next slide. So I come back to precision surgery. Precision surgery for intrathyroidal tumors requires extracapsular lobectomy or total thyroidectomy. It creates an effective surgical ablation of thyroid cancer and avoids the need for remnant ablation with radioactive iodine. Precision surgery for patients with extrathyroid extension require a R0 resection. Next slide. Now, a comment about aesthetics. Much has been practiced and shown in the literature about doing a thyroidectomy with the robot through transaxillary approach, transmemory approach, going from behind the skull, hairline, and so on and so forth, and transorally. All of this, in my opinion, are producing excessive trauma to normal tissues. If you select an appropriate natural skin crease for surgery, generally higher than what you are used to, a skin crease at the level of the cricoid cartilage, and use meticulous closure of skin incision, avoid excessive stretching of skin flaps through unduly small incisions. All incisions heal sideways, whether it is 1 inch, 2 inch, or 3 inches. Paolo Miccoli in Mewat used to do the operation with a 1 inch incision with a hypertrophic scar of that 1 inch incision because of excessive stretching of the skin flaps. Remote access surgery, transaxillary or transoral, causes excessive tissue trauma and is feasible only for small tumors. Next slide. Here is a patient who has undergone total thyroidectomy. Show me the scar. Her scar, I will show you, is right there, along a natural skin crease overlying the cricoid cartilage. So this is simple thyroidectomy. Next slide. Here is thyroidectomy and central compartment lymph node dissection. The incision is here, much higher than you would normally be inclined to put at this point. So this should be the goal should be to a natural skin crease at the level of the cricoid cartilage. Next slide. And here is one with bilateral lateral neck dissections. Do not do a hockey stick incision going up in the neck. That will give you an ugly scar. A simple transverse incision, as far back as you want to go, is fine. You can go up to and even over the trapezius if you need to do that, but keep it simple transverse incision. No hockey stick, no vertical component. Next slide. So, in summary, precision surgery in 2024 is undertaken after a balanced judgment of tumor and patient factors. Precision surgery achieves complete tumor removal with a curative intent. Precision surgery often avoids the need for adjuvant treatment. Precision surgery is safe and leads to minimal complications. It does not inflict excessive tissue trauma and gives excellent cosmetic outcomes. Precision surgery is curative, and it is the state of the art and science in thyroid cancer treatment in 2024. Next slide. I thank you for your time, and I would be happy to take any questions.
Thank you, sir. Thank you so much. We really appreciate.
Yeah. Asim, any questions
stop
coming?
sharing the screen.
Asim?
Good.
No questions so far.
No, if you have
So,
got a
Dr.
written
Shah,
question.
only one question that I would like to ask for the benefit of the audience is about the molecular markers, because these days everybody keeps talking about the molecular markers, especially when you are having a low risk 1.5 centimeter, 1 centimeter tumor, to classify them into biologically aggressive, whether to do molecular markers.
Okay, so I think it's a very good question, and I will answer your question in two sections. First is how often I personally have requested molecular markers. And in over 50 years of thyroid cancer surgery practice, I've ordered it 2 times. And I've done a few thyroid operations. Now, question 2. Molecular markers is not like a pregnancy test. It doesn't give you yes or no. It gives you percentage probability of cancer. You can guess the percentage probability of cancer by patient's age, gender, tumor size, sonographic findings, such as hypervascularity, irregular border, microcalcifications, and by the cytology. If you have a 3 centimeter nodule in the thyroid lobe in a patient who is 40 years old, cytology is inconclusive, but the sonogram shows increased vascularity and microcalcification, I don't need molecular markers. So molecular markers truly do not add value to clinical decision making or selection of treatment. Now, if you are in a tertiary care research center, and if you are doing a study to assess the value of molecular markers in selection of adjuvant treatments, in selection of induction therapy on a clinical trial, or what have you, it is fine. But in day-to-day practice in the community, it has little value, it is expensive, and it does not impact upon your selection of the operation.
One more question for the benefit of the students is a concept quite widely used in certain nuclear medicine facility is stimulated thyroglobulin. So when you do the surgery, so rather than looking at the baseline unstimulated, whether stimulated thyroglobulin has a better value than the unstimulated.
The short answer is yes, but the bigger explanation is it doesn't make one bit of difference. There is no patient whose unstimulated thyroglobulin was below 1 and the stimulated thyroglobulin was elevated has ever died of thyroid cancer. So there is no shred of evidence there. I do not do stimulated thyroglobulins because it has no value. Now, if the patient is apprehensive and wants to increase his or her apprehension, I would do a stimulated thyroglobulin to make her more nervous because there is nothing you're going to do about it. And I would not necessarily recommend radioactive iodine treatment in the absence of unstimulated elevated thyroglobulin only because the stimulated thyroglobulin is high. So in general, in day-to-day practice, unstimulated thyroglobulin is fine as long as the patient's TSH is within normal range.
Dr. Shah, the molecular marker, I'll just extrapolate a little bit, that in diagnosing there is hardly any role. India will never be able to afford, even if it is cost has come down to 25,000. Anaplastic is like a way to go because all the targeted therapy will be targeted only by doing a molecular. But the one which is in between where you have done a complete surgery and now the patient is coming back with a recurrence and you scratch your head that is he having some genetic predisposition towards bad behavior? Do you think that this is a group of patients where we should be really doing molecular markers at the first recurrence and see whether they have something?
I would even go before the first recurrence. If your patient has a locally advanced cancer where you are going to anticipate the need for adjuvant treatment, either it is well differentiated or a poorly differentiated carcinoma, the number of molecular markers can be studied. They could be BRAF inhibitors, they could be MEK inhibitors, MAP kinase inhibitors. Based on those, you would have selective drugs available either to use as induction treatment prior to surgery, adjuvant treatment post-surgery, or therapeutic treatment for recurrent disease. But all of these not in a private practice setting because all of this is still work in progress. So if your patient enters a clinical trial at an institution for any of these three indications, pre-treatment, advanced tumor, or poorly differentiated carcinoma, post-treatment, again, same histological criteria, or recurrent disease, same histological criteria. Where there are drugs available inhibiting specifically BRAF or MEP kinase or TKI inhibitors, then you can justify the use of that to accrue more patients in that clinical trial to justify. I don't know whether Greg gave his talk to your group today or not.
He gave.
So he has an active clinical trial going on preoperative lenvatinib, and his colleague Lori Worth has a trial on selpercatinib as a new adjuvant drug prior to surgery to improve the efficacy of surgery and make a quote unresectable tumor resectable. But this is still work in progress. It is not a standard of care. So I would not use it in a private practice setting. If your patient is in a major institution in a clinical trial absolutely, you must do it. Because that is how we will learn.
Dr. Shah, I have a question.
Yes, sir.
So, from your talk, we understand that there is not much role of minimally access thyroid surgery or a robotic surgery for thyroid malignancies. However, where do you place developing surgical skills through robot or the minimal access surgery for thyroid? Where do you place it? Should we acquire those skills or no?
So I think, I'm not against robots or minimal access surgery, but I'm not an enthusiast of that either. If you teach your trainees proper surgery, i.e., attention to detail in terms of choosing the incision, choosing a natural skin crease, avoiding a vertical component to the scar, and a proper technical closure, you will not have a visible incision, scar in the neck. And I showed you 3 examples. For example, we have a habit of cutting the skin and the platysma through the same incision. I don't do that because that is going to draw your scar inwards as the platysma heals. The fibrosis of platysma is going to pull the dermis in, and the scar will be horrible. So I would incise the skin superficial to the platysma and cut the platysma a centimeter below or above the skin incision. And it will be closed as a second layer, but the 2 suture lines will not superimpose. These are some finer techniques to get a aesthetically better scar. Transoral surgery, in my opinion, is too much trauma for a small tumor which needs a 1.5-inch incision, for which you are going through the mouth, violating the central compartment. I completely disagree with that approach.
Thank you, sir.
So, Asim, any more questions in writing?
I think there are no more questions.
Okay.
Excellent.
So, sir, I cannot thank you enough because, what I was just saying in your introduction, I don't want to introduce in the standard way, but what you have done for complete head and neck, but for thyroid, I think is phenomenal. And generations and generations and centuries will remember for your work. And we really truly appreciate that you have never refused an invitation to speak and teach and stimulate the younger minds. And thank you so much to do this always. Thank you.
Jyoti, Pankaj, Asim, all of you, thank you very much. I enjoyed the participation, and I hope that we have tried to clarify some misconceptions, particularly for the younger people as they grow and develop into expert thyroid surgeons. Good evening, good night, and enjoy the rest of the meeting.
Thank you, sir. Thank you.
Thank you, sir.
Asim? Asim? Your mic is muted, Asim.
Yes, sir.
So this was the last talk, na?
We have another talk. We have the record. Dr. Randolph's session is also there, sir.
Oh, okay. Excellent work, Asim and Komal. Excellent work.
Thank you, sir. So we'll be coming to our last session of the day. And for this session, the chairpersons are Professor Ashok Shenoy. He's ex-professor and head of Kidwai Memorial Institute of Oncology, and he's a director of oncology at Indore. And Dr. Madan Kapre. Again, he doesn't need any introduction. He is the father figure for thyroid surgery in India. He has been teaching Thyroid Gurukul in Chikaldhara, and he's the director of Niti Clinics, Nagpur. We welcome you, sir. Unfortunately, Dr. Randolph could not join us today because of another meeting. So he has sent us a recorded presentation, and we'll be playing the presentation.
Hello, everyone, and I welcome you to our lecture on advanced thyroid cancer treatment, neoadjuvant therapy. I'm Rick Randolph from Massachusetts Eye and Ear Infirmary, the Bertucci Endowed Chair in Thyroid Surgical Oncology at Harvard Medical School. And I am honored to be part of the Mahamana Thyroid Cancer Update 2024, given by both IFNOS and the Indian Society of Thyroid Surgeons. I welcome you to the meeting and to this lecture. Tonight, I'm going to give a discussion of advanced cancer treatment relating specifically to neoadjuvant therapy. So the real issue is, can we do better with surgery, which is certainly the most effective treatment for aggressive thyroid cancer, by judiciously adding chemotherapy prior to that therapy as neoadjuvant therapy. But these are my disclosures, basically research, institutional-based funding for several research projects as listed here. This is the view of the Charles River, which is just outside our office here at Harvard in Boston. I'd like to note the importance of my research colleague. The central group is my research group, which is involved in much of this work, and all of surrounded by all of my colleagues, multidisciplinary colleagues that help me provide the care for my patients and as part of my research program. So these are the 5 points that I want to make during this lecture. I again apologize that I can't be with you in person, but appreciate the opportunity to present this material to you and hope you will enjoy it. First is defining advanced disease and some of the problems associated with that, and also the importance of next generation sequencing testing in order to molecularly define the underpinning molecular alterations that occur in advanced thyroid cancer treatment. So I'll start with that. And so basically, aggressive disease is not well or uniformly defined, although you certainly know it when you see it. This is a patient with multiple scars on her neck, recurrent disease after 800 millicurie radioactive iodine. And so you know certainly this is one example of advanced disease where skin needs to be resected as part of the surgery. But what is the definition? Again, this is has been now provided by this article, which has been led by Dave Shanka. This is a joint statement from the International Thyroid Oncology Group and the Head and Neck Society that offers some definitions of advanced disease and its targeted treatment. We know that gene-specific therapy is available for radioactive iodine refractory differentiated thyroid carcinoma, and we have a number of molecular targets that exist as listed here in papillary carcinoma, follicular carcinoma, peripheral cell, currently called oncocytic carcinoma, as well as port differentiated carcinoma. So we have multiple molecular targets. In fact, thyroid cancer is one of the highest cancers with molecular targets which are druggable in the range of solid tumor malignancies. So let's go ahead and move forward here. Why is the management of advanced cancer so important? We know that advanced extrathyroidal extension has associated with higher risk of recurrence and lesser survival. We know that this occurs in about 13 to 50% of DTC patients. And we know that when it occurs, the strap muscles, RLN, trachea, and esophagus, as well as larynx, are affected in that order. Again, RLN invasion is the second most common foci of disease when disease presents with extrathyroidal extension. We know, though, that we can apply some science to this. We know that we can identify patients with extrathyroidal extension, often based on preoperative history, based on preoperative exam, based on preoperative imaging, especially. And we know that the surgery for invasive disease is meaningful because this is important for the surgeon to know, because the resection of non-thyroidal structures increases the surgical complexity, requires advanced surgical skills, increases the surgical morbidity, and decreases the patient's quality of life. We know that there is limited information on non-neoadjuvant based therapy. That is, you just take the patient who presents with advanced disease, bring him to the operating room. We know that that leads to low rates of R0 or R1 resection, as noted in both of these studies, one from a more modern era from Memorial Sloan Kettering, and another older one by Dr. McCaffrey, showing that the rate of gross clearance is low in patients who are not treated with neoadjuvant therapy, that are just brought right for surgery. Again, these studies have been hampered, as I mentioned, with the former lack of definition of advanced disease. So can we do better? And the idea here is, with neoadjuvant therapy, might we be able to obtain oncologically more secure margins? And might we able potentially even to offer less morbid initial surgery through the offering of neoadjuvant prepared surgical procedures? We do have a limited experience with cytotoxic chemotherapy prior to DTC surgery. And it looks like there is, at least, again, this is quite different than the targeted therapy that I'll be discussing today, but it looks like there is at least a signal as compared to historical papers on unprepared patients brought to surgery, that at least with in these series with cytotoxic chemotherapy, it looks like there is some signal suggesting improvement in rates of R0 resection. We also know that there is a history of TKI therapy in other solid tumors, which appears to be tolerated well. The example I give here is cytoreductive nephrectomy for renal cell carcinoma, appears to be tolerated well. And again, this is in advance of complex abdominal surgery. And there is also a history of borderline resectable pancreatic cancer being treated successfully with neoadjuvant therapy, which is in fact endorsed by NCCN. So there are other solid tumor examples where neoadjuvant therapy with targeted TKI therapy is been shown to be safe and in fact effective. So let's look at what we have right now in the literature and what clinical trials are going on. I've divided this neoadjuvant space for thyroid disease into anaplastic thyroid carcinoma, the retrospective studies and clinical trials that are underway, the neoadjuvant therapy for RET altered cancers, the retrospective studies, clinical trials that are underway, and then neoadjuvant therapy when the NGS testing comes back disappointingly negative, and this is offered agnostically, neoadjuvant therapy in the setting of no targetable, druggable NGS testing. So those are the three spaces that I'll talk about. And so we'll start again with the therapy, retrospective therapy of BRAF-directed therapy, neoadjuvant for ATC. This has been reported from MD Anderson, surgery after BRAF-directed preoperative neoadjuvant therapy, a retrospective cohort. This looks at actually a small number of patients. The one I'm going to concentrate on neoadjuvant BRAF-directed therapy. This is with BRAF inhibition and MEK inhibition with dabrafenib trametinib. This is just 32 patients is the basis of this neoadjuvant, this arm of this neoadjuvant trial, double therapy with neoadjuvant therapy prior to surgery. But it clearly looks like there is a signal. And so if you look at the uppermost curves, that you see that neoadjuvant followed by surgery as compared to upfront surgery, that clearly there is a signal, again, small number of patients, retrospective analysis, where overall survival and progression-free survival is favorably affected by the giving of in BRAF mutant cancer neoadjuvant therapy, dabrafenib and trametinib prior to surgery. And so clearly a strong signal there. In fact, if you look at the waterfall plot, we have the largest tumor reduction by 61%, median of 61%, largest tumor reduction. And this occurs in 70% of patients treated with neoadjuvant therapy in this way. You could see if we look at if we place these patients when they present into an invasive class, unresectable, severe, moderate, and mild, you can see in general with the Schenke plot that there is a downshifting of disease to less severe degrees of invasion, permitting more successful surgery. And so there's clearly a signal there that BRAF-directed neoadjuvant therapy, admittedly small series, retrospectively analyzed in this particular setting of BRAF-mutated anaplastic carcinoma. And so the clinical trial, which prospectively studies this therapy, which will actually be dabrafenib, trametinib, and immune therapy, is now underway, centered from Mark Luferio and MD Anderson. And again, this study is not complete. It's accruing successfully, and we will have prospective clinical trial data looking at this question in the future, not completed now. We'll move now to the next region of neoadjuvant therapy for advanced cancer, which is in the setting of RET alteration. This is typically point mutations for medullary, but also can be RET fusions, which occur in a subset of papillary thyroid carcinoma. These were formerly called RET PTC RET altered fusions for DTC. These are not point mutations, but still RET alteration subject to RET inhibition. Two different RET inhibitors, selpercatinib and pralsetinib. These are based on the libretto study, which shows the utility of selpercatinib in distant metastatic disease. You can see a very favorable signal from selpercatinib given to RET altered cancers with this waterfall. This is for metastatic disease. You can see also the ARROW trial showing similar, very favorable waterfall plot for pralsetinib. So again, pralsetinib and selpercatinib been shown in distant metastatic disease to have very successful response rates. And so now let's look at what is known about selective RET inhibition for either NPC with RET point mutations or RET altered fusion DTC. And so again, this is a very small case series. This is 4 patients who were treated in MD Anderson with RET altered cancers that presented with widespread invasion, treated with selective RET inhibitors, specifically selpercatinib, and then it looks at the signal here. So again, RECIST change 32%, a median morbidity change score is reduced, and RLMs can be sometimes preserved. You can see here pictures before and after the selective RET neoadjuvant therapies, so surgery with a much reduced tumor distribution. Again, this is a case series of 4 patients retrospectively analyzed, but clearly, although small number and retrospectively analyzed, clearly a signal here. And so you have favorable tolerance to this agent, these very selective agents, and a calcitonin, corresponding calcitonin drop as well. It's the radiographic shrinkage that you can see is dramatic. And so basically, clearly a signal here. And so this clinical trial, also out of MD Anderson, is underway. It is accruing well. And so this is a ITOG, International Thyroid Oncology Group study. This is underway. Again, prospective confirmation of this selective RET inhibition prior to advanced RET altered cancer surgery, suggested by retrospective analysis, is underway, and we'll have prospective clinical trial data relatively soon. Now, finally, the last space is looking at when your NGS testing comes back disappointingly negative. And so I'll review this now in the final slides. This is based on a collective, retrospective analysis, again, from University of Sydney and at Harvard, where we combined patients that had been treated with neoadjuvant therapy. This has just been accepted for publication, and it looks at a series of patients looking at change in both invasive thyroid class and surgical morbidity complexity score. This is a unvalidated measure that we've come together creating with MD Anderson and Mohan Kettering here at Harvard, looking at a number of different features of the invasive cancer, looking at surgical complexity, morbidity to the patient of that surgery, the patient morbidity associated with that resection. And so we come up with a score, and this score basically becomes lower and lower as we treat with neoadjuvant therapy, and then we compare that to the final surgical score that's done at once the surgery is done. We look at the percent receiving surgery and the percent having R0 and R1 resection. But again, this is a retrospective analysis from these two centers, 17 subjects. It's a range of histologies, papillary, medullary, follicular, oncocytic cancer, and anaplastic, with a range of different mutations. And we find overall quite favorable reductions in the MMN score. Again, that's a global gestalt score of what the surgery would mean to the patient. And so you can see that there's overall a downshifting of this MMN scores, suggesting shrinkage of the tumor and reduction in the intensity of surgery that would be required. We also see a similar downshifting in general from the different invasive thyroid class scores, patients presenting with this and having this improved with neoadjuvant therapy. And then we look at the individual potential R2 interfaces that are identified radiographically, and we can see overall a downshifting of many of these cartilaginous, esophageal, and RLN R2 interfaces. We see here the waterfall plot for the largest tumor diameter change, which median is 37% with this neoadjuvant therapy, and we can see a favorable progression-free survival duration of at 12 months, 67%. There are some complications that can occur from neoadjuvant therapy that are listed here. And so we propose, based on this retrospective two-center analysis of a range of different agents used in a range of different histologies, this algorithm in the paper, which is to get NGS testing, base your neoadjuvant therapy on that NGS testing, and importantly, if the NGS testing is negative for any defined, understood, targetable NGS alteration, in the absence of ALK fusion, RET alteration, BRAF alteration, then lenvatinib is the kind of agnostic agent in that it is a little wider based TKI is the agent for which neoadjuvant therapy would be offered. And again, that I'll skip that, leads me now to the final clinical trial on that lenvatinib based agnostic algorithm. And this I'll describe now in my final set of slides. This is a multi-center phase 2 open label trial centered at Harvard, but opened at MD Anderson and MSK, using lenvatinib as a neoadjuvant therapy. Again, when the NGS testing comes back negative for otherwise druggable alterations. We have it open here at Harvard and MSK and Mohan Kettering. As you know, lenvatinib is a multiple tyrosine kinase inhibitor. That's why it has utility when there's not a targetable, druggable alteration on your NGS testing. In that way, it is agnostically offered to these patients with advanced disease without such a mutation. And it has been approved for locally recurrent or metastatic DTC. You can see here that this is the human kinome, and it shows the relative wider inhibition that a wider TKI inhibitor like lenvatinib provides. This drug was initially shown to be efficacious in patients with metastatic BTC. And this is the SELECT trial of Dr. Schlumberger, published in 2015. And this shows the really quite remarkable progression-free survival of 18 months compared to placebo of 3.6 months, with an overall response rate for patients with metastatic disease, for example, pulmonary disease of 65%. So this implies a 65% of patients have a 30% diameter and resist shrinkage in lesions in the lung with this therapy. So quite remarkable also that this remarkable high response rate also results in tumor shrinkage within the first 2 months of therapy. So when I read this paper, I thought this is an ideal agent. It quickly and broadly, agnostically provides tumor shrinkage to patients without any targetable otherwise NGS testing. And that shrinkage occurs within the first 2 months. So we leverage this information, understanding also that although it is has VEGF activity, lenvatinib was tolerated fairly well and only discontinued for patients with distant metastatic disease after prolonged therapy, and only 14% of those patients treated in the SELECT trial. So overall tolerated pretty well. For that reason, we selected this agent, and this is the algorithm. We see patients present with locally advanced extrathyroidal DTC. This is defined by radiographic cross-sectional imaging and laryngeal exam, basically. And then the patient is NGS tested. In the absence of any druggable alteration, lenvatinib is offered initially for 2 cycles, then re-imaged and offered additional cycles depending on their response to that therapy. We're accruing very well now. We have 23 of a target accrual of 30. Our primary outcome is, can we get the patient who is presenting with widely invasive disease and typically multiple RG interfaces based on preoperative imaging, can we get them to have a higher rate of R0 or R1 than we would expect based on historical controls? I'll show you just one case to show how meaningful this is. A 50-year-old presenting with a 4-centimeter invasive mass. So instead of just booking him for surgery, we booked him for a core ultrasound-guided biopsy for NGS testing. That testing came back without any targetable lesion. He was judged to be therefore a candidate for the lenvatinib trial. He received 4 cycles of neoadjuvant lenvatinib. He tolerated that well. And then he went in for what was ultimately an R0 resection. This is his presentation on the left. On the right, you see not a dramatic shrinkage of the tumor, but the tumor becomes, after lenvatinib, a little bit shrunken, but a little bit more nodular and less widely invasive. And here you can see that change after neoadjuvant therapy. And he basically had an R0 resection. We needed only to resect the right recurrent laryngeal nerve, which was still embraced by the tumor, but the trachea, esophagus, and prevertebral fascia were free. So that is the 3 areas of neoadjuvant therapy, all characterized initially anaplastic, red altered, and agnostic, all initially investigated with retrospective, relatively small patient series, and all being followed up with clinical trials, which are obtaining prospective data to give us more information soon about the utility of neoadjuvant therapy in these different molecular presentations. But clearly a very strong signal suggesting this will be a significant alteration in our landscape of treating advanced thyroid cancer. I want to finish with one last piece as an otolaryngologist and neck surgeon that I think is really was unexpected and is quite remarkable, and that is the, as you know, patients who present with advanced disease often will present with RLN invasion and vocal cord paralysis. This is, as I mentioned before, the second most common structure outside of the thyroid that is affected by invasive disease, the recurrent laryngeal nerve. We have a series of patients with retrospective look at 3 different centers where we see a resumption of vocal cord function in a patient who presented with preoperative vocal cord paralysis after neoadjuvant therapy. Obviously, this then causes one side of the larynx to wake back up and function normally, and this expands surgical options very significantly. We don't have the denominator here, but we know that if in these 3 centers over a year or 2 of patients being offered neoadjuvant therapy, if we have a study of these patients, we think that there is a significant signal, and that this is one of the other potential outcomes of neoadjuvant therapy, that is the resumption of vocal cord function. We call this the Lazarus effect, referring to Lazarus who arose from the dead. This is published recently in Thyroid, and looks at basically, I'll just briefly discuss retrospective review. We looked at 7 patients that we gleaned from our records, patients treated recently with neoadjuvant therapy in 3 centers. These are all patients who presented with vocal cord paralysis as they presented with their advanced disease, 6 anaplastic and 1 papillary carcinoma. These are the genetic alterations in those patients. And in those patients, we see that there was a resumption in all these patients of vocal cord function with the neoadjuvant therapy prior to being brought for surgery. The median time to return to vocal cord mobility was 3 months. And interestingly, of these 7 patients who presented with paralysis at presentation, all of these patients had a resumption of vocal cord function prior to surgery, and only 1 of them required nerve resection. So this is really quite, I think, remarkable. I think this implies that there's a significant signal in this regard that this can occur. We may not have all patients with vocal cord paralysis have a resumption of function, but certainly if we can glean 7 with our initial experience, which is nascent in neoadjuvant therapy, it means that's clearly a signal. And so basically, I think it's quite remarkable, and we will have to do additional studies to determine what is the likelihood of vocal cord function resumption. It also gives us a little understanding of the pathophysiology of vocal cord paralysis in the setting of invasive disease. You know, we were all trained that once the nerve was out, it would stay out forever, but I think it depends on how quickly the nerve was invaded, perhaps, the extent of invasion, the histology of invasion may be important, the agent used for neoadjuvant therapy may be important, the duration of that agent may be important, a lot of things that we still speculate about, but a very interesting added potential benefit to patients presenting with advanced disease, having neoadjuvant therapy, and having resumption of vocal cord function. So quite remarkable. ITOG, International Thyroid Oncology Group, has put together a leadership group to look at this issue, a think tank, to try and define the optimal outcome parameters that should be studied in neoadjuvant studies. And we are also in the process of setting up a neoadjuvant registry to study these patients more thoroughly. So I have want to thank again the Tata Hospital, IFNOS, and the Indian Society of Thyroid Surgeons for their time in allowing me to speak. I have reviewed neoadjuvant therapy and looked at the problems that advanced disease has in terms of the need for more acute definition so that we can study it more appropriately. We looked at the 3 spaces as I kind of construe them as anaplastic, red altered, and agnostic spaces for neoadjuvant therapy, and looked at the very limited, as of now, retrospective information we have, clearly showing a signal in many patients, but still nascent in our understanding, and that each of these spaces then, anaplastic, red altered, and agnostic, have clinical trials underway to try and get us some better information. I've ended with some, I think, really quite remarkable information on the resumption of vocal cord function in some patients treated with neoadjuvant therapy. With that, I want to thank you again and extend some kind invitations. Education here at Harvard, we have a surgery of the thyroid and parathyroid glands, the QR code for registration. This is in November of this coming year. It's a course that we've given for the first time in 1996 and have given it every year or two since. It's quite a remarkable course. I'd welcome you all to attend. I also want to emphasize the World Congress on Thyroid Cancer. This was given most recently June in London. We had 1,000 attendees from 74 different countries, and we have a new version of the World Congress, which will be held in July 9th to the 12th, 2025 in Boston. Here's the QR code for registration and information about that large world-class Congress. It's quite global, this meeting, and quite multidisciplinary. And so I think you will enjoy that. Certainly consider joining us in Boston. And we also have a World Congress Academy that you can look into through that website as well. I want to thank you again for your attention. And I wish you a very pleasant Congress. Again, I apologize, I can't be there in person, but I know the meeting will be outstanding, and I thank you for your attention. Thank you.
I would request Madan Kapre sir for his comments.
Madan?
You are, sir, you are muted.
Yeah, okay. Well, thank you very much. It was an excellent Congress so far. I enjoyed both the talks, and I also enjoyed the comments made both by Pankaj and Jyoti on the earlier session. As regards to Gregory Randall, I always get amazed how seamlessly he moves from the basics of parathyroid and thyroid and recurrent nerve to the molecular markers into now new adjuvant therapy. Amazing to see the results of lenvatinib, particularly downgrading the recurrent laryngeal nerve paralysis, and probably something for future for us, may not be near future. In our setup, I'm very pleased to say that Abhishek is doing quite a lot of work on lenvatinib, and maybe I will request him to please get in touch with Greg and maybe also have some inputs into him from our center. I also congratulate Jyoti taking this opportunity for make the dream come true for me, because when we first formed the ISTS, the whole objective of ISTS in the years when we formed it was to raise the standard of care at the bar of academics where it matters and bring some discipline and uniformity to the treatment of thyroid cancer. And how well Jyoti and her team has done it. It is almost brings tears to my eyes when I see her work done, because it's a dream fulfilled. So thank you very much, Jyoti, for making an old man happy. With this, I think the lenvatinib or the other new adjuvant session done by Greg was phenomenal, and probably we'll see more of this Lazarus effect being used by us in India, because we have centers where we can do lenvatinib trials on advanced thyroid cancers. Over to Ashok in case he has some comments to make.
So my comment was that only, that, we couldn't include the molecular markers in the guidelines in the section that whether it helps in diagnosing or not. To diagnose a cancer, you don't need a molecular marker, because there's a very small spectrum of group of thyroid cancer where you are in a dilemma. And a well-trained doctor can definitely do a HEMI, get the diagnosis, and may do a completion. Or even Niti's paper, prospect trial, when that gets out, probably the nanograms will tell us that yes, the probability of the cancer is this much, so you do a total. So I'm just telling that to diagnose a cancer, I don't think we need molecular markers. But we need a molecular markers for two reasons. One is the anaplastic and undifferentiated. We just heard the lecture. And the another one is the locally advanced differentiated thyroid cancer, which which are going to behave badly. And whether we can do something by giving them the newer adjuvant chemo and then operate, and then bring down the complication, better cure rate, and better reduce mortality and morbidity. So my request to you, the younger generation, is that please take up these studies. This is not difficult. The drugs are available in India. And I think that like doing a multi-centric trial, you will incur the patients faster, recruit the patient faster and get out with the results. Don't be behind the world in all this. And it is possible. The younger generation is fantastic and it is possible. I think it is just that it requires a little bit of a push and you should do it. All the youngsters should do it.
I think Ashok is on the line. I can.
Yeah, I've been watching you. I just landed into Bangalore. And thank you, Madan. And great work, Jyoti. I really enjoyed. I could hear Dr. Shah's lecture. And I think precision surgery was awesome. I mean, listening to him again and again, we are seeing multidimensional aspects of the disease being unveiled. And of course, to quote him, I feel that all this is work in progress, as he said. And certainly India can probably participate in some of the trials with respect to anaplastic thyroid cancers. I think the issue is to just identify those with good genetic markers, and maybe this should be standardized.
Now, my next push is on molecular markers.
Yeah,
we
absolutely.
have to do it. Like we have guidelines now. We have to do this, and we have to put up our data. I don't know when you joined, but this session is going on from 1:30 onwards. I had an introductory lecture, and then there were 5 lectures. Believe me, Ashok and Madan, the way the whole session went was so amazing.
No, we are watching.
We are watching.
And it was fantastic. I mean, I feel that this was something great that we could just do it in a day, and
No, of course, this is Pankaj and Asim. They have done a great job.
And all the thanks to
all the thanks to
Asim
and Pankaj for last night's their case discussion, and wonderful, very nice.
Yeah. Asim, I take this opportunity to thank you from the bottom of my heart. You are immaculate planning and everything, and I think it is amazing. Please continue the same in other aspects of head and neck also. You are a great teacher and you should contribute, because Madan and you will agree that both of us are teachers' children, and I personally feel that we are both so passionate about teaching. And when I see somebody taking so much of interest in teaching, my heart really, really goes out with that person. So please continue teaching, continue organizing. Any help you need from us, we are always there, a phone call away, and God bless you.
I think I must echo Jyoti's sentiments exactly. Asim and of course our friend Pankaj, I think they have put together a wonderful program, of course, with guidance of the ISTS president. Thank you, Jyoti, for putting together this program. I was in from Archie's time, I just landed.
Late. You joined late. Because,
I joined. I was flying.
I know you had just reached Bangalore. So we started at about 1:30. 2 lectures of the guidelines on a risk stratification and the medullary were covered singly day before yesterday and otherwise. And the remaining all chapters today. So it was fantastic. All the chapters, I'm been part of it. So I'm enjoying the way the whole thing is going. I mean, it was amazing. And I already also said that we have already started working on the lacunae of this guideline. There are 2 lacunae, and I can tell you that 15 to 20% of that is also being done. So probably in a year's time, we will revise these guidelines also.
Okay. Wish you all the best, Jyoti. Keep it up.
Yeah.
You've done a great job.
And have a great Holi, great celebration, days, family time. Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, Asim.
Thank you, everyone, for joining.
Asim, you should go Asim, you should go and have a thandai with bhang.
Where is Professor? I can't see him.
Which Professor?
Pankaj, are you still there?
He just left half an hour.
Pankaj, gaya.
Anyway, he is also doing a great job. So my greetings to both Asim, Pankaj, and the whole team. Have a good Holi.
Thank
you, sir, and wish you all a very happy Holi.
Thank
And
you very
I
much.
could all pull together because of my wonderful team that we have here with Komal and Sunaina and all the team of residents that we have and all the guidance from the IFNOS and the ISTS. Thank you, Jyoti ma'am, and thank you, Pankaj sir. And thanks a lot, Madan sir, for giving this opportunity as well. Thank you everyone for joining.
Thank you.
Thanks, Madan. Bye.
Bye-bye. Bye, Ashok.